I do. Yeah, it is formatted nicely. Nothing's moving. Neither one of these is moving.
You were clicking.
I clicked backwards.
I see. You're looking at this one. Okay.
So
I had to take a different one live. You got a different deck live. Let me switch it over. I'm gonna bring you back to the front. Give me a thumbs up when you want me to send it to the screen. Okay.
yeah, now actually.
Okay.
So. Okay. Well, good morning. I still can't advance these, but I can talk. So, welcome to our 9th advanced curriculum for multiple sclerosis, 2024. We're delighted to have you all here. Special welcome to the residents who are here for the Actrum's Residents Forum. And still not clicking. There we go. Okay, so I have a couple things I want to do as baseline stuff. First off, when I tell you about questions, please keep in mind that there's lights there that are right in our eyes. So when you raise your hand, wave it like you were back in elementary school and you knew the answer to the question. Any event, okay, here's the introductory stuff. So this is a CME and CE activity. It's supported by independent educational grants from Bristol Myers Squibb, EMD Serono, Mylan Specialty, Viatris Company, Sandoz, Sanofi, and TG Therapeutics. And we're very grateful for that support. And it's been organized by the good folks at Academic CME, Tim Hayes, Patrick Hayes, Chelsea, and Nicole, who will be in the back and help you with anything you need. We have a great agenda and a spectacular faculty, and I think that you'll agree with me at the end of the day that that's the case. We've crammed a lot in because we've had to do the course all in one day, and so it'll be very intensive, but it really will be an MS 101, 202 for you. There is a pretest, which is part of the CME part, so if you haven't completed it, please visit this code, or you can put it online. Do I need to leave that up? Is it photographable? And this is a different code than for questions, is that right, guys? Yes, okay. And then questions, and this is key. So in addition to waving your hands around and asking a question, which we very much encourage because we've tried to leave time and panel discussions, you also can send questions through this QR code, and it's on your tables as well. And that comes into a little iPad that I will have, and I will triage those questions to the faculty. So it's important to us that we get to your questions, and we do our best to get to them all. This is the accreditation for the CME. Faculty disclosures, they're available online as well. And this is how you get your CME, another QR code. And the academic CME people can make this all available to you separately. And you can get your CME certificate. So that's the important things. One other important thing, if you're interested in restrooms, they're down a long corridor, straight back from here, and then there's an unmarked door, I kid you not, with a little sign in front of it that says restrooms. So just so you know, straight back. Okay, I think that's everything I need to say in terms of introductory remarks. We're going to get started. Our first talk today will be by Joe Berger from the University of Pennsylvania on the core principles of diagnosis, lessons learned. So, Joe, welcome.
Is there a timer, Fred?
Just watch my face.
Put up your hand. Great. Good morning, everybody. I'm delighted to be here. And we should get started because it really is indeed jam-packed. So to begin with, what I thought I'd do is tell you about the concept of framing a disease. You know, we don't really recognize diseases until they are identified to be a disease. And that was true of multiple sclerosis. It's been around for a long time. There are historical cases of multiple sclerosis, but they weren't identified as multiple sclerosis until the mid-19th century. And Charles Rosenberg is the person who put this concept of framing disease into practice. He said, in some ways, disease do not exist until we've agreed that they do by perceiving, naming, and responding to them. So in the mid-19th century, MS gets defined by Cruikshank and Cruvaillier and Charcot. And how did Charcot say what did you need to make a diagnosis? He said, well, you should have scanning speech and intention tremor and nystagmus. Listen, if that's what you were relying on to make a diagnosis of multiple sclerosis, you wouldn't be making the diagnosis very often in patients with this disease. That was modified somewhat by Otto Marburg, a German physician, who said, oh, you should have Uthoff sign. I don't know how many people even ask about Uthoff sign, but we often do. Temporal disc pallor, absent abdominal reflexes. I think I'm the only one in my department that checks for that, and pyramidal signs. And then it got further refined, and the concept of progressive disease was identified by Miller and others. And then there was a proposal by Douglas McAlpine in 1957 that got revised in 1965. But the real classification, the real criteria came about in 1961 when Shoemaker, as part of a NIH panel, put together a list of criteria, which included having objective abnormalities on examination, involvement of 2 or more areas of the central nervous system, having predominantly white matter disease, having 2 or more episodes of worsening separated by greater than 1 month and lasting at least 24 hours, being between the ages of 10 and 50, and having no better explanation for the disease. And when I went to medical school and Fred went to medical school, those were the criteria that we largely used in establishing the diagnosis of MS. They were since subsequently refined, and Poser included some paraclinical evidence for the disease. And then in 2001, international criteria were established by McDonald, and that's been revised repeatedly through this year. And I do not have the criteria for this year, by the way, the most recent. Fred said, don't say anything about it. I must say that I'm ignorant of what they are. But I do think that they will probably marginally increase the sensitivity maybe the specificity of establishing the diagnosis. So the most recent criteria, the ones that we use, are the McDonald 2017 criteria. They incorporate clinical evaluation with the MRI. As in prior diagnostic criteria, you have to have both dissemination in space and dissemination in time, evidence for both. And unlike the very earliest criteria, as of 2010, the possibility was raised that you can make the diagnosis after a single attack. You didn't have to have a second attack in order to establish the diagnosis. You do not need an MRI to make the diagnosis. You could be in the deepest parts of sub-Saharan Africa and make a diagnosis of multiple sclerosis. So as you see on this slide, if you have 2 or more clinical attacks and 2 or more clinically documented lesions, then you don't really need an MRI or laboratory studies in order to establish the diagnosis. And then if you don't have that, if you have only 2 clinical attacks but can only document 1 clinical lesion, then you have to have evidence for dissemination in space demonstrated by an additional clinical attack. So it requires some patience, and we'll talk about that in a second, that implicates a different area of the central nervous system, or you have to have MRI evidence of disease that indicates that there's dissemination in space. If you've only had 1 clinical attack, then you need dissemination in time. And the way that you identify dissemination in time is when you have another clinical attack, obviously, or alternatively by MRI, or as of the last revision of the McDonald criteria, the presence of oligoclonal bands in the spinal fluid. So oligoclonal bands will qualify as dissemination in time. So these are the criteria that we currently employ. As I said, as of 2024, sometime this year, the new criteria will be established. I'm going to tell you my own personal belief. I think that it'll probably marginally improve both sensitivity and specificity, but we're never going to get to 100% with either until we really have a good understanding of the pathogenesis of MS and probably have some very highly defined tests that helps us there. We're always going to make mistakes, and I'm going to show you how frequently we make mistakes in a second. So how did the 2010 criteria differ from the 2017 criteria? You see it in red here. So with respect to dissemination in space, for the 2017 criteria, this can be demonstrated by greater than 1 T2 lesion in at least 2 of the 4 areas of the central nervous system. So in 2010, it was periventricular, juxtacortical, infratentorial, and spinal cord. Cortical was added to it in 2017. And then you could have either symptomatic and asymptomatic lesions counted, regardless of their location. And then in terms of dissemination in time, how did the criteria change in that 7-year interval? Well, it changed in the following way. So what they did was add in patients with typical CIS, clinically isolated syndrome, meeting disseminated criteria by clinical and MRI criteria and no better explanation, presence of oligoclonal bands can substitute for dissemination in time. So the oligoclonal bands were added to the dissemination in time. So this is the 2017 diagnostic algorithm. If I stand before you next year and tell you something different, it's only because the criteria have changed somewhat. So if you have CIS and an MRI at any time with both dissemination in space and dissemination in time, you can make the diagnosis of multiple sclerosis. Of course, it's important that you've considered alternative possibilities, right? I mean, there are other diseases that are both disseminated in space and time, so you've got to rule those out. You could have CIS and an MRI at any time with dissemination in space, but not dissemination in time. If that's what you have, you then have to wait for a second event, which could be a clinical event or something that you see on the MRI that's new, that gives you dissemination in time. Or if you need dissemination in time, you could also use the CSF oligoclonal bands. And then lastly, if you don't have dissemination in space, you have to have a second event or a new MRI that shows dissemination in space and time. In terms of PPMS criteria, the 2017 criteria are at the bottom of the slide, and what they are is as follows. You have to have 1 year of progressive clinical disease and at least 2 of the following criteria. Greater than 1 T2 hyperintense lesion in a cranial area, and now cortical's been added to it. Greater than 2 T2 hyperintense lesions in the spinal area with brainstem and spinal cord symptomatic lesions, or CSF oligoclonal bands. So you need 2 of those 3 criteria in order to feel comfortable that you've established the diagnosis using McDonald criteria. So there are certain features that are typical for MS, some that are less common, and some that should raise red flags for you. This comes from a paper by Miller, published in 2008 in multiple sclerosis, which Fred always highly recommends at another course that we talk at. So, it's quite common to see unilateral optic neuritis, pain on eye movement, partial and mainly central visual blurring, and normal disc or mild disc swelling in people that have multiple sclerosis. It's less common to see bilateral simultaneous optic neuritis, no pain, no light perception, so very bad optic neuritis, moderate to severe disc swelling with no hemorrhage, and uveitis. Although we see uveitis, we see all of those things with MS. It's just that they're less commonly observed. Where you really should be concerned is when you have progressive optic neuropathy, where it gradually gets worse. Now, I will tell you, I've had a couple patients in the last years at the University of Pennsylvania who've had progressive optic nerve disease as a consequence of primary progressive MS, and that's been their only or their predominant clinical feature. So it is observed, but it's pretty unusual. Severe continuous orbital pain, persistent complete loss of vision, neuroretinitis, and severe anterior uveitis all should be red flags for you. With respect to the hemispheric syndromes or symptoms that one sees, it's not uncommon to see mild cognitive problems. People often complain of them. Hemiparesis is also frequently seen, but epilepsy, okay. Does that occur with MS? Of course it occurs with MS. We do see seizures from MS, but it's less common as are hemianopsias. We see it, but it's unusual. And it should start you thinking maybe there's something else going on. But encephalopathy, rare. Again, I've seen that, and I've also seen cortical blindness with MS. So they're atypical, not often seen, but doesn't mean that it's not MS. Brainstem and cerebellar symptoms. So what do we typically see with respect to brainstem symptoms? Bilateral internuclear ophthalmoplegia, ataxia and multidirectional nystagmus, 6 nerve palsies, and facial numbness, all commonly observed. Less commonly, unilateral internuclear ophthalmoplegias, facial palsies, facial myokymia, deafness, 1.5 syndrome, trigeminal neuralgia, paroxysmal pain, painful tonic spasms. Atypically would be a complete external ophthalmoplegia and vertical gaze palsies. They're unusual. Not that we don't see it, but unusual. Vascular territory syndrome, so a lateral medullary syndrome. Somebody who comes in with a Wallenberg, not likely to be due to MS, but occasionally can. Third nerve palsies, progressive trigeminal sensory neuropathy, focal dystonias, and torticollis, not likely to be due to MS. With respect to the myelopathies, it's common to see partial myelopathy, to have Lermite's phenomenon, to have a deafferented hand, numbness, urinary urgency, incontinence, erectile dysfunction, all quite common. Progressive spastic paraplegia, less common to see a complete transverse myelitis. We see it, but you should start thinking, maybe it's something else, like neuromyelitis optica or neuromyelitis optica spectrum disorder. A radiculopathy and areflexia, partial Brown-Séquard, fecal incontinence, and progressive spastic paraparesis. Of course, we do see that particularly in progressive disease, but it's unusual for it to be symmetric. So if it's symmetric, start thinking it may be something else. And atypically would be anterior spinal artery lesions, Caudy-Quiney syndrome, sharp sensory levels to all modalities and localized sharp pain, complete Brown-Séquard, an acute urinary retention, and progressive sensory ataxia. It turns out we've gotten better over time, and I don't know what the latest figures would show, but this is a paper that came out in 2005 that showed the speed with which we diagnose multiple sclerosis. I will tell you, I've been practicing medicine, believe it or not, 50 years. I graduated medical school 50 years ago. And I remember being very reluctant to tell people they had multiple sclerosis, even when I knew they had the diagnosis, because there was nothing to do for them. So it was vested with lamentable results when they heard the diagnosis. But as treatments improved and as our diagnostic measures have improved, we've diagnosed the disease with greater rapidity. And this comes from the North American Research Committee on MS, their registry. And what they demonstrated was that it sometimes took years. Now, it's not like the physician didn't know the diagnosis. He may very well have known, or she, known the diagnosis, just was reluctant to put it in the chart or tell the patient. But you can see that between 1980 and 1984, which is the part of that curve that, oops, sorry. I don't know if I can, not sure how to do this. Well, in any event, it's that part way over to the right of the curve, as opposed to 2000 to 2004, where they've shortened the diagnosis very considerably. So, and they claim that the false negative attribution to MS was rare. How often do we miss the diagnosis of MS? Well, the best estimates are that even today, that misdiagnosis rate is 5 to 10%. And as MS-trained individuals, you still make mistakes. And I'll show you some data on that. So this comes from a variety of clinical series at MS centers where the rates varied between 13 and 33%. So in one series, there were 52 of 400 patients referred to an MS specialty clinic that turned out not to have MS, where the commonest misdiagnosis was really psychiatric disease. And that actually is fairly common, where people have psychiatric problems misdiagnosed as MS with a variety of complaints and nonspecific MRI findings. In a pathologic series, what they found in 518 autopsies between 1965 and 1986, the diagnosis was incorrect in 33%. So a third of the patients did not have MS when they looked at their brains. Now, recall that this was in the day, some of these cases were in the days before CT scans being introduced in the early 70s. And CT scans are not all that helpful, in my opinion, in diagnosing multiple sclerosis. And certainly, MRIs were not widely used in this particular series. They found brain tumors in 9 patients and had 19 different diagnoses in 24 others. This is a nice study done by Andy Solomon where they looked at 4 academic centers, the University of Vermont, I guess that's Oregon, WashU, and the Mayo Clinic, and they looked at 110 patients that had been incorrectly diagnosed. It turned out that of those people, who did they see? 24% of them saw a neurologist with MS fellowships. So you're not immune to misdiagnosing people, even with an MS fellowship. And 32% were general neurologists. The rest were individuals that were not necessarily neurologists. The duration of misdiagnosis varied between 1 and 20 years, and the cumulative exposure to immunomodulatory medication varied between 1 and 20 years. So there's a real concern here. When you miss the diagnosis, there are a couple things that one worries about. One is you're not treating the underlying illness that the patient has, which could be debilitating. The second is that you're exposing them to medication that they really don't need, and perhaps a lifetime of medication. What they found among these 110 patients is that the most common abnormalities they saw were migraines in 22%, so probably migraine equivalents with nonspecific MRI findings, fibromyalgia in 15%, conversion disorders in 11%, neuromyelitis optica spectrum disorders in 8%. Now, I will say that the frequency with which we miss NMO and NMOSD has probably declined very considerably now that we almost routinely get aquaporin 4 antibody and MOG antibody tests. MS remains a clinical diagnosis. There is no specific test you're going to do where you say, that's multiple sclerosis. We just don't have it. So as a consequence of that, I think we're going to continue to make these mistakes. Overdiagnosis of MS is the most common diagnostic error that we make, calling somebody MS who does not have MS, and it's generally due to an uncritical reliance on the MRI and a hasty workup. You know, you get fixed. You say, oh, that sounds like MS. You see an MRI with a bunch of white matter lesions. You say, that's got to be MS. So be careful. What's the importance of detecting MS mimics? Treating an MS mimic appropriately may avoid significant morbidity or mortality that may occur in the absence of appropriate treatment. Minimizing the overdiagnosis of multiple sclerosis decreases or eliminates the potentially pernicious impact on the patient's psyche, social situation, employment, and finances. I mean, how many times do people with MS start worrying about their marriages, their jobs, et cetera? It avoids the side effects of platform therapies, such as the flu-like symptoms and skin reactions, although we rarely use these drugs anymore, and it avoids serious morbidity and mortality associated with some of the other disease-modifying therapies we use. And it also avoids the costly medications and expensive laboratory and radiographic monitoring, which I didn't include. Why do we make a wrong diagnosis? So I'm going to recommend two sources of information for you. One is a book by Jerry Groupman. Some of you may know Jerry. I think he's retired now. He's an oncologist in Boston who was very much involved in HIV treatment. And he wrote a book called How Doctors Think. I highly recommend it. And then Barbara Vickery, Alan Roper, and Marty Samuels would run a series every year at the American Neurologic Association meeting, which they rolled into a paper in 2010. Sorry about that. In 2010, in which they talk about why they made the wrong diagnosis in patients. And some of these things come from the work of the behavioral economics professors, Amos Tversky and Daniel Kahneman. Kahneman won the Nobel Prize for the work. Tversky was dead. Things like diagnosis momentum. You think of a diagnosis, you love the diagnosis, comes fixed in your mind, and you don't go any further. Framing effects, where somebody tells you something, you know, I have a Lhermitte's phenomenon, or, you know, I get worse when it's hot outside. You go, oh, that must be multiple sclerosis. So it frames the illness, and you start thinking, oh, that's what it must be. The satisfaction of search, where you find something, you say, this makes sense, I'm happy with it. So I won't go through all of these in the interest of time, but I do recommend that you read them. We're all subject to these ways of thinking. Now, this list of differential diagnoses comes from a paper that a former resident, now faculty member at the University of Texas, wrote with me a number of years ago, where we looked at what was in the literature and so, what are the differential diagnoses one needs to consider? There are the inflammatory and autoimmune diagnoses, things like neuromyelitis optica, ADEM, sarcoid, systemic lupus. I'm sure you all think of those things. There are vascular events that one need to consider, particularly the migraine variants. I told you that was the most common of the misdiagnoses in the series by Solomon. Neoplastic disease, and we see this from time to time. And I'm going to show you some cases, if time permits, where all of these or some of these are illustrated. Infectious diseases like Lyme and syphilis and HIV that can present with features similar to multiple sclerosis. Mitochondrial disorders, metabolic disorders, mechanical problems, cervical spondylotic myelopathy, miscellaneous disorders like environmental toxins, PRESS, CPM, all can have features that might be mistaken for MS or an MS-like illness, ophthalmologic disorders, and of course psychiatric disorders. So the list is very large. This is not fully inclusive. I will tell you that over the course of my years practicing medicine, I collected these cases, many of them, and I put them into PowerPoints, and I use them for teaching purposes, where there's been a misdiagnosis. Why did we make the wrong diagnosis? How would we have been thinking otherwise? And some of them are ones that I misdiagnosed. I thought that's what it was until the patient came back and told me something else that made me think differently. So always question yourself, by the way. I will tell you, not infrequently, a patient will come in, I haven't seen him in a while, and they look great, and I'm thinking, and they have MS, and I'm saying, well, who the hell made the diagnosis of MS in you? And they go, you did, Dr. Berger, 10 years ago, and I go back and look at the chart, and I say, oh yeah, I did make the diagnosis. And, and I put in why I made that diagnosis, what was the evidence for it, and I say, oh yeah, you have multiple sclerosis. But sometimes, you even question yourself if you've forgotten about the patient. I like this expression, a handful of patients is worth more than a barrel full of brains. Sometimes a patient comes to your office and you say, you know what, at this point in time, I just can't tell you what the hell you have. I don't know. Come back and see me in 6 months. Or if something comes up, come back sooner. Don't be afraid to tell patients you don't know, because sometimes you really don't know and you don't want to go down the wrong path. John Whitaker, a famous MS doctor, chair at UAB before he died, said it takes a good doctor to make the diagnosis of MS. It takes a great doctor to not make the diagnosis of multiple sclerosis. And I think that's worth citing. Here are the dictums for diagnosing MS. Uncommon manifestations of common disorders are far more common than common manifestations of uncommon disorders. So keep that in the back of your mind. MS is a common disease. So it's more likely than not, you're going to see MS rather than something else. Remain open-minded and question your diagnosis, particularly when there are atypical features of the disease. MS can manifest in a wide variety of fashions, but so do its mimickers. MS remains a clinical diagnosis. Careful history, physical examination, and ancillary studies are fundamental to diagnosing multiple sclerosis. Really, the history is incredibly important, and do a comprehensive neurologic examination. Take the shoes off, residents out there, take the shoes off the patient, when you examine their feet, and do a Babinski. A careful and comprehensive review of systems and general physical examination, rather than ancillary studies, may correctly suggest an MS mimicker. So doing a general physical examination is often quite rewarding, and I'm going to show you some cases where that's the case. And these features may suggest an alternate diagnosis. And avoid an over-reliance on MRI interpretations. And I'm going to conclude with this statement from Charcot, who said, in the last analysis, of course he said it in French, we see only what we are ready to see, what we have been taught to see. We eliminate and ignore everything that is not part of our prejudices. And I'll leave it at that. I think the questions are later. Thank you very much.
Okay, thank you, Joe. Next up will be Dr. Patricia Coyle, who's going to discuss biomarkers, fluid, and imaging. Welcome, Pat. And please, put in your questions.
Well, Joe really set up my talk because he emphasized the importance of getting better diagnostic biomarkers, and that's what I'm going to be talking about in the next 15 minutes, with a background, discuss fluid biomarkers, imaging biomarkers, and then summarize. So there are different types of biomarkers. We're going to focus on diagnostic biomarkers. There are different sources. Spinal fluid has been very valuable, but it's not as handy as blood. You would always prefer a blood source to a CSF source. And in imaging, we're going to look at brain, spinal cord, and retina, optic nerve. Now, biomarkers can be different substances, proteins, peptides, various omics. Even a gut microbiome can be considered a biomarker. Are you going to sample at a single time point or multiple? For a diagnostic biomarker, it would be a single time point. And then you need to consider other factors like the assay. What is the sensitivity and specificity? Do you have a single assay or multiple? Multiple clouds the picture because you have to standardize it, and you really can't cross assays. You're going to have to pick one and stick with that one. What's the control data for your biomarker? What's the impact of host factors like aging? Does it go up with aging? Then you've got to correct for that, or BMI, or comorbid conditions. What's the ease and time? What's the accessibility? You could have a great biomarker. If it was super expensive and nobody was paying for it, it wouldn't be used very well. So all of these are very important factors. Now, molecular biomarkers are very intriguing. These are making breakthroughs. Single-cell RNA sequencing allows you to look at the genes changed in a single cell or very small populations. So you can actually look at that. You can explore cells in blood, spinal fluid, and even CNS tissue and look at very low-frequency populations that may be key. For example, single-cell RNA-seq was a way to identify pathogenic astrocyte subsets in MS. And multi-omics, you should be familiar with omics. This includes genomics, epigenomics, transcriptomics, proteomics for peptides and proteins, metabolomics, metabolic factors, and lipidomics. And you can identify patterns, and you might have a diagnostic biomarker pattern. And then the microbiome, there's a lot of talk about epsilon toxin from Clostridia perfringens. This is part of a hypothesis that MS is due to sheep. MS is due to a sheep pathogen that passed to humans. And if you mark MS, you'll see it goes where sheep go and where sheep herders go. I think it's a little bit preposterous, but very smart people are putting this forward, and Clostridium perfringens is the sheep pathogen that they're saying may be producing MS. So let's move on to fluid biomarkers. And I want to give a shout out to CSF oligoclonal bands, and we'll mention kappa-free light chain index. And then this is not a diagnostic biomarker, but it's the most popular biomarker spoken about: neurofilament light chain, NFL, gliofibrillary acidic protein, GFAP, and chitinase 3-like 1, and I'll briefly mention them. Okay, oligoclonal bands, great, independent of MRI. You need CSF and serum. You can do it unconcentrated. You have an endorsed sensitive assay. It becomes more common over time, 80% initially, 95% plus later, independent of MRI scan. Very, very helpful. We do it routinely currently because we don't have an all-inclusive diagnostic biomarker for MS, and that's a big, big gap. That's a big lack. In a recent machine learning study, those MS patients who were oligoclonal band positive versus those that were oligoclonal band negative had immune activation CSF markers in the oligoclonal band positive, so that was going along with being oligoclonal band positive. What's going to happen with kappa-free light chain index, and maybe we can probe Fred to hear about, did the diagnostic criteria mention it? Kappa-free light chains were looked at years ago, and then they kind of dropped off the map, and you didn't hear them mentioned, and now they're making a comeback. They're elevated in the CSF of MS. You do a paired sample, just like for oligoclonal bands. You have fully automated techniques to measure them. They're not specific to MS, and the oligoclonal bands are not specific either, but MS is the most common major disorder that causes it. And they have similar positivity rates to CSF oligoclonal bands. And in one recent study, it looked like they were better predicting outcome than CSF oligoclonal bands. So are we going to be using kappa-free light chain index? Will it replace oligoclonal bands? Stay tuned. We don't have the answer to that yet. NFL, let me mention this. This is not going to be a diagnostic biomarker for MS, but it may be a very important biomarker for MS. This is looking at axonal and neuronal injury in the CNS and the PNS. You can get increased NFL from the PNS. It's elevated in many diseases, not just MS, of course. But this was a breakthrough when you could measure ultra-low levels in the blood compared to the spinal fluid, a breakthrough. And you can use that platform to look at ultra-low levels in the blood. There are multiple assays, at least 6 here. That's a problem. That's a problem. Wouldn't we like to have one assay that we all agreed on, because you have to standardize every single assay. And if you commit to one, you can't cross over to the others. And there are so many things that influence neurofilament light protein, so many things that influence it. Aging, probably BMI, comorbid conditions. You need to correct for that. You need to correct for all of those things. There's a recent consensus paper from the CMSC that noted that EDTA plasma had about a 23% lower level of neurofilament light than serum. So it's going to differ if you're using serum versus plasma. So that's something to think about. If you're using a blood biomarker, is it serum you're going to use? Is it plasma you're going to use? You have to think about that. They indicated that you had to define a normal range, but they suggested that greater than 22 picograms per ml or greater than 30% increase was likely significant, and you had good stability. They suggested maybe sampling every 3 to 6 months NFL, and it seemed to go along more with acute focal inflammation than smoldering inflammation, and you could see it up for 2 to 3 months after an acute attack. Well, there are interesting studies with NFL. Blood NFL is being touted as a prognostic biomarker, disease activity biomarker, and treatment response biomarker, not a diagnostic. Forget about that. In certain assays, they really say you need to use a z-score or percentile correcting for factors. That's better than doing a quantitative assay results. So that really needs to be worked out for each assay. And it currently appears to be more useful in relapsing than progressive MS. That on the face of it is surprising, because your prototype progressive MS is neurodegeneration, injury to axons, but this seems to be more focal inflammatory drives it up, the relapsing component, and it needs to be standardized across labs and platforms. This is 2 observational studies, Epic and the Swiss MS cohort, that looked at NFL levels and confirmed disability worsening longitudinally, and they found something interesting. This needs to be confirmed, but it was interesting. Serum NFL went up a year before relapse-associated worsening. Serum NFL went up 1 to 2 years before relapse-independent worsening progression. Isn't that interesting? Could it possibly be a segue marker for the future in the next 1 to 2 years of our MS patients? Obviously, that needs to be confirmed. GFAP. Right now, we have a test for mild TBI, point-of-care test, gives you an answer in 15 to 20 minutes on GFAP levels in the blood, along with a second component. This is from astrocytes. It's an intermediate filament. Clearly doesn't have the background of NFL yet. Clearly doesn't have the background, but it's looking very interesting from central and some peripheral sources, can contribute to GFAP, and you can measure the ultra-low levels in blood. So there are definite changes in GFAP levels increased in MS versus healthy controls and non-inflammatory diseases, and it correlates with disability parameters as well. And it's not NFL. It's somewhat different. You don't see the same correlations. In a recent study of RIS, radiologically isolated syndrome, blood GFAP but not blood NFL correlated with various outcomes, so they really gave a different pattern. And the current analysis suggests that GFAP plus NFL analysis may be more helpful in MS than either alone. Chitinase 3-like 1, this is mentioned more in Europe than here. This is a secreted glycoprotein from macrophages, astrocytes, and activated microglia. It's increased in inflammatory processes. It's not unique to MS. It's not going to be a diagnostic biomarker. There are interesting correlations. The biggest problem so far is it's unreliable in blood, and I think that's going to kill it. I'm not sure what's going to happen. If they can't figure it out in blood, then I'm not sure how meaningful it's going to be. Let's move to imaging biomarkers. And I want to talk about the central vein sign diagnostically, cortical lesions diagnostically, and chronic active lesions, which include slowly expanding lesions, cells, and paramagnetic/phase rim lesions, pearls, cells and pearls, chronic active lesions. Okay, the central vein sign. We do have a misdiagnosis rate. It's embarrassing. Many things cause lesions on the brain MRI. Many things cause white matter lesions in the brain. It turns out most of the lesions from MS are around small venules, small veins, that you can detect using susceptibility-weighted imaging. And it seems to be a 40% break. MS lesions in the brain greater than 40% show a central vein sign, and other diseases do not. So your optimized techniques like echoplanar imaging, high-resolution T2 star, you can do this on a 3T. You don't need a 7T. You can do it on a 3T, and it's being tested. It's being tested to see if it's going to be able to fit in neatly into current clinical imaging without upsetting the apple cart. This would be extremely helpful from a diagnostic point of view, and you can see that tremendous break there, the 40% break. Greater than 40% of lesions in MS have a central vein, and way less than that in other diseases. What about cortical lesions? Turns out cortical lesions are common in MS and uncommon in other diseases. It's not 100%, 0%, okay? Nothing in life is. Very few things in life are. You can increase detection using 3D double inversion recovery, phase-sensitive inversion recovery, MP-RAGE, MP2 RAGE. There's differences between cortical lesions and white matter lesions. They're not as inflammatory. They have a more limited blood-brain barrier breakdown. So what was the diagnostic performance of central vein sign and cortical lesions? This is a retrospective cross-sectional Magnum study that had about 600 MS-CIS patients and 450 controls. And they looked at the 40% rule for central vein and cortical lesions, yes or no. And the MS sensitivity, specificity, and accuracy was better for the central vein sign. But if you combine both, you did better accuracy than either one alone. And the combination outperformed infratentorial, periventricular, and juxtacortical lesions. So this could be meaningful from a diagnostic point of view in the future. Chronic active lesions. We have a NAMES consensus statement on chronic active lesions. These are white matter lesions that have an inactive center. They do not enhance, but they have an active rim of microglia and macrophages that may or may not have phagocytized iron. That determines whether they're cells or pearls. And these seem to occur in brain white matter, cortex, and spinal cord, and seem to represent chronic smoldering inflammation. So they predominate in MS, are more common in progressive MS, but you can clearly see them in earlier MS as well, and they predict disease activity, severity, et cetera. So do they last forever? No. It turns out pearls, for example, slowly increase in size for a couple of years, then they stabilize, then they reduce, and they're over with. So you only have a couple of years of these chronic active lesions, apparently. And they seem to represent multiple glial phenotypes that people are attempting to study, the smoldering inflammation, intra-CNS, perhaps driving neurodegeneration. You can pick these lesions up. It was originally on 7T. You can pick them up on 3T as well. You can pick them up on PET if you're doing TSPO, looking at activated microglia, and that's very important. And in a recent study, we're going to be hearing about BTK inhibitors this afternoon. In a recent study, there was a dose-dependent decrease in cell volume with the BTK inhibitor, suggesting it was hitting this measure of smoldering inflammation. I'm sure that'll be mentioned this afternoon. There's a recent study of juxtacortical pearls, which could be visualized on 3T. In a small-scale study, 10% of MS individual had juxtacortical pearls, and you could really visualize them as well on the 3T, and they had a small post-mortem, 5 brains, where it seemed to correlate with focal cortical demyelinization above the spot where you had the juxtacortical pearl lesion. So they were suggesting that juxtacortical pearls are biomarkers for focal cortical demyelinization, which seems to be relatively unique to MS. The evolution of pearls. This was a small-scale study, 23 patients, on 7T at baseline and in 3 and 6 months. They looked at those that had enhancing lesions at baseline and how many became pearls at 6 months. 37 of 93 became pearls at 6 months. They had changes in T1 relaxation time, and T1 volume was higher. And you could see differences between those destined to become pearls on 3T MRI scan as well. So they touted this as the ability to identify a future pearl and maybe be able to track them before they even became pearls. So again, that has to be substantiated in other studies, but is interesting. And here's a pearl study, a cross-sectional study of 412 subjects, 329 MS, 83 other neurologic diseases on 3T MRI scan. So 52% of MS had pearls, 7% of non-MS had pearls. So it's not 100%, 0%. Other diseases can have pearls, but they're highly associated with MS. Those that had 4 or more pearls had greater disability, higher use of high-efficacy disease-modifying therapy. And what were the non-MS individuals that had pearls? Susak syndrome. 3 of 5 had pearls within the corpus callosum. In addition, there was 1 NMO spectrum disorder that had a pearl, 1 Sjogren's that had a pearl, and 1 TSP-HAM that had a pearl. So it's occasionally seen in other diseases, not just MS, but MS is really common. And using 1 or more pearls plus the 40% greater central vein sign, the specificity went up to 99% for MS. So there are patients with MS that don't have pearls, but if you have pearls, and then you have other diagnostic features of MS, that's a pretty good specificity. The sensitivity was not so great. So I've summarized it. I may have given some time back. I don't know. Early accurate diagnosis is key. You make the wrong diagnosis, it's humiliating, it's embarrassing, it's poor medicine, as was pointed out. It's key. And we do want to minimize and hopefully even eliminate misdiagnosis. Therefore, diagnostic biomarkers should and are a high priority. We have very promising soluble biomarkers in MS. We have very promising image biomarkers in MS, but there are going to be criteria to meet to document the value and applicability. And the big thing for all of us is being able to bring it down to the individual patient. And even with the availability of NFL biomarkers, for example, it's still not being routinely used because of all of the issues that need to be worked out. Thank you very much.
Thank you, Pat. You heard that the McDonald 2024 is embargoed, so we won't tell you what it is yet because we get in trouble. But there are some hints around. One of the questions you might ask yourself is, why did I add the next talk to this course? And so the next talk is on the optic nerve from Fiona Costello from the University of Calgary. So Fiona, please.
Hello, everybody. I want to thank the academic CME organizers for having me here. And over the next, 15 minutes or so, my job is really to engender comfort with the optic nerve, which may or may not possibly make its debut in upcoming criteria that I may or may not make reference to. So my objectives really over the next 15 minutes, and I'll try and keep it to that. This is a new talk, so I tend to get very excited about the optic nerve and blather on. But I'll talk about the optic nerve as a model. So it's an anatomic compartment of relevance in MS, and it has connections within the brain as a whole that make it a beautiful relapse model and also a site that we can look for to see evidence of subcortical activity in MS. I'll talk about biomarkers of a visual nature and then make really brief kind of a highlighting reference to what's on the horizon and how we may use visual outcomes in multiple sclerosis in an era where we're incorporating more artificial intelligence and machine learning methodology. So I know what you're all thinking. Well, what is the relevance of the optic nerve in the diagnosis of multiple sclerosis? Well, the optic nerve is part of a pathway, and so information from the retina travels through the optic nerve. It's shared from both sides in the chiasm, And then there's a divide such that in the tract and in the lateral geniculate nucleus, and say, for example, the optic radiations on the right side, I see my left-sided world. What's interesting about the optic nerve is that we tend to think of it as a downstream effect. So what happens in the nerve may or may not cause changes within, the tracts, within the cortex. But it's far more complicated than that, and nuanced and beautiful in some respects, because even lesions in the posterior visual pathway can have upstream effects that we can visualize in the retina. And so really the optic nerve should be looked at as an integral part of an elegant pathway. So the visual pathway is a dynamic, as I mentioned, an interactive, functionally eloquent part of the central nervous system. But it has structural elegance as well that allow us to look at downstream effects of an optic nerve injury that we can measure at various points along the pathway, and even quantify microstructural alterations in the cortex. But so too, lesions in remote areas of the brain within the posterior visual pathway, so that's everything beyond the lateral geniculate nuclei, can actually cause a retrograde degenerative process that manifests as changes in the retina. So what this really means is we're able to look at and interrogate parts of the visual system that tell us about direct and then remote effects of demyelinating both clinically overt and clinically covert lesions in patients being evaluated for multiple sclerosis. And so in many respects, there is a structural elegance pairing with functional elegance, and the eye really is the window to the soul, or in this case, the brain. And what I've shown you here in the bottom part, I think to your left, is that we can actually visualize in MS patients defects that may look like wedge defects where there's fallout of retinal nerve fiber layer thickness, for example, by direct ophthalmoscopy, but admittedly that's hard to do. And so there are tools available to us, and I'll talk a bit about this, that enable this quantification of neuroaxonal loss using the visual system as a structurally elegant and functionally eloquent model of CNS inflammation. So this is just a snapshot of how the visual system may kind of pop up in your clinical experience and within the arena of MS patients that you look for. So shown first here in the retina is cystoid macular edema, and you can have this in MS patients with or without, for example, fingolimod use, but certainly fingolimod-associated macular edema is a real entity we need to look for in patients using these treatments. And so patients with macular edema may just have some blurriness, and they might mistakenly be called painless optic neuritis. The optic nerve is highly relevant, and we may see pallor over time or some of those retinal nerve fiber layer defects, and you see a wedge defect inferior to the nerve shown in the picture. We can use MRI to quantify both longitudinal and discrete lesions in the optic nerve with appropriately protocoled fat-suppressed, GAD-enhanced coronal and axial views. And with elegant MRI techniques, we can actually look at tractography, we can identify tract lesions, we can look at lesions in the posterior visual pathway. And functional MRI studies allow us to look at changes in the cortex that may manifest as a result of, for example, an optic nerve injury. So the optic nerve has both anatomical sort of relevance, but also clinical prevalence in multiple sclerosis. And so anywhere from 1 in 4 to 1 in 5 MS patients presents with optic neuritis as their first heralding event. If you follow patients closely enough, the vast majority will develop either clinically overt manifestations of optic nerve involvement or subclinical evidence of optic nerve disease. It's often heralded by pain, which is really helpful because you can tell what the discrete time of an optic neuritis event was as a relapse. And then functional measures are quite precise in terms of the afferent visual pathway and far surpass the sort of reliability, standardization, and quantifiability of many of our other measures with respect to the neurological examination. Now, back in the back in 1992, which I think predated the birth date of many people in this audience, the optic neuritis treatment trial study results were published. And one lasting lesson from the ONTT is many of the features that characterized optic neuritis as it pertains to MS patients. So we know in a study that was North American in terms of location that optic neuritis in the ONTT largely referred to patients who are mostly white, so 85%, mostly women, 77%, with a mean age of 31.8 years. We know that the majority of patients had pain. It was either present or worse with eye movement at onset. We know they did pretty well. So after a year, more than 90% of patients got back to better than a high visual contrast acuity measure of 20/40. What the optic neuritis treatment trial, however, didn't tell us is what about the patients who never met inclusion criteria? So those would be the patients who had bilateral optic neuritis at presentation. You could argue those would be patients who are outside of North America. So it stands to reason that Chen and colleagues looking at sera of patients in the ONTT, not surprisingly, found no aquaporin 4 antibodies and less than 2% of myelin oligodendrocyte glycoprotein IgG. And that largely reflects the way that study was designed. And I think really important for the residents in the audience is that you cannot extend the findings of the optic neuritis treatment trial to patients who would never have been allowed in this study. So it's not all comers with optic neuritis, it's people who fit the profile. This is a paper published in 2022 that highlights kind of the burgeoning optic neuritis subtypes that we've seen emerge over the last number of years. And so you see how MS-related optic neuritis differs from neuromyelitis optica spectrum disorders, myelin oligodendrocyte glycoprotein antibody-associated disease, GFAP or glial fibrillary acidic protein meningoencephalitis, and CRIMP5. And so what we typically see in our patients with MS is not a lot of optic disc edema. About a third will have severe vision loss. Most will improve by 3 to 5 weeks, whether or not you treat them. But I think one myth that's since been kind of busted from the optic neuritis treatment trial is, in fact, that optic neuritis is easy to diagnose. And for a decade, I've been beating the drum and pumping the tires and saying that optic neuritis is one of the easiest clinical diagnoses to make. So who thinks optic neuritis is easy to diagnose? Finally, the truth is revealed. And Stunkel and colleagues in 2018 actually demonstrated that, so that in over 100 patients sent to tertiary referral centers to consolidate whether the patients in fact had optic neuritis, the overdiagnosis rate was actually 60%. And factors that led to overdiagnosis, understandably, were reliance, for example, or perhaps an over-reliance on pain. So if you're a young person and you present with pain with eye movement and have difficulty performing a test, you may be labeled as having optic neuritis, and that's a potential pitfall, as Dr. Berger's pointed out and Dr. Coyle's pointed out, leading to misdiagnosis. Another thing that led to overdiagnosis of optic neuritis was really not being confident in the exam findings. So not documenting or being sure a patient had a relative afferent pupillary defect. Not being sure that the patient had normal vision or was in fact visually impaired. So that sort of leads me to, the next question is, what can we do to engender comfort in the evaluation of patients with optic neuritis to improve diagnostic certainty in what is a cardinal clinical presenting feature for many patients with MS? So what is the role of visually evoked potential testing? Who here uses VEPs in their practice? I see a few tentative hands, like Nemo. I was kind of beaten up on the VEP for about a decade as well, but I've since come to see its value, although it's actually a hard test to get in some centers. So if you're not familiar with it, you're in a fairly sizable majority. So visually evoked potential testing has largely been the mainstay of determining whether patients have had demyelination in the afferent visual pathway, and so it really measures the speed of light transfer from the optic nerve or retina right back to the cortex. And so delays of the P100 latency, a positive deflection in the VEP response, have been seen as measures of demyelination and subsequent shortening as remyelination. VEPs provide a slight improvement in the sensitivity of MS diagnostic criteria by adding an extra site, namely the optic nerve, to the dissemination in space category. Now, I'm not sure if people can see. Can everyone see this moving circle? If you can't, don't be alarmed. We'll talk later. And so this is really an example of what Netta Levin's group showed back in like roughly 2012. So we largely rely on static perceptions of form. So we look at high contrast acuity, visual field performance, to determine whether someone can see or not. But in reality, what many MS patients complain of after optic neuritis is more subtle and nuanced. Like they have difficulty tracking their child, for example, play soccer. They have difficulty with motion perception. And what you're seeing here is a test devised by Raz et al. That looked at motion perception deficits in patients with optic neuritis. And intriguingly, patients with prolonged VEP latencies had persistent motion perception deficits long after all their measures of static perception of form had improved. So we may be interrogating function the wrong way, is my point, by relying on looking at the big black E on a really white background. And there may be tools that we can use that better help us understand what the patient has actually experienced in terms of a demyelinating hit. Recently, and this isn't the only study that has shown this, the Barcelona group looked at a bunch of CIS patients and determined whether adding VEP improved diagnostic accuracy and sensitivity without forfeiting specificity. And in fact showed that we may be able to use VEPs to indicate evidence of optic nerve involvement in future iterations of the diagnostic criteria that shall not be named. So there are pros and cons, of course, with VEPs. They're widely available, but not widely used, as is evidenced from the fairly meager show of hands here when asked who's actually seeing them in their practice. Testing can be time-consuming, and there are artifacts within our traditional VEP measures that need to be considered. I do think VEPs have a very specific role and potentially motion perception and other very refined tests to look at the effects of demyelination and potentially remyelinating therapies. But that's not the only mechanistic process that contributes to neurological disability in MS patients. And so the next question is, how can we measure neurodegeneration, or specifically neuroaxonal loss, in patients with afferent visual pathway lesions? Well, first we have to rely on the plausibility that what we're measuring with the test actually reflects what's happening at a pathologic level. And in 2010, Ari Green and colleagues looked at post-mortem eyes and showed that retinal atrophy was very common in patients with MS as compared to those who had succumbed to other neurological diseases. And that worse retinal atrophy correlated with brain weight that was decreased as well. And so really Ari showed that what happens in the eye of MS patients is really reflective of what's happening in the brain as a whole. And the histological findings in this study confirmed what we see in OCT, which I'll talk about now. So OCT testing is something perhaps many of the people in this room have actually had. It's non-invasive, it doesn't hurt, it's easily accessible. Every eye care center will have one. It is reliable and reproducible. And it really has been something used in the study of retinal disease and glaucoma, but for our interest, we'll be looking at the retinal nerve fiber layer, and we'll be looking as well, which is a demyelinated region, I should say more an anatomical region that lacks myelin within the retina, and then the deeper lying retinal ganglion cells. The OCT is able to generate, within small microns of resolution, measures of the retinal nerve fiber layer and ganglion cell layer within 2 to 3 microns. And so it will look something like this. So you just sort of sit like you would at a slit lamp, and there are measures that are detected in terms of relevant neuroanatomy, I would argue, of the retina. And so what you'll see is a printout that looks a little bit like this, where the software compares a patient to age match and sex match controls. And you can get a peripapillary tomogram or a circular scan around the optic nerve that looks at the depth thickness, and this is our axonal measure. And as well, you can get depth measures through the macula or the macular ganglion cell interplexiform layer, and this represents a neuronal measure. And then the two combined are essentially a quantifiable metric of neuroaxonal integrity. And so to put that into meaningful terms, if you have a patient presenting with optic neuritis with a classic sequential defect in the left eye, not much to see in the fundus examination with decreased visual acuity and a relative afferent pupillary defect, what you'll often find with OCT is subclinical thickening, reflecting neuroaxonal flow stasis of the peripapillary RNFL, and you'll have normal baseline ganglion layer measurements. And so this is what I would call a snapshot. If this is a patient referred to me, this has all the markings of a patient with acute optic neuritis in the right clinical context. 6 months later, I'll see another snapshot, and that is of resolved optic neuritis, where there'll be inter-eye thinning or inter-eye differences with thinning of the peripapillary RNFL and thinning of the macular ganglion cell interplexiform layer in the eye that has suffered optic atrophy. And this is a lot easier to actually pick up on than to ballpark pallor with ophthalmoscopy. And so these inter-eye differences have gained significant relevance in identifying optic nerve lesions in MS. We can use OCT measures over time to track the effects of an event. So we know from pain heralding optic neuritis that peripapillary RNFL measurements and ganglion layer measurements will sort of thin over about 3 months, plateauing about 6 months. So you can really identify within what time frame and to what extent a patient has suffered neuroaxonal loss referable to a discrete clinical event. And so this is a study showing these very things by Shiv Seda and Peter Calabrese, and our group has shown the same. We also know that the extent of neuroaxonal loss after an optic neuritis event measured by OCT correlates with function. So this is a study done years ago where we identified a tipping point, meaning we can sustain a hit of up to about 20 microns after optic neuritis, but beyond that, we have irreversible vision loss. And for every 10 microns loss below approximately 75 microns, you get about a 7 decibel decrease in sensitivity. So this has been really described as the hill to die on. This is the substrate metric we need to protect in our patients in a functionally eloquent part of the central nervous system that defines whether they'll have permanent disability or not with respect to vision. In a meta-analysis done in 2017, Axel Petzel and colleagues showed us that while OCT kind of shows us what we know, that is the effects of an optic nerve insult and how we quantify that, we know that we lose about 20 microns of peripapillary RNFL thickness after optic neuritis. We know that we lose about 16 microns of macular ganglion cell interplexiform layer thickness. But perhaps unbeknownst to all prior to this study and the studies that sort of preceded it is that OCT is sensitive to detect 6 to 7 micron hit that a so-called normal eye of an MS patient will have relative to healthy controls. So it's also a biomarker for subclinical disease. And inter-eye differences, a little bit like I showed you in that case example, have been touted as a way that we can identify optic nerve involvement in evolving criteria that may involve the optic nerve as an anatomical compartment for dissemination in space. And so what I mean is this. If you have a lower peripapillary RNFL measurement by 5 microns and a lower ganglion cell measure by 4 microns, that is proof of concept that an optic nerve insult occurred in this patient. And this has been shown in adult patients as well as pediatric patients. In terms of machine learning, we're able to look at composite scores. And so what Nolan Kennedy and others have shown is that you can use ganglion cell interplexiform layer, so the neuronal metric, as a way to detect prior optic neuritis. But if you want to look at which patients have MS, there's a beautiful reproducibility and predictive value of using the ganglion layer thickness, the inter-eye difference between ganglion layer thickness, and binocular low contrast letter acuity. And these 3 pieces of information informed a machine learning classifier model that was able to predict MS patients from those without MS. And so the future is bright with respect to how we may be able to incorporate things like OCT measured inter-eye differences in terms of ganglion layer thickness and retinal nerve fiber layer thickness to, as I say, provide comfort to diagnosing MSologists about rendering whether or not the decision, whether this patient truly has MS or not. You'll no longer have to try and fight to find the RAPD, struggle in a dark room to see the back of the eye, and question whether or not you are kind of right on the money or not. So in terms of classification schemes for optic neuritis, there's role for VEP. This is a study by Pat Sold and colleagues as well. We know the role of peripapillary RNFL measure thicknesses and macular ganglion cell interplexiform layer measures. We know that MRI has a role here if protocoled properly in terms of persistent T2 signals as well as acute enhancing signals in the optic nerve. And fluid biomarkers can help us to make sure that we're not calling a patient with NMO or calling a MOGAD patient MS. And so I'll leave you with this. There has been, I would say underfoot, a 20-year dedicated effort to try and provide tools to non-vision specialists who look after MS patients to allow them to identify evidence of symptomatic optic nerve involvement and asymptomatic optic nerve involvement. And these will include things like low contrast letter acuity, which I didn't have time to talk too much about today in terms of time allocation, VEPs, MRI, and OCT. And in the world as we know it, we'll be able to use these visual outcomes to determine with, say, OCT, whether patients have inter-eye differences suggesting prior optic nerve unilateral involvement. We can also look at whether patients have MS based on their low contrast letter acuity measures in basically concert with their OCT measures. We can use VEP to determine whether patients have had prior demyelination. We can look for MRI features of axonal loss, demyelination, and potentially cortical compensation to figure out why patients sometimes do well and others do not after an optic neuritis event. And we can partner these visual measures with evolving discoveries in fluid biomarkers and MRI technology to better render the diagnosis we seek. And so to conclude, I will say I think the optic nerve should be part of the upcoming criteria. VEP, OCT, and MRIs will be your best friends. Advances in AI will help refine future models for MS diagnosis, and so I hope I've left you with a lasting, lingering love of the optic nerve as I share myself. Thank you.
Okay, the next two things we're going to do is we're going to have Joe Berger come up and talk about some cases, and we're going to have a panel up here which includes Ben Segal from The Ohio State University, plus Joe and Fiona and Patricia. Patricia, up here. And so you guys can weigh in on the cases that Joe's going to do. Then I've got some terrific questions that came in, so thank you for that. And I'll give them to the panel after he does a few cases.
This is a little unfair to Fiona and Ben because Pat's seen a couple of these cases in a prior conference, but so. All right, we'll start with case one. This is a 49-year-old man, came to see me in Kentucky. He had been hospitalized for vertigo and cognitive changes. He had a sudden onset of vertigo on awakening with intractable vomiting. He had no associated hearing loss or tinnitus. He reported impaired vision, blurring, and whiteness, and unaccompanied by pain, by the way, numbness in the right face and both hands, and electric shocks in his left arm, and he had severe headaches. That was the history that was obtained from him. An office visit reveals that he was morbidly obese. His visual acuity was 20/50 in the right eye, 20/40 -1 in the left. He missed two color plates. It was curious. I didn't hear much about color vision in Fiona's talk, but maybe we could talk about that later. And one on the left. He had a slow, deliberate gait in tandem. He had an equivocal left Babinski, and he had diminished sensation over the right side of his face and his body. He had been worked up long before he'd seen me. He had audiology, ENG, bears, all of which were normal. He had a visual evoked potential that showed prolongation of the P100 bilaterally. His cranial MRI, which I'll show you in a second, was thought to be compatible with multiple sclerosis. He had a CT angiogram that was normal, a CBC, SED rate, ANA, ANCA, so on, all of which were normal. His spinal fluid showed 4 oligoclonal bands. He received 5 days of IV methylprednisolone. His headache resolved, but his symptoms hadn't resolved. And this was his MRI. So you see these lesions that you'd say, hey, that's pretty consistent with MS. Actually, there's a faintly contrast-enhancing lesion here. It doesn't reflect well on this study. But with that information in hand, maybe I'll turn it over to the panel. What do you guys think? I mean, would you say, and by the way, these may be MS cases. They're not necessarily all MS mimics, so I'm going to tell you that. So would you say this is MS, or would you say, just with that information, or would you say, I want more data?
Well, bilateral optic nerve issue is unusual in MS.
You know what, you should bring your mic down a little, Pat.
Bilateral optic nerve abnormalities are unusual in MS.
Fiona, any thoughts? Ben, any thoughts? Go ahead. Yeah, please.
How old was this gentleman again?
He was in his 30s.
Okay, young. We've got a lot of information thrown at us, but if I were, so he has long track findings with Babinski. I don't know the tempo or whether he's had a relapsing course. I know that he has non-specific findings. The VEP could be part of a macular process because there's overrepresentation of the cortex, so I wouldn't hang my hat on that. The imaging's great, but these are not actually the cuts I would like to look at. And right now it's a busy snapshot with a lot of data, but without the tincture of time. So I would put MS on the list, but I'd keep my mind open.
Okay, Ben?
I agree. He had 4 oligoclonal bands, correct?
Yeah, he had oligoclonal bands.
So that suggests it could be a neuroinflammatory process. You also have to think of other things like lymphoma, et cetera, but...
Okay. Sure. Well, let me tell you what happened. So in July of 2010, so a year later, he comes back. He had been treated with modafinil for severe fatigue, sort of, thought to be MS-related. He got better with that, but he had worsening vertigo. He did complain of innervation on exposure to heat with worsening symptoms that were transient. He had lightning-like shocks in his extremities, weakness in both lower extremities, and he said one other thing. He said, you know what? It hurts when I swallow and I have diarrhea. It hurts when I swallow and I have diarrhea. So what do you want to do next? I'm going to ask the panel. You hear that story. Is there something you want to do when you hear that story? Pat, you can't answer.
Look at his mouth.
You weren't supposed to say that. I wanted to hear what Ben and Fiona said, because Pat hears me say this every year. What do you want to do? You want to examine the patient. Hey, open your mouth. Let me see what's going on. So he opens his mouth, and lo and behold, he's got ulcers on his tongue, and he's got ulcers in his mouth. And it turns out, what do you want to do after you see that?
Ask if he has ulcers on his genitals.
Why would I ask? I said, take off all your clothes. I mean, you are a doctor. I had him take off all his clothes. And guess what? He's got ulcers on his genitals. He's got all the characteristic lesions of Paget's disease. And that's indeed what he had. He had Paget's. So the criteria are, and he tells you that, yeah, I've had these oral ulcers. I didn't think much of them. I thought everybody got them. Well, a lot of us do get these oral ulcers. But yeah, you should see the oral ulcers, or they should recur 3 times annually. Genital ulcers or scarring, eye involvement, skin lesions, pathogy, and then there are these minor criteria. And to make the diagnosis, you need the oral ulcers and 2 criteria. We used to think this was a disease of the Mediterranean littoral. It's not. You see it everywhere. It's more common there. The Turks see a lot of it. When I lived in Israel, I saw a lot more than I do now here. But I will tell you that this was a lily-white Scotch-Irishman of Scotch-Irish heritage from eastern Kentucky the hollers of eastern Kentucky. Roughly equal genders, diagnosis is based on clinical features. There's no pathognomonic sign, and 4 to 50% have neurologic manifestations, sometimes looking very much like MS.
Can I make a quick comment?
Sure.
So, not to belabor this, but I do really think the eye is the window to the soul. And I will say that those acuities would not have made sense for recovered optic neuritis in MS. And if you ask your ophthalmologist to see a patient like this, they'll look very specifically for signs of uveitis, which would be, I think, a very different quick and dirty differential, and they would have rendered the diagnosis quickly.
Yeah, maybe. All right, here's another case. 36-year-old man, he's evaluated for clinically isolated syndrome. Again, another Kentucky case, 2009. He had vertigo, horizontal diplopia on gaze left, slurred speech, right hemi-tongue numbness, and imbalance. And then he had a subsequent spread of the numbness over his entire right side. But all these symptoms resolved within 4 hours, except for the tongue numbness. The tongue numbness was persistent. In March, he had another episode, but it was short-lived, only an hour. He had left-sided numbness with paresthesias, questionable left-sided weakness. He denied fatigue, enervation with heat, Lhermitte's, sphincter problems, or anything else. He had a family history was negative for MS. He had a history of hypertension of a 1.5 years duration. And one other thing he talked about is, he said, my skin changes color when I'm out in the cold. And he had a classic Raynaud's with a tricolor response. It went from white to blue to red and was painful. His neurologic examination was normal. Fundi and color perception were normal. He had no nystagmus or ocular dysmetria. He had mild fixation about the left arm. He was clumsy using the left hand. He had no limb dysmetria. His gait was normal, but he was unable to tandem. He had normal reflexes, normal sensation, but a positive Romberg test. And his MRI showed atrophy, a hyperintense signal abnormality on T2-weighted imaging in the subcortical right frontal lobe and subcortical lesions in the left hemisphere and deep white matter lesions. None were periventricular. Diffusion-weighted imaging was normal. He had no black holes, and he had no contrast enhancement. He did have 2 oligoclonal bands and a slight elevation of myelin basic protein. And these, I don't have the whole MRI series here. Some of them I do, not this. But these were the type of lesions that were seen on, here we go. Here, that we're seen. So, whoops, I gave away the answer. Any thoughts, panel?
Well, it's not a good story for MS.
Right. So what do you want to do next?
Examine him. Does he have libido reticularis?
Yeah, so, So, I put this case in because one of the things that I'm very fond of is doing a good physical examination. I think it's critical, particularly in cases like this where you say, well, I'm not quite sure what's going on, and the patient tells you they have Raynaud's. And in fact, the reason that I told him to take off his clothes was because when I checked his Babinski, this is what I saw. Oops. Look at his toes. They were purple. I said, wow, that ain't right, as they say in Kentucky. I said, that just ain't right.
But even by history, you would be concerned about a vasculitis or possible ischemic etiology because of how short-lived the events were.
Precisely. So he has libido reticularis. Panel, do you want to tell us what he has? Any thoughts?
Did you ask the audience? Or?
Oh, you want to ask the audience?
Oh.
I'll ask the audience. Anybody want to tell me what you think he has? Pardon? Sneddon's. Yeah, he had antiphospholipid antibody syndrome. So all these things were normal with the exception of the antiphospholipid antibodies. They were positive. And this is Sneddon syndrome, described by Sneddon in 1965. The incidence is 4 per million. It's more common in women. Mean age is 31. It's an antibody to antiphospholipids. You could see anticardiolipin antibody, lupus anticoagulant, anti-beta-2 glycoprotein. However, they're commonly observed in the otherwise normal population. So you have to interpret it in the context in which you see it. The hallmark is an ischemic stroke. You know, his problems sounded more strokey than they did MS-like. And sometimes you'll see myelopathy, seizures, headache, chorea, Guillain-Barré, peripheral neuropathy. So those are some of the things. All right, case 3. This is a woman who came to see me for progressive MS, primary progressive MS. She's a 49-year-old lady from Jamaica originally. She was seen in 2015. She said that in 2011 she noticed stiffness in her legs, her hands, and her neck. She began walking slowly and had difficulty lifting her right leg. Her symptoms worsened, but she was fully ambulatory, and in 2013, in January, she had numbness of her feet that ascended to the mid-thighs. It started on the right, but ultimately both were affected. She developed Lermite's phenomenon in April with neck flexion. She was found to have cervical spondylotic myelopathy, or thought to have cervical spondylotic myelopathy. She had an ACDF at C5-6. And by the way, I've frequently seen patients that have cervical spondylotic myelopathy that have been misdiagnosed as primary progressive MS. She continued to worsen after surgery, however. And then in 2015, she began using a cane in her left hand, and in May, she needed a walker. She had an ACE, Lyme, and NMO, all negative. Spinal fluid showed 8 oligoclonal bands. The protein and glucose were normal, and she did have some white cells, 26 white cells. It was repeated in 2015. Again, she had oligoclonal bands, a greater number. She had 12. An MRI of the brain showed a few nonspecific lesions, nothing that really suggested MS. Cervical spine showed stenosis at C3-4 and C5-6 chiefly. Her exam, which I'm going to show you, I'm not going to show you the whole exam, I'll just show you her walking, was remarkable for spastic weakness, chiefly in the proximal lower extremities, diffusely brisk reflexes, bilateral Hoffmans and Babinskis, a sensory level at T7-8 to pinprick, absent vibration at her knees, and she had been diagnosed elsewhere, I should say, with primary progressive MS before she saw me. This was her brain MRI, which really didn't show a whole lot. And this is her.
So, and you have to hold on to the railing because your balance is so poor?
Yes.
I asked her if she had to hold on to the railing because her balance is poor, and the answer is yes.
Do you find that the right leg is stiffer than the left? Yeah, let's have you turn around and walk back the other way.
So I guess I'll ask the audience, why don't I?
And you were walking relatively normally until a year ago?
Not even a year ago.
Not even a year, but
Yeah, we have picnic every year. Last August, I was walking very fine.
Okay, audience, what do you think? Is this primary progressive MS, or is this something else? Is there another test that you want to get? HTLV1, very good. Okay, got a smart audience. So that was my impression. I mean, she was Jamaican. I lived in Miami for almost 20 years, practiced there, and we saw a lot of HTLV1 in Miami, large Caribbean population. And indeed, she did. That's what she had. She had HTLV1 myelopathy. This also goes by the name of tropical spastic paraparesis. Are you throwing me off the stage? Oh, no, let me do one more case. I'm going to forgo all that, and we'll do at least one more case, because these are so cool. 2 minutes, okay. This is a 64-year-old Caucasian lady. She was diagnosed in Houston at age 48 with multiple sclerosis. She found it difficult to walk across the campus. She was taking classes there. She had progressive weakness and stiffness in her lower extremities. She was not started on any disease-modifying therapy. She was seen, actually, by a very well-known, highly respected MS neurologist who diagnosed her. She then developed acute face numbness at age 56. Glutaramine acetate was initiated at 58. She began using a cane intermittently. She got progressively worse with urinary incontinence and frequency. Family reported cognitive abnormalities, and she also reported enervation with heat, tinnitus, other issues. She had a history of migraines from age 14, but they were infrequent, no other neurologic problems. She had hyperlipidemia, family history was unremarkable. She, on examination, had poor memory, bradykhrenia, spastic extremities, brisk reflexes with bilateral Babinski's and Hoffman's, and vibratory sense diminished in lower extremities, but not dramatically. And this was her MRI. So does anybody want to tell me what they think she has? CADASIL. And in fact, that's what she had. She had CADASIL, and when we saw her at the University of Kentucky for the first time, she had had an acute stroke. So it sort of helped in making the diagnosis. So this was an individual that had CADASIL. And she was positive for Notch P3, as was one of her sons, who was followed by Jim Grotta at the University of Texas, Houston. So Fred's giving me the hook. My best case is the last one. So by audience, all right, we'll come back to it.
Okay, I've got some terrific questions here for the group, so thank you all for that. So I'm going to do them in the order they came in. So when a patient presents with vague symptoms, that could be MS, the kinds of patients that are misdiagnosed with psychiatric disease or migraine, what should be the threshold for ordering an MRI, and what about MRI with contrast? So Joe, maybe you take that.
Yeah, all right. So I guess I have a low. I guess I have a low threshold because you know what? The patients come in and they say, "I want an MRI," you know, and who am I to argue? And you know, every now and then you'll find something. So my threshold's actually pretty low unless I'm absolutely convinced they're Meshuggah.
Contrast?
Yeah, I'll generally get contrast. I mean, it just, I don't know. I end up getting both.
Other thoughts? Okay, Pat, in oligoclonal band negative cases, should we repeat the CSF testing and when?
We find looking at spinal fluid extraordinarily helpful, and honestly, if they're oligoclonal band negative, it's sort of like a mini red flag, red check. There may be a rationale in repeating it, but you have to leave long enough. So I certainly wouldn't do it within probably a few years. You can see conversion to oligoclonal bands, and you can also use it as a check for people where you maybe have diagnosed MS, but you have big question marks. Oligoclonal bands should not disappear. That would be a sign that they didn't have MS.
So one of the questions I've always had is, when do they develop? Which gets to this, and you said repeating, but I don't know, do you know the answer?
Well, remember, I quoted that machine learning article that found CNS activation markers were associated with oligoclonal band positivity or not. The oligoclonal bands are presumably due to plasma cells in the meninges, so maybe you have a slightly more inflammatory condition. Obviously, lacking oligoclonal bands doesn't mean you don't have MS. It does happen, but it's unusual over time, less than 5%.
Okay. Does NFL correlate with gadolinium-enhancing lesions? Who wants to try that?
Well, I would say theoretically, yes. NFL goes up more so with focal inflammatory relapsing component than the progressive neurodegenerative smoldering inflammation component. And that was a surprise. They expected NFL to be great for progressive MS. It's not. It's not. You get higher levels with relapsing MS, active relapsing.
So when we looked at this in CombiRx, the presence of NFL was highly predictive of a relapse over the next 6 months. The presence of a gadolinium-enhancing lesion at baseline was a little more predictive, and of course, both was even better. If we develop therapies that cross the blood-brain barrier, do you expect to see a change in oligoclonal bands, or do you feel that OCBs will always be a constant, that is, never go away?
You can't do oligoclonal bands without having the paired blood and spinal fluid. You subtract out anything in blood. Your clearest is not to have oligoclonal bands in the blood compartment, just in the CSF. But you've got to do a duplicate sample. You can't run oligoclonal bands just on CSF.
So are there any therapies that have taken away all the clonal bands?
You know, that's an interesting question, and I'm going to say that I don't think there have been multiple studies that definitively say this can take it away. It's obviously possible if you had a potent enough, treatment.
Ben?
Well, there have been studies with B-cell depletion therapy, and they do not take away oligoclonal bands. So in every study I've seen, no therapy eliminates them.
Okay. Again, for Dr. Coyle, is there a way to order MRI for patients in non-academic settings so that MRI is performed with appropriate sequences?
This is a big deal. So there's been recommended standardized brain, spinal cord, optic nerve imaging from names, from Magnums, from CMSC, and there's like a little card. You can give that to your imaging center and say, please do the MS protocol for the imaging. That would be very helpful. People should get that.
Okay.
One thing that I always specify is to get sagittal flare sequences, because in the community sometimes those aren't done, and I find it very useful.
Okay, but what about central veins, paramagnetic rim lesions, and cortical lesions?
Those are research right now, research. Wave of the future, maybe?
Yeah, next hint, think about those. Okay, how long does it take for the VEP to be abnormal, prolonged P100, after the patient starts having optic neuritis symptoms? Fiona.
The VEP is abnormal most predictably acutely, and you'll still see abnormalities after 6 months, but the signal of VEP abnormality will attenuate with time with remyelination. So it's most likely to be highest yield in the acute setting.
And between VEP and OCT, is one more effective at diagnosing optic neuritis?
Oh, yeah. No, they're all my favorites. They're like children. I would say that the question needs to be rephrased, because I don't think either one of them should be used in isolation. And so I would say in my practice, if I were seeing a patient with a really classical presentation of optic neuritis, they would both be very useful acutely. In the VEP, I would see a delayed P100 response and a diminished amplitude. The amplitude and the P100 latency would improve over time. In the OCT, I would see some peripapillary thickening and attenuation of the peripapillary RNFL thickness and ganglion layer measurements over time. And it would be very much like a neck-and-neck race within the first 6 months. I think the problem lies in that the staying power of an OCT finding, I think, outpaces a VEP after 6 months. So it would be my favorite if I had to choose one.
Okay, and for choosing, is the use of the ganglion cell interplexiform layer plus NFL, the retinal nerve fiber layer rather, combined better than either one alone?
Yeah, it depends on the paper you read, I should say, and maybe the paper you write. So people will say that the ganglion layer and the ganglion cell interplexiform layer composite is the best way to determine optic neuritis, and I think there's truth in that. But I would say that the problem with the GCIPL is it's kind of a one-hit wonder. It's really hard because of floor effects to pick up new on old. So a new event on top of old atrophy. So I find that there's a little bit more bandwidth in the peripapillary RNFL measurement for that. The other thing, too, that I haven't talked about, because I already went over my time, Fred, and I do apologize, but there are problems with using OCT that have to do with the anatomy of your eye, or whether you have mediopacity or carry a much more common optic neuropathy like glaucoma. And so I do think that you need both measures to really suss out what is unrelated to the question you're seeking to answer about MS and inherent to the patient, and what is related to the MS question.
Okay, and then the last one I have here is, what if NFL and GFAP pointed in two different directions?
Well, that would be a dilemma, wouldn't it? They aren't, generally they travel together. They aren't correlating with the same things. That's why the argument is being made that, GFAP and neurofilament light are both going to be useful biomarkers to give us insights into MS. They won't be telling us the same thing. And there are recent articles that are, stating that there are value in looking at both of them in combination.
Okay, anyone want to yell out a question before I dismiss the panel? Is there one out there? Yes, no? Yeah. Yeah. He did. Okay, well, thank you for that, Cliff. Oh, one more quick one here. What are red flags for nonspecific subcortical white matter lesions in migraines that make you more concerned for RIS? Number, size, enhancement, it doesn't say it here, but central vein?
Any of those?
Yeah. The central vein is going to be very helpful once that gets into common practice for doing that, but mostly the location as well. There's this nonspecific area, and then you heard about the 4 specific areas in MS. Okay, thank you very much, panel. And then can we load my presentation? And while they're loading that, the next hint for McDonald 2024 is think of Einstein's space-time continuum. And you won't appreciate that till you see me at this course next year. Okay, I'm going to talk about clinical courses, starting at the prodrome, ending at progressive disease, and perhaps some new ways to look at the clinical courses. So we're going to talk about the revised clinical courses that we came up with and published in 2014, some revised definitions, and then the consequences of the changes. So we originally did the clinical courses in 1996 just to provide some clarity and some consistency amongst colleagues of what we were describing, and we did it as a community exercise. We queried the international MS community, what are you calling relapsing, remitting, secondary progressive, et cetera, and came up with definitions. And they did pretty well over time. Clinicians used them. They were useful in clinical practice. Regulators used them, and they were particularly helpful in clinical trials for getting homogeneous populations. We met in 2012 and 2013, to see if we needed to revise them, and we decided that they had done pretty well, but we wanted to add on an assessment of activity to give a more dynamic approach to the characterizations as how did the patient look when they presented to you, and so measures of activity, and then measures of progression with the understanding that progressive disease is not inexorable. It plateaus, it stops, it comes back again. And so we also, by doing that, did away with the term progressive relapsing MS because that became primary progressive MS with activity, meaning it starts out as primary progressive and then there's subsequent relapses or MRI activity. We also stated and still believe that primary progressive MS, and I'm going to show you something about this, is a part of the MS spectrum and not a separate disorder. We took up clinically isolated syndrome at that time and said this is MS, it's part of the spectrum of MS. We said radiologic isolated syndrome, not yet because there was nothing clinical, but that may change, so that's another hint. And so when we talk about active disease, so first thing is, and this has caused considerable concern, enough that we had to write a clarification in neurology in 2020, is any of these characterizations, whether it be active disease or progressive disease, has to be framed in time. Otherwise, it has no meaning. Now, you could pick your time frame. We said you should at least assess people annually for whether they've had a relapse or new MRI activity, which is what the diagnosis, what the characterization rather was of active disease. Either one of those is active, and we equated the two. So new gadolinium-enhancing lesion had the same biological significance as a new relapse, but had to be framed in a particular time period. Same thing with progressive disease. Progressive disease was any way you want to measure it, and we all have different ways of measuring progressive disease, but looking at someone over a period of time, saying were they progressing or not. So someone that I'll see in the clinic with say primary progressive disease, I'll go through, and if they look the same, primary progressive disease not progressing over the past year, or relapsing remitting disease active in the past 6 months. So then when we got done, we said, well, what is a relapsing form of MS? You'll see this in labels now that the regulators have picked up, and they got it partially right and majorly wrong. So a relapsing form of MS, well, relapsing remitting MS is a relapsing form. Clinically isolated syndrome, even though there's no relapse, it meets criteria. It is the start, it's the first attack, and so that's a relapsing form of MS. Secondary progressive MS, that's active, is a relapsing form of MS. Primary progressive with relapses, no one's looking at this clinically, and that's not a bad thing, but it's a relapsing form of MS. What we never really dealt with was whether a primary progressive who has new T2 activity we would consider relapsing MS or not. And some of the things that we're thinking about, well, should we have newer, better definitions of activity? Should we look at brain volume loss? Should we look at cognitive changes? For progression, should we look at cognitive changes? Should we look at changes of OCT? Because OCT does somewhat correlate with progressive disease. And then you saw the 2017 McDonald criteria, and I highlighted the fourth item, and that was, in addition to making the diagnosis, when you make the diagnosis, also incorporate the clinical course that you see at the time of diagnosis. And that's of some importance, whether you diagnose MS and then say relapsing, remitting, and active over the past year or not. So then we have this issue of what's active secondary progressive MS. So this is in the label of all of the drugs that have been approved for relapsing forms of MS. It started with the Saponimod label, but then was broadened to all of the other agents that are approved. And it doesn't make a lot of sense because, let's see if I did it in this. All secondary progressive MS has been active by definition. You can't get to secondary progressive MS without having relapsing remitting MS. And so if you don't time frame that definition, then you as a clinician can treat any secondary progressive you want with approved medications because it's in the label, because all it says is active, and it doesn't give you that time frame. Non-active secondary progressive MS, in the absence of a time frame, is an oxymoron. And then worsening MS is not the same as progressive MS. We wanted worsening to be any way you got worse, and I'm going to show you why that's important, because there's two ways you do it, and reserve the term progressive just for those who are in the progressive phase of MS. And even though the FDA screwed this up, Health Canada and EMA only did a little better when they defined active MS. They included MRI activity, but they still didn't time frame it. So some thoughts for the future on this are, reconsidering radiologic isolated syndrome. We have staging progressive disease, looking at MS as a continuous disease, and I'm going to show you where that's going, and maybe quantitating the activity. We dichotomized it. You're either active or you're not active, but there's probably value in looking at someone who has one gadolinium lesion and distinguishing that from someone with 12 of them. And when you think about the clinical course ontology, and I've thrown in the prodrome here because there's something going on in MS patients before they're ever diagnosed with MS, and I'll show you a little more about that. And then RIS, and then what's interesting about radiologic isolated syndrome is that most of it goes on to clinically isolated syndrome, relapsing, remitting, et cetera, but about 10% of RIS goes on to be primary progressive MS. And that's the same frequency as you see primary progressive MS in your general population, which further unites the concept of primary progressive MS is very much a part of the spectrum of MS and not something different. And then there's this very nice paper that came out last year on trying to harmonize the definitions of progression independent of relapse activity. And I'm going to give you my views on it because while this is an important paper, there's a problem with it. So there's only two ways you get worse in MS. The first is relapse-associated worsening, and that's what's shown here. Does this show up? Yes. So you have an exacerbation, and anytime you have an exacerbation, you're going to have recovery of 0 to 100%, and something in between. Any residual that's left over is relapse-associated worsening. And then there's PIRA, progression independent of relapse activity, which is worsening independent of relapse activity. And though these are interesting concepts, PIRA is progressive disease, and I'll show you that. This we went through, the different types. I don't need to show you that. So then, and there's been some discussion about this, is all MS progressive? And my answer is no, it is not. And I think that those of us with grayer or fewer hairs will tell you that we see people who we've diagnosed correctly with MS that do great over 20, 30, 40 years. Most of them with therapy, some without. There's some patients who do poor, but not every patient has progressive disease. And that doesn't matter how you develop your impairment. Well, it matters when we think about how we're going to treat it, whether it's raw or whether it's PIRA. Doesn't matter to the patient how they got their disability, and that's something we need to deal with. And PIRA is progressive disease. It's in the name, right? Progression independent of relapse activity, and it's either primary progressive or secondary progressive, depending on the history. So this is part of that harmonized definition, which looking at people over time, and like I said, it serves a purpose, but the problem with PIRA, if you read the literature, is in the definition. And definitions matter, and I'm going to show you why. So another thing that I'm thinking about PIRA is irreversible PIRA. To me, true PIRA is irreversible. That is, once you develop a level of impairment, you never get better. Okay, and that's also the definition of progressive disease. But people are now showing PIRA that occurs separate from a relapse, but that also improves. So I've been calling that reversible PIRA. And that's what you see when you see people talking about confirmed PIRA as opposed to sustained PIRA. So true PIRA should be sustained. Reversible PIRA is interesting. It may relate to repair mechanisms. It may relate to errors in assessing the EDSS. Biologically, it may relate to some of these metrics like pearls and slowly expanding lesions, which, as you heard, resolve over time. And then, I was hoping this wasn't a build. Sorry. So this is some work we did with, I'm going to go one too far. No, I did it. Okay. This was some work from Novartis, which has this enormous database of all sorts of MS cases, like 27,000 from clinical trials and observational studies, and they gave them to the Oxford University Big Data Group for analyses. And so we did some analyses, and one of the things that you'll see is in every PIRA paper, there's different percentages. There's some that say PIRA is 60% of progression and such. When we looked at clinical trials, which is this bottom here, the number of individuals entering a relapsing remitting clinical trial who actually had PIRA was only about 3 to 4%. Now, in this group, only 11% of them had actual worsening. And we've seen that in most of the relapsing clinical trials. Not that many people actually worsen over time, as opposed to those here that have relapses. Interestingly, when you go to the full data set, which includes observation studies, PIRA is a larger percentage of the group, which to me suggests that in observational studies you're missing out on a lot of relapses that are more carefully characterized in phase 3 randomized trials. Now, when you get to secondary progressive and primary progressive, the percentages that are PIRA go much higher because that's the definition of progressive disease. And just to look at the role of relapses in driving worsening, so this is raw. And so, and you look at the full data set, just the hazard ratio of a relapse in the 1 year prior or 2 years priors indicates the increased risk of worsening over time. So relapses still matter. oops, that stopped working. There we go. And then when you look at how long it takes people to transition from various things like EDS 1 to 4, 1 to 6, and 4 to 6, and look at it in individuals who have relapse-associated worsening, it's the slowest. A little faster, but not a lot, people who have PIRA with relapses, and then without relapses, rather. And then people who have both PIRA and relapses transition the fastest to all of these metrics, although the effect is seen less well in going 4 to 6. And the risk factors for incomplete recovery from relapses in all of the data set, disappointingly, only were the disability that you had pre-existing entering the study and older age. So relapses in 1 year increased the chance of disability by 31 to 48%. PIRA starts early in some patients and count for about 50% of the disability worsening in relapse and remitting patients, but it's still a small percentage and becomes the dominant driver of disability in progressive MS. The principal risk factors are for further disability accumulation or prior disability and older age. And I didn't show you the data, but using disease-modifying therapies of all sorts delayed the disability of accrual by years. So here's one of the problems with defining PIRA, and that is you have to pick a period after the relapse when the effects of the relapse no longer are seen. And this paper by Marcus Koch using CombiRx data showed that, in fact, improvement from a relapse goes all the way out. Look at this. There's the 50% line, and you get to 50% at 4 months, and even at 6 months, you're still seeing people improve, and actually improvement goes on out to a year. So all of that is raw, although in every definition you'll see of PIRA right now, it stops at either 3 months, sometimes 6 months. So the definition makes sense. And then this idea of PIRA focally is taken up nicely in Stephen Krieger's swimming pool metaphor, where all of the worsening is focal, just relapses or relapse activity that doesn't reach the surface, which is the clinically relevance. And then over time, as this surface drops, the effects of those relapses become expressed. And then we look at how durable are our metrics, and this is of some importance as well. So if you look at, for example, 6-month confirmed disability worsening, which is looked at in many trials, and is much better than the 3-month confirmed disability worsening. And remember, I'm saying confirmed disability worsening, not confirmed disability progression, because that's the wrong use of the term progression. But anyway, if you look at that, you see that in individuals either who have had a relapse or have not, 42 to 43% of them will improve after that 6-month worsening, which makes that not a great metric for looking at disability. If you look at people ever reaching EDSS-4, you still have significant numbers improving. Reaching EDSS-6 is fairly hard, and not that many improve. And having 2 confirmed disability worsening, having 1 reset, having a second, actually gives you a much higher number of individuals that don't revert back to a better score. And so this is work from Samita Satyanarayan in our group, looking at PIRA and also, up here at the top, PIA, progression independent of activity, which means both relapses and MRI activity. And you can see that, at least in this group of relapsing remitting patients, that the number goes down when you look at how rigorous it is you define a relapse. And that's another part of PIRA independent of relapse activity. How'd you define the relapse? And if you want to find true PIRA, then you need to use the least stringent definition of a relapse, and that's what's over in this far right column. This was a relapse, again, from CombiRx, that anything the investigator called a relapse, plus the confirmed ones, was included, and it lowers your numbers. Same thing with lowering the numbers for NIDA. How much does it matter? Well, we have the potential to reduce relapse rates to very low levels. And I'm going to actually talk about this a little bit later on when we talk about BTKs. If relapses have no effect, then we'll continue to see high rates of disability develop independent of relapses. That is, high efficacy agents and bone marrow transplant. If they're only treating the relapsing part of the disease, will we see an effect? And that hasn't been the case yet. So we do need therapies to address progressive disease, but the earlier disability occurs, the longer one is in a more disabled state, and that's a quality of life. So we talked about irreversible and reversible PIRA. And so we're starting to think about this in a dynamic situation and looking at MS in phases. I'm still wrestling with the concept of the term MS as a continuum. My problem is the continuum suggests some directionality, and I think that has to be addressed, because one of the things we're trying to avoid when we redo these clinical courses is being locked in. So, for example, right now, once you are called secondary progressive, you can never go back, right? You could stop activity, you could stop progression, but you'll always be secondary progressive. And that concept has been criticized, and I think that that's correct. And so we might start thinking about relapsing phases, progressive phases, stable phases, repair phases, inflammatory phases, whether it be adaptive or innate, and degenerative phases, and think about that in the populations that we include in clinical trials. Now, real quick, I'm going to talk about the MS prodrome, because this is really kind of interesting, and that is there are a number of factors that are going to lead to MS, right? Some of them are genetic, we know that. Some of them are viral exposure, like EBV. It mentions vitamin D here, although I must say I'm not that impressed with vitamin D anymore. But then when you looked at individuals, and this comes from healthcare data sets in Canada, it turned out that shortly before they were diagnosed, or a period before they were diagnosed with MS, there was more hospitalizations, more physician services, and more of issues like psychiatric disease, visits to psychiatrists, mental health issues, non-specific for MS, but it raises this idea of, is there a way for us to start looking at people even earlier? And someone asked, how often we should get MRIs, and so we're not going to MRI the entire population. Even though there's people out there, this is what RIS has shown us, there's people out there who have the earliest stages of MS. But perhaps if we combine some of the risk factors that we're seeing, like hospitalizations, visits, psychiatric morbidity, HLA typing, EBV exposure, we may be able to pick out populations that are appropriate for MRI screening, just spitballing that. And so when you think about what we have here, you have the susceptibility at risk, both genetically for autoimmune disease, you have the biological onset of the disease, which we usually don't see. You have the prodromal or nonspecific symptoms, and then you have manifest multiple sclerosis, and RIS probably inside there, if anyone looks. That is, you have to do the MRI. And there's the RIS, which may show up at any of those points in time. And so things that we're thinking about now are looking at MS as relapsing forms or PIRA-predominant forms, and that's getting into one of our big unmet needs, whether they're stable or worsening. And if they're worsening, is it raw, or is it PIRA, or is it both? And then this shows you a little bit of the dynamic phase of looking at this dynamically over time. And this comes from the National MS Society, and Alan Thompson put this one together of looking at people, again, in phases and looking at the clinical course in a more dynamic way. So we're sitting and noodling over this still. We're thinking about it, and over the next year, we'll be doing more with it, of looking at reversible PIRA, irreversible PIRA, and trying to stage disease in a much more dynamic fashion. And then ultimately, we want to have more biologically based phenotyping. And this probably is a little hard to read, but using the MRI as a radiologic biopsy, looking at chronic active lesions, you've heard about those, slowly expanding lesions, paraneck rim lesions, atrophy, both focal and diffuse, and also MRI metrics of repair, Fluid biomarkers, you heard that they're not helping us a lot just yet, certainly not specific. They may help us in measuring effects of therapy or clinical course, perhaps. And then pathologically, we're not going to be doing biopsies, but we will try to characterize the type of inflammation by immunophenotyping as to whether you see adaptive markers, innate markers. Innate might be hard because it's within the central nervous system. And then looking at how much degeneration there is and whether it's axonal or neuronal or both. And then what kind of repair strategies are there. We know that that changes over time. And then I think the most exciting finding of the last couple of years was the genetics of severity. So there are susceptibility genes, like, over 220 of them. None is necessary or sufficient. But now there's a couple of genes that measure severity, which are different from the susceptibility genes, which means that, A, you're going to inherit the ability to develop, the tendency to develop MS, but independently how severe that disease will be. And this is going to be of really, really great importance. And I urge you to read those papers. It's very interesting. And with that, I thank you for your attention. And we have time for a few questions. So thank you very much. Let's see here. Anyone in the audience? I know I'm keeping you from your break, but. Pat?
How fulsome is the data for reversible cure? In other words, how long a patient can be followed to truly document that they are stable or
Well, so that's a good question, and so it depends on what data set you looked at. So some have looked at clinical trials, which are only going to follow them 2 to 3 years. Some have been observational ones, which have followed longer. And so it's a key point because this idea of people who improve is very different from the ones who never improve. And so it's a variety of data sets. I think the Novartis one I showed you follows out longer periods, and the Barcelona group with their CIS population, they followed for a very long time. Okay, there is a question here. It says, what strategies could be used to standardize the definition of disease progression and worsening in observational studies and clinical trials? Well, so they're different. And I showed you from that Novartis database some data showing that the results are different. Clinical trials are more rigorously done. The assessments are standardized and frequent. The shortcoming of the clinical trials, randomized clinical trials, is they're short, right? They only go out 2 years. Maybe you have 3 years worth of data until everyone finishes up the trial. Observational studies have the advantage of much longer term collection of data, but the disadvantage of non-standard accumulation of the data, potentially missing relapses, different definitions of both relapses and worsening. So ultimately, we have to integrate both into our discussions and take advantage of the benefits, but keeping in mind the pitfalls. Okay, any other questions? Okay, we're going to take a break, and we'll be back at 10 o'clock. Thank you so much. Okay, we're going to reconvene. All right. Stephen here? Ah, okay. Okay, please have a seat. We will continue. We're doing great on time. Next talk is going to be a review of treatment strategies with the current agents by Dr. Stephen Krieger from Mount Sinai. Stephen.
All right, everyone. Nice to see all of you. Many familiar faces, some new faces, so welcome. I have the almost impossible task of welcoming you back in from the sun to come back into this dark room and press on in multiple sclerosis. I've also been given the task of trying to cover how we treat MS with our existing medicines in 15 minutes. So it's a little bit like trying to summarize our life's work in no time at all, but we'll see how we do. Before I get into how we treat MS, principally relapsing MS, let me take a step back, build a tiny bit on what Dr. Lublin left us with, thinking about the importance of relapses, these distinctions between relapse-associated worsening and PIRA, and I'm going to pose a provocative question for you to start the session. What if all the disability accumulation that we see is ultimately relapse-associated? Here's a graph from work done over a decade ago that showed that in the first couple of years of someone's MS disease, if they had 1 relapse, 2 relapses, or 3 relapses, it changed the trajectory of their likelihood of accumulating disability. We know that. It sounds obvious. If someone has a few relapses, well, that's worse than someone who didn't have a few relapses. But what's interesting about it is you look at the time scale here. This goes out 20, 30, 40 years. None of those relapses caused these patients to need a cane in the first couple of years. It led to that decades later. That is to say, early relapses forged the disease topography, the burden of that patient's disease, which later, I think, becomes unmasked as reserve declines and all of that existing lesion burden becomes manifest as progression. Why am I putting this slide up first? It is to say, so many of the other things we're going to talk about in my talk and many of the other ones on disease-modifying therapies are all about preventing relapses. And if preventing relapses were just trying to spare our patients a bad week or spare them 5 days of steroids, I don't think there would be nearly the importance and the emphasis on our treatment decisions as there rightly is. The reason we have to choose our medicines wisely, treat this disease proactively, is because of this. Because by preventing those early relapses and lesions now, we prevent disability down the road. So how do we do it? Again, I've been tasked with talking about all of our medicines in no time at all. So this is the scheme I've created to try to do it really quickly, to kind of replicate how MS doctors think, to use that line from Dr. Berger's talk earlier. So here's a quick summary of our therapies. We could organize them by mechanism and say we've got selective immune modulators, non-selective broad-spectrum immune modulators. We have medicines that block the movement of our cells, the migration blockers. We have specifically the S1Ps that do that at the lymph nodes. And then we have medicines that deplete cell populations. And here's a list of them. Not an exhaustive list. We'll come to that. Then we can think about how they're given orally, injections, infusions. We can think about how often our patients must take them. And then comes this. How we conceive of efficacy, safety, and tolerability with respect to each other. And here, because we don't have head-to-head trials of everything, This really is a question of perception. How do we perceive these drugs to work and be effective in comparison with each other? And so here's a very rough schema for safety, efficacy, and tolerability. And now we can debate all day why one drug gets 3 pluses and another one gets 2. It's not the point. Let's just think broadly about classes of safety, efficacy, and tolerability as we decide which medicines to use. And then finally, how well do we know these drugs? Some of these have been out since the 90s, some are much more recent, and I will add that we will talk about the newer therapies, at least briefly. Some of my colleagues will talk in more detail about the nuances amongst S1P modulators and B-cell depleters, but I will give a little bit of a nod to our current generation of agents. How do we align all of these treatment opportunities with our patient? Well, first of all, I dropped mechanism of action off the list here because in truth, we really don't sit down with our newly diagnosed, relapsing remitting MS patient in the office and say, do you feel more like a migration blocker or do you feel more like a cell depleter? We just don't. We're not there yet. We have to make our decisions on the basis of the things that I have here on the screen. So how do we think about this? What do we actually do in practice? Consider a patient presents to you after a pyramidal relapse with weakness, a high burden of lesions in the brainstem and spinal cord. Are you worried about that patient? I'm worried about her and her prognosis. Or consider the patient who maybe you're not that worried about, but the one who sits down in the office when you're there to talk to her about disease-modifying therapy, and she says, I'll do whatever it takes to fight MS with everything you've got. Don't waste my time talking about ineffective medicines, because that tells you about the person's value system. So here, you've got an example where your value system says, I'm worried, or a patient and her value system says, I'm worried. Let's hit this thing hard. If that's the case, I circle efficacy here because then you're going to rank order the treatments at your disposal by which ones are going to be most effective. And in your mind, you shuffle around the options and you rank them bottom to top. By which do you think are most powerful? So here, a few medicines rose to the top. Alemtuzumab, ocrelizumab, natalizumab, and as I said, we're going to get into some of the more modern versions of these down the road. Take these as paradigms for how they work. Now, in truth, we don't just put everyone who we are worried about on one of these medicines, but it gives you a little bit of a structure, how you can pare down the list so that you're not overwhelming your patient with 25 options when really only perhaps 4 or 5 of them apply. That patient leaves. The next patient comes in, she sits down. She has an EDSS of 0, a normal neurological exam, though in other papers I've poked at the EDSS 0 concept to say there's actually more there than meets the eye. But someone you are not so worried about. The MRI scan, consistent with MS, but barely meets McDonald. So here you've got a patient that you are less worried about. On the other hand, perhaps you have a patient who comes in and says, well, I have multiple sclerosis, but she also has diabetes, hypertension, some liver disease, she has a history of breast cancer, and now you're trying to navigate around all those comorbidities because the MS is in some ways the least of her problems. And we don't want to use a medicine that's going to exacerbate or be otherwise incompatible with her medical life. In both of these circumstances, the mild patient or the medically complicated patient, now we might prioritize the safety of the drugs. Now we're going to think, how can I treat this person, but do so in a way that brings the least risk of harm? And in that circumstance, we might reshuffle these medicines in a totally different way and think about many of our oldest medicines, glatiramer acetate, the interferons, medicines that frankly never killed anybody. We could think about a medicine like natalizumab, and if you're paying close attention here, you'll notice that natalizumab actually split into 2 in this table. I think of natalizumab as two drugs. In a patient who is JC virus antibody negative, natalizumab is a very effective and very safe medicine. If someone is JC virus antibody positive, well, natalizumab is still very effective, but its safety drops way down because of the PML risk. So I really do imagine natalizumab as two agents based upon whether that patient before me is JC positive or negative. So you could divide this up in this way, prioritizing things that you think are safe. Your next patient, though, is totally different again. This is someone with a history of non-adherence to medical treatments, self-proclaimed, I'm really bad about taking my medications. You're sitting there listening to this and you're trying to imagine, how can I make sure that the drug that I've got is really going to be in the person, doing the work that it needs to do? In this respect, I might think about frequency and route of administration. I might say to myself, if there's a patient who is not good at taking her medicine or his medicine, what can I give him that's going to get in his system and stay there? And here we have medicines like oral cladribine given in yearly cycles, where someone does not have to worry about taking their treatment after that cycle is complete. We could think about alemtuzumab, an infusion in a yearly cycle, or ocrelizumab, an infusion in a 6-monthly cycle, and second generations of that as well, like ublituximab. We have options. What I wouldn't do is take a patient who is averse to taking medicine and bad at it, maybe has cognitive limitations and is likely to forget to do it. I probably wouldn't have that person take a medicine that he has to take 2 times a day, every day, because that is going to be a recipe for somebody not getting the medicine that they need. For many years, what we heard over and over again when we would offer the injectables, when we only had them, was, I hate shots, what do we have? Now, sometimes people are told about infusions and they recoil. They don't want to be in an infusion center. They don't want to feel like they're sick. They don't want to see other people who are ill. And here, route of administration, I think, becomes really important, because if somebody has an incredibly negative feeling about the medicine that they are committing to taking, they're never going to be happy on it. They're perhaps never going to take it. And they're never going to associate it with positivity and positive outcomes. And honestly, I think that's really important for people with a chronic condition. So route of administration becomes important. For many years we heard, Doc, when are we going to have pills? And then we had pills, and things only got more complicated and not easier. Nowadays, though, we have an array of pills, and they're not even all listed here. As I said, some of my colleagues are going to talk more about the newer medicines and their nuances, but we have pills that work in different ways, have very different treatment regimens, of different comorbidities that we have to navigate. So if somebody only wants pills, we don't have to commit them to one thing. We have a range that we can further divide to meet that person where they are. Now, you heard from Dr. Lublin that progression takes a lot of forms. It may start early. It doesn't happen in everyone. But if you have someone with relapsing, remitting multiple sclerosis, you're treating them for RRMS, and they tell you that their gait is a little slower, their endurance is going down, maybe they're more fatigued, perhaps their cognitive clarity seems to be blurred, you kind of know in your heart that they're beginning to progress. And what you do with that information is extremely broad. I don't think any two people in this room would necessarily have the same answer. But if you know that it's happening, this implies for you the beginning of progression. And there, you could start to think about where there's data for these medicines in progressive forms of the disease. Ocrelizumab still carries the approval, the only approval for primary progressive MS. In the trials, oral siponimod was studied for secondary progressive MS. I still had mitoxantrone there, but we don't really use that, so I'm going to just pull that off the list. And then, as you heard from Dr. Lublin, the active secondary progressive MS designation was arrived at around the time that oral cladribine came out. It was then applied to many of our other medicines, but you could start to think about where the data is for progressive disease. So I'll pull away from that paradigm, which is the bulk of my talk here, and say, in that brief period, you saw 5 or 6 different ways to shuffle 20 medicines to give your patient a reasonable number of choices. I don't think anyone can process 20 choices at a time. And to be honest, I think it's our responsibility to guide people along these lines and many others to have a smaller number of options that they can parse amongst. How else can we do it ourselves to make for the best treatment strategy and recommendation? Anytime I'm thinking that we're going to have a disease-modifying therapy discussion, I send this panel of labs. It's simple, but it allows us to risk stratify people for common infections early on, which can sometimes narrow the field of choices. The JC virus antibody and index, which is essential for natalizumab, the data for predicting PML is only germane to natalizumab, but we think about PML risk with many of our other agents. We look for exposure to tuberculosis. I make the joke that I'm in New York. Anyone who rides the subway in New York may very well have tuberculosis, so we screen for it. We look for VZV immunity, we check for hepatitis, and in appropriate patients, or if you're thinking about cladribine, you check HIV. It's a nice little panel, but you get that back, and it may help to narrow your choices down. Certainly, if someone turns out that they have tuberculosis, it has implications for how they need to be treated before you treat their MS, which has happened a couple of times in my practice in just the last 6 months. So I send this off at the very beginning. Honestly, if you're in residency, you're admitting your patients to the hospital, you're doing an MS workup, you get the scan, it looks like MS, send this panel off immediately. You're gonna need it. It may not influence the decisions you make during that patient's 4 or 5 day hospitalization, but that information is going to be essential at their first follow-up visit when disease-modifying therapy decisions have to be made. So we try to do this almost on admission when you're diagnosing somebody with relapsing MS. So I said there'll be more on these newer agents in a minute, but it would be incomplete to not talk about them. So I want to make sure we cover a couple of things. We're living in an era of version 2.0, or in some ways version 3.0 of many of our treatment strategies. So first, in the S1P receptor category, we had the first oral agent, which was fingolimod. And now we have children of fingolimod. This includes an orally dissolving version of fingolimod. And I do have the brand names on here because otherwise it gets incredibly confusing, but I'm going to try to refer to them without it. We have the more selective S1P modulators that have come out over these last few years. Siponimod, which was studied in secondary progressive MS. I think of that as its distinguishing feature. We have ozanimod, which was studied in relapsing MS, which is somewhat simpler to start without a first dose observation, without a macular edema screen. These were things that were a really big deal when fingolimod first launched. There's also ponesimod, which came and went on the market in multiple sclerosis, but maybe it's still around, so I have it on there for reference. We've had fumarates now for a decade, the parent compound being dimethyl fumarate, approved 10 years or so ago. Sons of dimethyl fumarate include diroximyl fumarate, which seems to be more tolerable from a gastrointestinal perspective. There's monomethyl fumarate, which was approved based on those DMF studies. There's also generic dimethyl fumarate, which seems to be a real favorite amongst insurance companies in the United States. And then, of course, I said we have anti-CD20s, ocrelizumab being the one that is approved in multiple sclerosis, and then we have children of ocrelizumab. So ofatumumab, studied in relapsing MS towards preventing relapses and lesions. This is a once monthly sub-Q injection. So that's an interesting one, I think, because here we have 2 medicines that work with the same mechanism, anti-CD20, but are delivered in totally different dosing schemes, infused every 6 months versus injected sub-Q once a month. and you can guide your patient to what they're going to be most comfortable with. And most recently, ublituximab, approved about a year ago, right around the time of this meeting, also studied in relapsing remitting MS towards preventing relapses and lesions. All three of these agents have very similar, brilliant efficacy numbers. Ublituximab distinguished by being a 6-monthly infusion that can be given more quickly. So now we've got an entire class of medicines in the CD20 realm. So in summary, again, trying to, in essence, encompass most of my work in 15 minutes, trying to align prognosis, our sense of prognosis, safety, and the patient considerations. How do we do it? Consider distinguishing the prognostically mild from the prognostically concerning cases. You're not going to be right 100% of the time, but you do want to think about the risk factors for poor prognosis and try to meet that disease where it is with the strength of your treatment strategy. You want to distinguish relapsing from progressive MS, which, as you heard in Dr. Lublин's talk, is easier said than done. There is an enormous amount of overlap. How you define whether disability comes from relapses or comes from insidious progression is tricky and it's nuanced. But you want to be open to thinking about in what way is your patient stable and in what way is your patient worsening so that you can try to adjust your treatment strategy to that. You need to identify and navigate comorbidities. Many people that apply to become multiple sclerosis specialists who apply in the MS fellowship match talk about wanting to be cutting edge, but also wanting to be broad spectrum doctors, great clinicians. It's what I wrote in my personal statement 18 years ago, still true. You still have to be a really good doctor and take a thorough history, know the comorbidities, know what you're navigating around in order to choose your medicine safely and well. You need to screen for infectious risk and watch for them. It's really important. None of us are going to treat MS without, at some point, causing or seeing some type of infection that we might not otherwise see. You need to be attuned to that. And then, I didn't talk about it here, but we think about aging and immunosenescence. How we treat a 27-year-old is not going to be the same as how we treat a 57-year-old. So we do need to balance that as we choose our strategy. And then finally, this seems like the soft stuff. Take the patient's preferences into account. It's not the soft stuff, right? You really have to focus on it. When you're presenting treatment options to your patients, look at them. Look at how they're responding. Think of everything you say about a medicine as an opportunity to gauge what your patient thinks of it. This is their decision too, but you've got to be really attuned to it. If you're just running your script, saying everything you came into the room to say about the disease-modifying therapies, you're not having a conversation. You're not taking their responses and their preferences into account. Ask about issues of adherence. Ask about their treatment goals. Ask about lifestyle planning and family planning considerations. Open that conversation up. Sometimes it'll surprise you, and it's going to be crucial information for you to choose treatments that are going to be aligned with what that person needs. That is my approach to my life's work in 15 minutes. Thank you, guys. No questions? Panel discussion later. Hold your questions.
Okay, moving on. The next theme, we'll have Dr. Mark Friedman from Ottawa discussing therapeutic transitioning and sequencing. Welcome, Mark.
Thank you, Fred, and thank you, Stephen. I knew that you would set this up for me, and I wouldn't have to get into a lot of the details that you've so nicely already outlined. So I actually think of this talk as part B of what Stephen has presented to you, because he talked about the initiation of medicine. And what I'm going to talk about is the transition in sequencing. And basically, I'm acknowledging the fact that whatever you've chosen to begin with is probably not going to work in most patients because we don't know what mechanism is driving the disease in any one individual, and that can change over time as well. So you make a reasonable decision using really all the methodology that Stephen outlined. But at some point, you have to be on guard that maybe this is not going to be working to the 100% that you were hoping for. And so that's really what I'm going to talk about. The issues around transitioning are very similar to the same issues about initiating the first therapy. So a lot of the things that he has nicely outlined, the kind of disease, how efficacious you want to make it, how risk-averse a patient is, this is all very important. In fact, I would say that one thing that he missed was whatever you choose today might actually influence the next choice. And that's key, because although you may have gone for, say, a very efficacious agent, that may have carryover risks depending on if you have to stop that agent due to intolerance or whether or not you're thinking of, well, what am I going to use next? So this is very important to consider the two together. I'm going to choose a medicine today, but if it doesn't work, what's plan B? And there's also not only, to address the inertia that oh, well, let's just stay the course kind of thing, because that was our feelings 20 years ago when we had one or two agents, but now we have many different agents, so there's no reason to accept a poor outcome. And how do you decide that? And I'll get into that a little bit. And at some point, if you have chosen something that may be conferring increasing risk with the longer you use it, consider the possibility that the disease has changed and you may want to de-escalate to something perhaps safer and that could be maintained for a longer period of time. And then as Stephen just at the end talked about, well, what about the aging patient? What about the person who's been on disease-modifying drug for 40 years, hasn't had any activity in the last 10? Do we want to keep giving them medicine into their 60s and 70s where other problems tend to ensue? I'll touch on that a little bit. And everybody's got their little diagram, so this is mine, and it's very similar to what you've already seen. But the whole idea is everything above that pink line, people are aware. So patients are aware of symptoms. You, the clinician, are aware that something has changed on their examination. And we know that demyelination comes and goes. And in some of it, if you look way, I don't know, there's no pointer on here, but the very, Oh, the mouse. Okay. If you look over here, clearly demyelination has occurred under the clinical threshold. The MRI tells you it was there, but it didn't produce any symptoms, right? How many times have your patients said to you, oh, I got a new lesion. What was that supposed to cause? What should I notice from that? And most of the lesions are in fact asymptomatic. So the first time it crosses the clinical threshold, patient's aware of symptoms. We often make the diagnosis. That's what was referred to as CIS, which doesn't necessarily even exist anymore. But we can at least say something has happened. We know, though, that whatever is driving the death of the neuroaxonal structure is not something that starts late. It's something that you see once it crosses the clinical threshold. But in fact, it starts here. And this very elegant, ancient paper now by Bruce Trapp showing these axonal transections that he somehow coerced a medical student to sit and count in sections and showed that most of these axonal transections occurred in the early active inflammatory plaques. So it's really, the damage is building, but at some point, because of redundancy, plasticity, attempts at repair, it's delayed, and then at some point later, we are appreciating all that damage that has accumulated. And that brings to concept what's driving this, and it seems to be correlating with inflammation. This type of inflammation that you can see that often leads to attacks, new MRI lesions, but even that dissipates with time. So at some point, the inflammation that's driving all that, which is the target of the majority of our medicines, is no longer the dominant feature, which raises the question as to why we're continuing to use medicine that's addressing inflammation if inflammation isn't driving this. This concept of reserve, so elegantly displayed by Stephen's water tank and the evolution, that's, I think that's such a beautiful way of looking at this. But it's important because as your ability to fight this off dissipates, every attack then becomes more likely to lead to further detriment. And that's why attacks tend to matter differently in different patients at different times. So you're losing this cognitive and other type of brain reserve with time. Time is really against you with MS. And so I think of this window of where you're going to treat this disease with anti-inflammatory medications is probably starting around the time of the first clinical attack. That may change dramatically later this year with the new McDonald criteria, but I'll say no more about that. And probably starts to end once the axonal transections are becoming so manifest and the inflammation is dying out. The question is, what are we really doing with the medicines? And clearly what we need is what Jeff Cohen's going to tell us about in the next talk, which would be something to repair. So as we think of our patient, and this is true for the beginning strategy, the first choice, it's the same is apparent when you think about switching. You want to know where the patient is in this window, because if they're still very early on, then you've got time. But if they're late, you have no time, and you may choose differently for this. So let's get into the considerations here. The initiating treatment, you've heard about that. How do you choose that? And whatever you've gone with, it's very important then to say, how am I going to evaluate it? I get this question all the time. Okay, so how do you know it's working? Does anybody here have an answer? How do you know it's working? You gave it. What is your expectation? I can tell you the patient's expectations are a lot different than yours. But you have to decide what is really driving efficacy. And then if it's not meeting those whatever goals that you've set out, hopefully they're realistic ones, then what do you do? And what are the kinds of considerations that are taking into effect? How are you going to optimize this strategy? And you're thinking, I gave them this. If I stop it, are there any repercussions? Some of these drugs are associated with terrible rebound disease that you've got to think about covering before the next drug. What about, are there cumulative risks? Do I need to wash out? Do I need to wait a while? Or is there actually an antidote to the medicine? Do I put the patient through that before I go to the next drug? These are all important considerations, right? You still want to try to get optimal disease management. We're acknowledging that not every drug is going to do that in everyone. You also, and this is an important one to consider, you don't want to limit future possibilities because you've put them on that drug. Some of the cell-depleting drugs have very long-lasting effects on lymphocytes. And if your next product requires you to have a normal lymphocyte count, you may be in trouble by the choice of the very first one, right? And think about compounded toxicities. We don't see a lot of this today because people aren't following, but there are some examples of drug A leading to a problem if you then gave drug B. And then, really this is, the sentence at the bottom here is just saying, acknowledging the fact that most people are going to have some degree of breakthrough, and then you have to decide how much is too much. And that concept is not new in medicine, right? I draw a similarity to, say, diabetes, right? You're not curing diabetes, you're managing diabetes, and you have markers to indicate whether the management is working. The development of complications, of course, but also you got this little biomarker called serum glucose. So if the glucose or the hemoglobin A1C goes off the wall, have you lost the battle? Or do you need tighter management? So you're not going to keep every one of those values perfect, but you haven't lost the disease, so you just have to change a little bit. And so this is kind of what I'm getting into in MS. Now, you've heard about this from Stephen, so I'm not going to go into this again, because these are all the kinds of things that come into the consideration of the switch drug as well as the initiation drug. It's important, you know, obviously the use of immunosuppressants puts you at higher risk of PML if you go to natalizumab. So these are the kinds of things you have to think about. JCV antibody status, patient planning a pregnancy, very important. You heard about the example of somebody who doesn't adhere to regimens very well. The likelihood is that they won't adhere to regular blood draws if you are requiring this for safety purposes. All of these factors are in consideration. And then there's this other little metaphor I like, which is the patient falling off the cliff. And this abyss is really the progressive disease. That's what we're trying to prevent them from doing, falling off that cliff. And much of this whole perspective of how do you figure out a patient's prognosis is based on whether we think they're right here, about to fall, versus way back here. And if they're way back here, probably you have time to pick a safe agent first, evaluate its treatment response, and still have time to escalate to something that is more effective but also carrying some risk. Whereas this person here needs everything yesterday, and that's really important. Most cases today of MS are not aggressive. You have patients who feel that they are because they have many other symptoms that may have no relation to the actual disease load, and they see themselves as very fatigued and expect that this drug is going to change all that, and of course it doesn't. But if you had to define aggressive disease, and by the time you've had a little experience in an MS clinic, you can almost pick out these people as they walk in the door. You got a sense of what's happening almost immediately with them, the way they walk, the way they talk, the way they think, the MRI burden of disease, their neurological exam. You know that they're in that very small but definite 10% of patients who have a very aggressive picture, and they warrant a much more aggressive approach. I won't say anything more about that. So we have this notion of NIDA, which is no evidence of disease activity, so no relapse, no progression, no MRI. And I jokingly say the best way to make your patients NIDA is to never see them again, because they have no evidence of disease activity. But honestly, if you followed patients in a clinic, as they did very nicely, my colleague Dahlia Rothstein, when she was down at Harvard, looked at that CLIMB database, and it doesn't matter what you treated them with, by the time you follow these patients out 7 years, even longer, everybody is no longer NIDA, because something's going to happen in just about everybody. And so this is unrealistic. It's utopia, sure. Give the treatment, absolutely shut down disease, wonderful. Never happens in real life. And so how do you then monitor for a treatment response? So I won't get into initiation, because Stephen basically already introduced this, but how do you determine the way you're going to monitor them? So we put this together a few years ago, and I think it's still very valid today. This is the Canadian Treatment Optimization Recommendations, where we looked at, okay, poor prognostic factors are here, so the more of these you have, the higher the likelihood that you're going to probably fail the first drug and that you're going to progress much earlier than someone who doesn't have these characteristics. And on the right-hand side, these are things that can modify the prognostic factors. And these are important because there's something you can do about them. So these comorbidities are treatable, and it's important not to ignore them. Obesity, we can deal with, right? It's tough. You can just leave that to the GP to figure out, but I think it's really important, since you're managing their MS, that you have to at least point out that certain comorbidities that are modifiable can impact not only how this disease progresses, but probably how effective the medicine is that you're going to choose. So get them off their cigarettes, get them on a diet. These are very important. Treat their blood pressure if necessary. Certain genetics, obviously, you're not going to choose, and I'll come back later and talk to you a little bit about NFL, although Pat introduced that concept to you earlier. So way back when we had these dials, and we said, you know, how do you rate a relapse, and how do you rate a progressive disease, and then how do you rate the MRI changes? And we hypothesized that, you know, if any one of these gauges read high or any two of them read medium, that sort of thing. And I think there's another dial today, and that's probably the serum neurofilament light chain. And it's really part of what we do every day, at least in our clinic, and very, very quickly growing across Canada as a way of monitoring the disease. So this sort of scheme is there for escalation. So if you're looking at this algorithm and following it along here, this on the left-hand side here is the level of concern. What concern do I have about this patient having a very quick progression or likely to fail first medicine? And if it's low and they've already had this event while taking what I call a first-line drug, which are orals or the old injectables, if it's low, then it's all about tolerance and safety. We could pick another one of these amongst the group. But if the level of concern, and that can change, you may start out having somebody you thought was really benign, EDSS 0, low lesion load, and then over time they break through, and all of a sudden they've had a big attack, and their MRI lights up, and their NFL goes high. Oops. Okay, we acknowledge the fact that this patient has just shifted their prognosis, and I'm going to choose differently. And then there's the possibility that if you feel that that's a permanent state, you will stay on those higher efficacy drugs. But if you think that that's changed or there's safety issues for maintaining the drug, you have to consider the possibility that it's a temporary escalation, 3-5 years maybe, and then drop down to something else. And if that doesn't hold it, then you're automatically going to the third tier where you're pulling out all stops and trying to stop the disease accordingly. So this is all about what we say of treatment optimization, and we created some criteria that were based on all the data we could find in a kind of series review, and we published these tables. We said if you had at least one major criterion, that's enough to switch medicine. Minor criteria, you would need a few. So this is sort of an approach. I'm not telling you this is the one you should adapt, but I can tell you that we did that in Canada. I believe there's an approach that's been published by the American Academy. Our European colleagues have had their own approach. And we basically said, here are the characteristics that you're going to look at. So to go back, how do you know if the drug is not working? Well, the patient's had an attack. So clearly it wasn't doing its job enough. But some attacks are probably less worrisome. Somebody who's had a numb hand, you can't find anything on their neurological exam, the MRI showed no change, but you had acknowledged the fact the patient's had some new symptoms, that was probably an attack. You didn't even bother treating them with steroids. I'm less worried about that kind of attack, right? But one that knocks them off their feet, takes out their bladder, requires steroids, maybe they have to be hospitalized for a while. Clearly, that has a different impact than the other. So these are what's considered the major events. The attack, how many you've had, how it's affected you, what kind of functional impairment, and most importantly, if you're going to treat attacks, it's absolutely mandatory, I think, that you bring the patient back in 3 months and see what has happened. Did they recover? Because their inability to recover from attack is already telling you that reserve has moved down and they're going to succumb from another attack if you let it happen. So recovery is very important. You're looking at their capacity to repair. And Jeff may get at a little bit more of that when he talks next. Then, where about the MRI, and how often do you do it, and what sort of criteria? I mean, if you're going to say, oh, if I see one new lesion, that's it, you basically might as well go home, because you're going to go through every single drug there is out there, because there isn't one that stops all lesions from forming in everyone all the time. So you need to be at least somewhat reasonable in that regard. And the data's been out there to show how many numbers might be important. But it's also important to know when to look. So if you started a new therapy, when would you do the first MRI to show whether or not it's efficacious or not? So that was really important, to have some idea as to when the drugs are going to be effective. Because if you look too soon, it's kind of like if you were treating epilepsy and you knew it took, say, 4 to 6 weeks to hit steady state level of your drug, and the patient had a seizure at week 2. Would you say your drug is inefficacious? Of course not, right? So when would you look? So the whole idea here is to get a new baseline of your MRI if you're going to look forward. And that may be also true of getting the serum neurofilament light chain, because you want to get it away from the attack, and you want to get them at a baseline. And so this little table that we published is actually kind of useful, because then at least you know when to re-baseline and when you would expect to see then benefit at following them with MRI. And so what has been shown is, once you're on therapy, and this is old data and it needs to be redone, but even I think the Magnum's group came up with their own rules. It's not one lesion. So in this case, 3 or more new lesions, you have to be convinced of that, within a year of starting a therapy, in the absence of clinical, because as soon as you have clinical, it changes everything. In the absence of any clinical symptoms or signs, probably is enough to say, okay, maybe we can do better. And, to be clear, 3 new lesions is not common. And you have to be sure they're new. So obviously, if they're gadolinium enhancing, they're new. But they could be new T2s, but all of that depends on the scan that you had before and how comparable they are. And I can tell you they're more oftentimes not comparable than they are. So if you see a new spot, was it really there a year ago? I don't know. Was the cuts the same? Did we get the same angle? So it's got to be pretty clear that those are new T2 lesions. I know that people are saying, well, you got to look at the spinal cord. We know how poor the imaging is, especially below the neck. And so it's going to be very hard to make decisions unless it's obvious. But I mean, as a neurologist, if you can't tell when a patient has spinal cord lesion, seriously, I mean, they're going to have signs and symptoms almost every time. So this is where this 3 new lesions came into effect, and this is in the absence of any clear symptoms or signs. I talk about NFL, and I think Pat had these figures, and they do need to be reproduced, but one of the criticisms of the NFL story has been that all the data that was generated was group data based on retrospective analysis of clinical trials. That was true up until recently, and this publication out of the Harvard group showed, following their CLIMB patients again, that's the CLIMB database, they followed these patients with serial NFL and imaging and clinical evaluation, and they saw that almost entirely, if you had a 30% increase in your baseline NFL, you had 6 or 7 times more likely to have a new enhancing lesion within 2 to 3 months. Or, based on the CLIMB database again, an NFL value of over 23 picograms. Most of these patients would have a normal NFL less than 10. So in their database, this was highly specific and highly sensitive for a new enhancing lesion within 2 to 3 months. So NFL probably is allowing us for the first time to not be reactive to a disease, waiting for the relapse to occur or the MRI lesion, but if the NFL is going up and meets these criteria, you can then be proactive and we do that. If the NFL goes up and is, I think Pat basically said it's not specific, but if you haven't got another reason for NFL going up, if you got a patient who has no comorbidities, they're not diabetic, they didn't get in a head injury or anything to cause NFL, it's probably reflective of the underlying MS. When we escalate therapy or maintaining therapy, we're always thinking of the balance between the efficacy and the safety for that particular drug for that patient. The choice of escalation is again based on where we feel that patient is in the window or the risk of early progression. So left side would be for people who we have a low risk. The right side would be for patients who are at higher risk. This came out some years ago from Heinz Windel, and he basically put together all the drugs that were available at the time and said, where do we position these on the idea of how risky you are? Okay, so the potential for a drug-free remission is highest with the drugs that have the greatest impact, such as HSCT, and lowest for the drugs that we've been seeing for years, the orals and the interferons. And you look at the severity up the y-axis. And it's an interesting concept, but it also then puts that into the, think of this table, this picture and the table that Stephen showed, and it sort of goes overlapping. Okay, so the concept of sequencing is what did you have last versus what you're going to go to. And I already suggested that the choice of the first therapy very much can impact the choice of the next therapy. And so you must plan for plan B. So you're going to have some evaluation of the treatment response. If you decide that it's a suboptimal treatment response, the thought that this is a patient who has low risk of early progression, you're going to do maybe a lateral switch. But if this is someone who has a higher risk of progression, you're going to choose some of the other drugs, such as the anti-trafficking or the immune reconstitution therapies that you see here. And the whole idea is to try to maintain or reestablish a new response, get a new baseline, and then follow the person forward. You have to think about what they were on. You have to decide if they're going to be on a drug that's going to lead to rebound. And the two drugs that are terrible for that are natalizumab and currently fingolimod, although the newer ones, which I'll tell you about at lunchtime, don't necessarily have that. You have the possibility for eliminating drugs, at least in the case of teriflunomide. There's a rapid elimination. I don't know of another drug that has the antidote, but it has an antidote. We also have used teriflunomide as a way of obviating rebound, especially if the patient is transitioning from fingolimod or natalizumab. We have this rapid load, which we presented, at least in poster form, in ECTRIMS last year. You need to get a new baseline again, because you're going to use that new baseline to judge moving forward. And then there are certain things to consider. The antibody status for JC virus confers risk for PML for natalizumab. Some people have thought it might be useful for the other drugs that have been associated with PML, which is fingolimod and dimethyl fumarate, although that has not been proven. And if you're going to move forward with any of these drugs, you have to think about some of the other things that are involved, such as the comorbidities. Anybody who's got cardiovascular disease, diabetes, they're going to put them at higher risk for the S1P receptor-related problems. If they've not been, if they've not had varicella zoster, if they've had immunization against varicella zoster, you have to check all these things before you go further. And then we talked briefly about the idea of a washout. Then I'm just going to, quickly review a couple of the things. If you're dealing with a first-line interferon in GA, basically you don't have anything to worry about. They can transition to anything without any problems whatsoever. There are some rare things that have been seen, but except for dimethyl fumarate, no PML, and in the cases with dimethyl fumarate, it's thought to be related to prolonged lymphocytopenia, although not in every case. When you're thinking about one first line to another, there's very little issue from transitioning from one to another. And from the first line therapy, the second line, also mostly quite easy to do with very little to think about in terms of safety issues. It's the second to the third line that's a problem. So if you're going to consider, for instance, a drug such as fingolimod or natalizumab, and then you're going to go to a cell-depleting drug, you got to be sure that, because of the risk of PML, that patient doesn't have JC virus swimming around their CSF. It might be a rare thing, but once you deplete somebody's immune system, that's the only competent way of dealing with PML. And so if you get rid of that immune system, you're in trouble. And that's been seen on a few occasions, unfortunately. So I think, in our center, we advocate at least getting a spinal tap to rule out JC virus swimming around. The antibody doesn't tell you anything. It's the actual virus that you want to be looking for. And then this is really a rehash, so I'm going to go quickly through this. Pretty well, you can move from most things. The big one is natalizumab and the risk of going to a cell depletion therapy and the risk of rebound. Both of these have been associated with PML, and the cases have been increasing. Cladribine, for the most part, has been quite safe. There's never been a case of PML and MS, and the only thing we have had to worry about was zoster. The ocrelizumab, and I'll get into that detail later this afternoon when I talk about anti-CD20s, are few and far between, except for the persistent hypogammaglobulinemia, which would be a problem. And you've already heard that alemtuzumab has fallen out of favor in most cases. Something to think about would be the effect on lymphocyte numbers. So I'm just throw this together here to show you that numbers may be important if you're on one drug and transitioning to another drug that requires you to have a normal lymphocyte. You want to know when they're going to come back. There have been cases, believe it or not, even though on the B-cell depleters, where patients have become neutropenic and lymphocytopenic for whatever reason. It does occur. It's important to know when the timing would be for these lymphocytes to normalize. Special considerations, or I mentioned natalizumab. There has been issues of fingolimod to alemtuzumab leading to a higher degree of autoimmunity, but since so few people are using alemtuzumab, I won't get into that. And as I told you, teriflunomide, if you're worried about a prolonged effect, if you stop teriflunomide, it's out of your system, but it takes about 8 or 9 months. If you want it out of your system faster, you can do the washout that takes 11 days. And then if you're going to go from either natalizumab, dimethylfumarate, fingolimod, these are drugs that have been associated with PML, and you're going to go to a potent cell-depleting therapy like alemtuzumab, look out if that patient has even a little JC virus swimming around. And there has been a case where the patient was completely asymptomatic, went to alemtuzumab, the PML just went, and the patient died. So it's preventable. The stratification here for PML, you can see here, from 1 to 3 being unknown. We've got a few cases that have been reported, and they keep on coming with dimethylfumarate. There's an increasing number of fingolimod. There's even been a case with ozanimod, but none with some of the other drugs. And we talked about the rebound. One comment, because I'm almost at time here, for possibility of de-escalation. We have very little guidance in this regard, but at some point, you have to acknowledge that the disease may have changed and maybe even stabilized, and the patient is getting older. And I mean, older, I say in quotations because I keep changing my mind what that means. But let's just say over the age of 50, you start to get some degree of immunosenescence. You start to get an increase in the number of opportunistic infections. That was certainly true for all the experience that was there with fingolimod. Most of those opportunistic things happened, including even the fungal infections, in older patients. So as your patient is aging and on these drugs, their risks are going up. And maybe their disease control is good, and you have the option of perhaps dropping down to a safer drug and still being able to maintain. Very, very few studies out there that have actually looked at this proactively, but there are some data that says you can transition safely. Just something to think about. especially if risk factors continue to grow. We know the longer you're on natalizumab and fingolimod, the more problems you're going to have. Okay, so in terms of de-escalation, once again, you're going to look for activity. Can you safely de-escalate? If someone's still having events and an active MRI, you'd be very hesitant to do so, but if they've been stable for a long time, we even have a study that just got published, a year ago, the DISCO-MS, where they looked at discontinuing drugs in patients who have had long-term stability and no activity. Progressive MS I'm not going to talk about because Jeff's about to go into that. And pregnancy, this slide is just to tell you, of course this is a topic that warrants an entire lecture, but know what your patient is planning, because if they want to get pregnant in the next few years, your whole strategy is going to change, because you don't want them on agents that if you stop them suddenly because they got pregnant, they're going to have a bad rebound, and then they're going to be worried about a pregnancy and then a very active MS. So pregnancy comes in many aspects of choosing the first drug and sequencing. So I think it's something that you think about not after the patient fails the first drug, but before you even start the first drug, know what your plan B is. Have a monitoring scheme to know if the patient's responding or not to a degree that and share that strategy with the patient so they know what you're thinking. Here's what we're going to do. We're going to monitor you thus, and I'm going to draw the line here and make sure the patient understands that. Consider escalation when it's needed, even consider de-escalation as the patient ages. And I'll stop there, and I'm sure you're going to have a million questions for Stephen and I, but that'll come later in the panel. Thanks.
Okay, continuing on this theme, Dr. Jeff Cohen from the Cleveland Clinic is going to come up and discuss better treatment options for progressive disease and neuroprotective strategies.
Well, thanks, Fred, for the invitation and for the introduction. So what I'm going to do in this talk, hopefully over the next approximately 30 minutes, is provide an update on developing new treatment strategies for progressive MS. I'm going to start with two disclaimers. One is I'm actually not going to talk about repair, although I may talk about neuroprotection. And secondly, let me apologize in advance if I have a coughing spell. I'm still recovering from the complications of going to Disney World last week. So my disclosures are listed here. So this slide, this table lists recent phase 3 trials in progressive MS, which almost exclusively were negative. The agents did not show efficacy in progressive MS. Aside for ocrelizumab in primary progressive MS and siponimod in secondary progressive MS. However, the magnitude of benefit in those trials was modest. And then the other piece of background I want to give you is this concept, which has come up a couple of times, which is the realization recently that our disease categories probably are more of a continuum rather than being distinct. And I like to think of the disease as driven by two biologies. One is focal lesion activity, which drives relapses. But we know that that biology is also present in some patients with progressive MS. In fact, those are the patients that tend to respond to our available disease-modifying therapy. And conversely, there are other processes which drive progression, which increasingly we're realizing are present in many patients from the earliest stages of the disease. And those include an evolution from focal lesion activity to more diffuse, compartmentalized, non-remitting inflammation, the accumulation of damage, the increase in neurodegeneration, the failure, the exhaustion of brain reserve, and the failure of compensatory mechanisms such as neuroplasticity and repair. And it's that failure of compensatory mechanisms which may unmask the progressive biology. And then finally, as you've heard from a couple of speakers, aging also plays a part. It determines the type of damage that occurs, the susceptibility of the nervous system to damage, and the resilience of the nervous system to damage. And so there are a number of unmet needs in progressive MS. One is to develop agents that target these drivers of progression. Secondly, it's better outcome measures that can measure the progressive disease process, particularly in preliminary trials. Third, we need better trial designs to test these agents more effectively. And then finally, we need strategies that promote the compensatory mechanism. So I'm going to touch on those themes in this talk. So the first topic I want to talk about is the BTK inhibitors. There's been a lot of anticipation of their emergence. Dr. Lublin's going to go into them in more detail this afternoon, but I want to at least mention them. So there are a large number of BTK inhibitors under development for a large number of indications, but also these agents are under development for multiple sclerosis. And in fact, 4 of them have made it to phase 3. So what are the BTK inhibitors? Well, Bruton tyrosine kinase is part of the signaling pathway for a number of cell surface receptors, in particular the B cell receptor. So blocking BTK, inhibiting BTK function, inhibits B cell activation. But BTK is also linked to a number of other receptors, and so inhibiting it blocks microglial activation and also may potentially augment remyelination. And it's those target mechanisms which have made BTK inhibitors of substantial interest in multiple sclerosis, not just for relapsing MS, but potentially for progressive MS. So this table contrasts the effects of the BTK inhibitors with the B-cell depleting monoclonal antibodies. In principle, blocking B-cell activation may overlap some of the effects of the B-cell depleting monoclonal antibodies. That remains to be seen, whether that's also efficacious. But the advantage would be is that it's somewhat more reversible. But the main advantages potentially of the BTK inhibitors includes that they penetrate into the CNS, so they can affect B-cell mechanisms within the CNS, and also may beneficially affect some of the other processes in progressive MS mediated by microglia. So that's why there's been a great deal of interest in BTK inhibitors. There have been 2 phase 2 trials. The first was this one of evobrutinib in relapsing MS. The primary endpoint, as is typical of our phase 2 trials in relapsing MS, was MRI lesion activity. And in short, the highest doses tested did show benefit on MRI lesion activity. In a more recent publication that actually just came out in the last couple weeks, in a post hoc analysis, these slowly evolving lesions were also examined in this trial. So as you heard from Dr. Coyle, slowly evolving lesions are thought to be one of the MRI markers of the chronic active lesions that play an important role in progressive MS. And so this analysis, this is a complicated slide, also suggested that evobrutinib had benefit on slowly evolving lesions. The second phase 2 trial was this trial of tolebrutinib, also in relapsing MS, also focusing on MRI lesion activity as the primary outcome measure. The analysis on the left, it's analyzed in somewhat of a weird way, so it's the negative log of gadolinium-enhancing lesions, so up is a reduction, but it also showed at the highest dose there was a reduction in gadolinium-enhancing lesions. This trial also looked at slowly evolving lesions and paramagnetic rim lesions, the 2 MRI markers potentially of progressive biology, and there was some indication of benefit. So, as I showed you this slide previously, there are, among the phase 3 trials that are ongoing, are 3 trials in progressive MS. So we're anxious to see the results of those trials. But so what is the current status of the BTK inhibitors? So as some of you may know, the evobrutinib trial in a press release was said not to have achieved its primary endpoint, annualized relapse rate, in comparing evobrutinib versus teriflunomide. We'll hear the full results of that trial later in the week at the ACTRIMS forum. The other trials of the BTK inhibitors in relapsing and progressive MS are ongoing. We expect those results over the next couple years. One issue that's emerged with the BTK inhibitors has been drug-induced liver injury, which led to a partial FDA hold on enrollment in several of the ongoing MS trials of BTK inhibitors. So there's a lot of anticipation of the BTK inhibitor results, and we're looking forward to getting those over the next couple years. Another study, another approach that I just want to mention is CAR T cell therapy. So CAR T cells are chimeric antigen receptor engineered effector T cells, which have an extracellular domain derived from antibodies, which lead to antigen specificity, a transmembrane domain, and then an intracellular domain that's typically derived from the T cell antigen receptor that drives signaling. So there's a lot of excitement about CAR T therapies, particularly in oncology, where there are a number of approved CAR T therapies for a number of neoplasms, including B-cell-derived neoplasms with CAR T cells directed against CD19. There have also been some reports of anti-CD19 CAR T therapy in other autoimmune diseases, lupus, anti-synthetase syndrome, NMO, myasthenia gravis, and there are several trials of anti-CD19 CAR T therapy in startup in multiple sclerosis. So what are the potential advantages of CAR T therapy? Well, first of all, some CAR T agents already exist. They've already achieved regulatory approval, so we have some sense of their safety. They lead to potent depletion of CD19 B cells. This is a population that largely overlaps the CD20 population that our monoclonal antibodies for MS deplete. A somewhat broader population, whether that's an advantage or a disadvantage, remains to be seen. But the main potential advantages of CAR T therapy are that they may produce long-lived, more potent benefit. One, because of the duration of the CAR T product, which will continue to lyse CD19 B cells, but most importantly, by their ability to penetrate into tissues, including the central nervous system, where they may treat B cell related mechanisms in progressive MS. So the next agent I want to talk a little bit about is ibutylast. So ibutylast is an orally available small molecule. It has several mechanisms of action that one might think would be of benefit in progressive MS, and it crosses the blood-brain barrier. It's approved in Japan to treat bronchial asthma and post-stroke vertigo, and in a number of animal models, it has effects that would suggest neuroprotective effects, including in animal models of multiple sclerosis. Now, the story of ibutylast in multiple sclerosis starts here. So this was a phase 2 trial carried out now more than 10 years ago, which intended to show a benefit of ibutylast on MRI lesion activity, our typical relapsing phase 2 trial design. It turned out not to be effective in on affecting MRI lesion activity, but in this trial did appear to slow brain volume loss. So that led to this trial, the SPRINT MS trial, which was a phase 2 trial of abutulast in progressive MS, focusing more on outcomes related to progressive MS. So this trial had two purposes. One was to look for the neuroprotective effects of abutulast, but secondly, to analyze the utility of a variety of putative outcome measures that have been proposed for phase 2 proof of principle studies in progressive MS to see which ones were best able to demonstrate a treatment effect. And so the main results of this trial are shown here. Abutulast did lead to an almost 50% reduction in the rate of whole brain volume loss. That was highly statistically significant. That benefit was supported by some other secondary MRI outcome measures. It turned out that magnetization transfer imaging was useful. Regional atrophy, cortical thickness, and gray matter fraction also looked to be useful. Diffusion tensor imaging turned out not to be very useful for this purpose. And in the initial analysis, OCT did not show benefit, but I'll show you a reanalysis of the OCT data, which did indicate that OCT is also useful for detecting this treatment effect. In a recent publication, abutulast was also shown to reduce the accumulation of slowly evolving lesions. And then this is the reanalysis of the OCT data with more strict quality control and an algorithmic segmentation, which allowed the results of the two OCT machines, the Spectralis and the Cirrus machines, the data to be pooled, which also showed a robust benefit on OCT. Now, one of the interesting results of this trial is that it also looked at the utility of neurofilament light as an outcome measure. There was high hopes that neurofilament light, as you've heard now from a couple speakers, would be a useful fluid biomarker for MS. The data currently suggests that it's useful for monitoring lesion activity, but one of the areas for which there was great expectation was that it would also be useful as a marker for progressive biology. And interestingly, in this trial, even though it showed a robust benefit on several measures of CNS tissue integrity, including brain volume loss, there was no benefit seen on neurofilament light concentration. So there's a long-term follow-up study of SPRINT that's ongoing. This is to bring these patients back to see which of these outcome measures in a preliminary phase 2 study predicted more robust disease behavior long-term. So the other agent that I want to talk about are the statins. So there's a number of reasons why statins may be of benefit in progressive MS. They have, in addition to their lipid-lowering properties, they have immunoregulatory effects, potential neuroprotective effects. They can be given orally. We, of course, have extensive experience with treating hyperlipidemia with statins. They have, in general, good tolerability and safety. So they've been tested in a number of trials in MS. They turn out to not be very effective in relapsing MS. But there was this trial of simvastatin, Zocor, in secondary progressive MS by Jeremy Chataway and colleagues. And like the SPRINT MS study, the MS STAT trial also showed benefit on whole brain volume loss, which was supported by a significant but modest benefit on EDSS, on the MSIS, which is a patient-reported outcome measure, and a trend towards benefit on the MS functional composite, another outcome measure related to disability. Now, interestingly, MS stat also showed the same effect or lack of effect on neurofilament light. So although there was benefit on brain volume loss, in this trial in progressive MS, there was not a treatment effect on serum neurofilament light concentration. So unfortunately, it looks like neurofilament light is not going to be a very useful measure for progression. So that trial then led to this trial, which was the MS SMART trial. So this was a multi-arm trial testing 3 potential neuroprotective agents versus placebo. Those agents were amiloride, fluoxetine, and riluzole, all of which had some preliminary data that suggested they might have neuroprotective effects. And to make a long story short, none of those agents showed benefit in this trial. But that then led to the development of this SPIDER MS trial infrastructure, which is a so-called multi-arm, multi-stage adaptive trial platform, which allows for an enduring clinical trial infrastructure, which facilitates testing of multiple agents with the same investigators and with largely the same protocol to effectively, efficiently screen agents and discontinue testing of agents that don't turn out to be beneficial, and for those that show promise to effectively go from phase 2 to phase 3. So this trial design has been implemented, and they're developing the next multi-arm trial. So what I've tried to do is in the last 25 minutes is give you a sense of where things are going in progressive MS. There's a big unmet need for better therapies, better ways of testing those therapies, and for better trial designs to use those outcome measures to test those therapies. There's a large list of potential therapeutic targets, and hopefully over the next couple of years we'll see some positive results from those. So thank you.
Okay, Mark, Stephen. Okay, lots of questions, so I'm going to dive right into it. Question from a former resident, which relates to a conversation I was just having with a different former resident, which is, can you see MS developing cognitively first and later actually showing up as lesions? Jeff?
Yeah, so cognitive impairment is very common in MS. Usually, I would say it develops in parallel with the physical manifestations, but there are some patients in whom the cognitive impairment outweighs the physical, gets worse faster than the physical manifestations, and we have seen a few patients present predominantly with cognitive impairment who then turned out to have MS, so yes, it can happen.
And it depends on how hard you look.
Right.
Okay. This is a good one. Do you have a good way to differentiate PIRA from functional decline with aging as our population with MS gets older? So interestingly enough, the MS Society is going to take up the issue of aging and MS in almost about a month and a half. It's a major issue. Comorbidities are a major issue, and our population is aging. The average age has gone up considerably. So you have to subtract out what's due to arthritic disease and everything else from what you think is due to the underlying disease itself. Stephen?
You can also think of it as a differential diagnosis of progression in someone who has MS. And, I always like to think about the cases that humbled me in this respect. So very briefly, at a 73-year-old woman who's had MS for 40 years. I've been taking care of her for a long time. She used a cane, and she used bilateral support, and then she was using a walker. But she really was declining in how far she could go, and her stamina was low, and she couldn't go up hills anymore, she couldn't go upstairs anymore, and we all ascribed it to progression of her disease. Until someone did a careful listen to her chest and realized she had a significant systolic murmur. Turned out she had critical aortic stenosis, and she was going into heart failure. And that was treatable. And it's a really good reminder. And so then we looked back to say, was it really progression at all, or was this all cardiovascular insufficiency? So that's a more extreme example than just the kind of loss of motor power that happens as people age. But you do have to really try to distinguish what's medical, what's age-related, and what's the disease itself.
Yeah, so I think that's an a point that bears emphasis, which is there are certain aspects of MS that we cannot treat. Progression, as I just indicated in my talk, some of the symptoms, for example, fatigue. So it's very important to not miss a treatable cause for those things.
Yeah. Mark?
I'm just reminded of something that sort of changed my concept about understanding this, and it was, well, you and I will probably, and Jeff will probably remember this because it goes back to the early 80s when they thought they had a new syndrome, and it was called the post-polio syndrome. And this was something that happened in patients who had polio back, I guess, after World War II. And they, you know, this is a one-time disease where it leaves you knock out of the motor neurons at that segment, wherever it was. But these patients, 40, 50 years later, came in complaining that that leg that was always weak is now tremendously much more weaker, and every year it seems to get worse, and they thought their polio was back. And it sort of, it puts to mind the fact that there must be some sort of threshold for maintenance of a limb, function, walking, whatever. And as soon as you've lost enough neurons and axons to subserve that function, you start to decline. And that brings into the whole, reserve that you showed in your diagram. If early on you use up that reserve, then aging is against you. And I guess that's, the water level going down in your tank. As you age, you call upon that reserve to keep you into your 70s and 80s. And if you've knocked out that reserve by knocking out the anterior horn cells for polio, or MS has taken out some pathways, the decline will start to be apparent. And it's not because of active disease, it's because of the aging phenomena. And I guess the best way of trying to figure out if it's MS or aging would be look for activity. You don't see any activity. But the progression is really slow. It doesn't occur over weeks or months. It occurs over years. And if patients are followed carefully, I think you'll see the fact that that's the aging.
One last small point about that. I smiled when you brought up the polio example. When I first presented the topographical model, a 90-year-old neurologist in the room pointed out that this depiction that reserve declines and unmasks damage, particularly motor damage that may have been compensated before, was in fact very reminiscent of post-polio syndrome. What's, I think, distinct about MS is that, and this relates to Dr. Cohen's talk, is that MS causes both drivers, both the focal and the diffuse, and what makes MS so specific, I think, is the coming together. But to help distinguish aging from progression, I think, and you just said, recapitulates the existing symptoms. It worsens the specific symptom that's there. So in the post-polio scenario, the leg that was always weak gets weaker. I think that's true in MS progression as well.
I'm not 90 years old.
Okay.
You're not 90 years old.
Here's a question. What strategies could be used to standardize the definitions of disease progression and worsening in observational studies and clinical trials? So this gets to the heart of some of the differences between those two things. So in a randomized well-controlled clinical trial, you standardize the definitions on how your EDS, you train for EDSS, you have a committee that's going to look at your relapses and such. In observational studies, none of that's done because they're spread out over multiple things. So I mentioned earlier relative advantages and disadvantages of each. My own view, and I welcome argument here, is observational studies serve two important purposes. One, to generate hypotheses to be studied in a randomized clinical trial, and the other is to take results of randomized clinical trials, which use a narrow, homogeneous population, and expand it into populations that weren't necessarily covered in the original trial. But I'm happy to hear dissent.
I would add one third reason. I agree with those two. And the third one is to try to ask questions that you can't possibly ask with a clinical trial. You know, to compare things that will never be compared, for instance, and recognizing that the data you get from that won't be the same as doing a clinical trial, but it's a way of trying to answer a question that a trial will never be designed to do.
Yeah, maybe, may not trust the answer though. And one other related to mine, why aren't you impressed with low vitamin D anymore? Do you think it doesn't play a role? So we put people on vitamin D, but the data are not very good. It's one of the things with the difference between an association and cause and effect. But what's moved me most was a Mendelian randomization study we did with the Johns Hopkins people, looking at people who had a gene for high levels of vitamin D versus low levels of vitamin D. And we looked at 3 different populations, and it didn't predict, the low level did not predict worsening disease. So vitamin D is benign, we use it, but I don't think it hasn't gone anywhere in the last decade. Dissent?
No, I would say that the data that low vitamin D is a risk, contributes to the risk of MS is more robust than the ongoing data that it drives disease course or that supplementation affects disease course.
The latter we don't have data for.
Right.
Right. Okay, for Dr. Krieger, when you see a patient with first presentation acutely in a hospital setting, how much does approval/access of a medication for in-hospital use, like an Ocrevus infusion, come into play for what treatment plan is selected?
So I said in my talk that when a patient's admitted with new diagnosis of MS or workup for MS, I send off that panel of infectious risks to start to set the table for that treatment decision. But rarely, if ever, is it approached during that first few day hospitalization when someone's in-house, for a lot of reasons. One is typically the priority there is to treat the acute relapse, make sure differential diagnosis has been pursued. If you're obtaining spinal fluid, often the salient results aren't going to come back until that patient's been discharged for a few days anyway. So I can't think of an example where we've endeavored to get through insurance what is inherently a disease-modifying therapy while someone's in-house for that first time. I would say, though, zooming out, how much does third-party coverage, payment coverage and insurance authorizations, how much does that drive what we do? It drives an enormous amount of the work that we and our staff and our colleagues and our fellows do to try to get these drugs approved. We try very hard to not let that fundamentally change the treatment plan that we have in place.
There are other conditions where we may want to start rituximab, for example, as an inpatient, but for MS, it's pretty uncommon. Okay, this one I'm going to start with Mark, then throw it open to the rest of our faculty and everyone else in the room to weigh in. So how do you justify starting a patient on a lower efficacy medication when you could, and I love this question, when you could start them on a high efficacy med and prevent relapses but contribute to earlier onset of disability? Even if you think they don't have an aggressive form of MS, the desire to prevent relapse or progression is still the same as if they did. So we'll start with Mark, and this is escalation versus high efficacy.
Yeah, I mean, this is a debate that's been going on now for the last 20 years. And really, if we could very accurately identify patients at high risk, then it would be easy to just go ahead and pick the strongest stuff you have and go for it. If, in fact, the strongest medicine or treatment that you have had no risks or downsides. And that's the key, right? Because you're not treating today and next week and a month. You're thinking 5 years, 10 years down the road, this therapy is going to be maintained. And the patient may want to get pregnant. The patient may have travel plans. The patient may have a lot of other issues that you need to bring into play. So it's not so simple. If the highest efficacy therapy had no downside whatsoever, I would agree with whoever asked that question. But I think we are getting a little bit better at figuring out prognosis. There's lots of information that is now informing on that. I think there's a lecture or something about AI later today that tries to bring a lot of this together. Briefly, you mentioned about a genetic marker. We're going to probably have more genetic markers that will indicate who perhaps is at a worse prognosis. In those individuals, now you can make the argument, you know, maybe you want to hold off getting pregnant, so because your prognostic indicators are, you know, in the next couple of years, if we don't catch this disease, well, you may be in big trouble. And I think that rather than just empirically throwing everything out there, the best, you know, the hardest you want to hit it, there are downsides and issues that you have to take into effect. You know, we do bone marrow transplant, HSCT in Ottawa. I've had patients come after a single optic neuritis show up saying, you know, I want to nip this in the bud now, and I don't want to have MS anymore, so I'm here for the stem cell transplant. I went, hey, do you have any idea what is involved with this? And you know, you could die from this procedure. They're just unrealistic about that sort of expectation. So it's not a complicated, it's a very complicated decision. It's not a simple answer.
Thoughts?
Yeah,
Jeff, you want to mention the study?
Yes. Yes, I would just mention that I would agree there are some patients with very worrisome MS where it's very clear they need a high efficacy therapy. And there are some patients at the beginning who have extremely mild disease and are risk averse for whom an escalation approach might be appropriate. But most patients sort of fall in the middle. And for those patients, we don't really know the best strategy for the first treatment. That's why there's 2 prospective randomized trials looking at that, Treat MS and Deliver MS.
And how soon might we have data?
Deliver MS just finished enrolling, so we should have results when. And Treat MS is not quite finished enrolling.
I would just add that I think that question might have come after I, you know, shuffled the deck in the order of putting very old school, very simple medicines at the top. And the bottom line is I think we start those medicines very infrequently in this era. It's still worth thinking about them. There are still people that could perhaps do just fine on very low-risk medicines, but certainly the field has moved rather substantially in the direction of high-efficacy therapy quite early, if not, you know, right from the beginning for the great majority, I would say, of patients in this era.
Yeah, and now we have to start thinking what I think was Mark mentioned about when to de-escalate, where we don't have data yet, but it's a big. So anybody out in the audience there want to weigh in on this? Okay, sorry, we'll move along. No, well here, this, can you further discuss the concept of de-escalation of treatment and specific cases in which you've done this or suggest doing it? De-escalation, sure.
Sure, and you've spoken on this as well. So I think that I think of a couple of paradigms: the older, stable patients who, we have patients now on drugs for 30 plus years, who probably in the last 10 or 15 years have just been, they show up for their appointment, hello, how are you, everything's good, fine, everything's stable, good, see you in a year. I mean, that's been going on for so many years, and they start saying, you know, I'm running out of skin. Do I really need to keep doing these injections? That, or the pills that haven't been around for that much longer, but, you know, do I need to continue the medicine? And we're now getting some information that maybe they don't. And I think the Disco MS was one of at least the attempts at randomized study to look and see what happens if you do this methodically. But we've had a number of other studies that were sort of ad hoc. These are patients who more or less decided to vote with their feet and stop the medicine on their own, and they were followed. And it turns out that the characteristics are similar. So this older patient group, older being probably 55 or older, who've had MS for decades, who've been stable for 10 plus years, no attacks, MRI stable, no change on their neurological examination, probably could stop their medicine. And depending on what they're on, you could just stop it. So if they're on the injectables, if they're on teriflunomide, dimethyl fumarate, it's not an issue. Although in the case of teriflunomide, you also have the alternative of washing them out. But if they're older and they're not going to get pregnant, then I don't worry about it. So I just let it go. If they're on drugs like fingolimod or natalizumab, you have to deal with the potential for rebound in that, even in that older group who you'd expect to think, oh, well, they're not going to get a rebound. I can assure you, I've had many cases that that's not true, and they have had rebound disease. We still don't understand the meaning of why that happens, but it happens, and so you got to plan for that. What's happening with the B-cell therapies? They've been around less. As far as I've seen, stopping the B-cell therapy has had very little repercussion. There's no rebound from those drugs. And there's actually a study that's ongoing that at Penn, right, where they've randomized people off of an anti-CD20 drug after, I don't know how many years.
Short time.
Yeah, probably been on it for 2 years, and they're going to randomize off. But we've already seen details from looking at the patients in their COVID, in the COVID era, which is not that much older, but people during COVID didn't want to leave their house. They didn't want to go to infusion centers. They were leery about anti-CD20s because data was showing that maybe they're more likely to get COVID or bad COVID. And so they went off their infusions for up to 2 years in some circumstances. And that recently was published, what happened to them. And basically nothing happened to them. They were fine. If they've had a couple of years of anti-CD20, maybe you don't need it anymore. So they've kind of de-escalated on their own. So those are kinds of the patients that I would be concerned about are natural sort of questions, and I don't want to take up all the time, but the other ones are the ones who've given you a safety issue. And I sort of alluded to it in my talk. You may have chosen a particular drug because they're young and in their 30s, but as soon as they hit the 50s, the risks of all these kinds of problems just start to go up, and you want to get them off that to reduce that potential risk. And I can talk more afterwards, but I'll let my colleagues deal with.
Jump in. So I would just mention 2 points. One is the ability to stop medication is not just because of immune senescence and aging. There also is this concept that autoimmune diseases such as MS are self-perpetuating, where there's inflammatory damage, which then to which there's an immune reaction, which then sets up more inflammation. So tight control for a while, the disease may in fact peter out, which would support the concept that you could stop treatment in some people, even those who had active disease previously. And then the other point I want to make is something that Dr. Krieger alluded to, which is stopping therapy is a prime example of a discussion that should be a shared decision-making, where you interrogate the patient as to what their preferences are, their prior knowledge are, their goals, their priorities, and then you provide your input and you come to a common decision.
I would add only one last point. I think that really does cover the spectrum of it. And that is one thing I've started writing in my notes, especially for my older patients, is when was the last known disease activity? So, we capture all these scans over time, but I'd like to have in my note, here's a 63-year-old person. Her last known new lesion was in 2017 or in 2002, whatever it was. But that piece of information kind of helps to inform if you start to have the conversation about stopping therapy. If someone had disease activity as recently as 3 or 4 or 5 years ago, I don't care how old they are. Their immune system has declared itself that it's still active, and I treat it that way. But if someone truly hasn't had a new lesion in 20 years, it definitely gives you a sense that there's true quiescence there. So I try to look for that. And then the last thing I'll say is if you stop someone's disease-modifying therapy, watch them. Watch them closely, because sometimes you're going to be wrong. Sometimes the disease is going to start to wake up, and the only thing you can't afford to do is miss it. So that's the person I might do MRI scans every year in a 72-year-old person, which I might not otherwise do once they're off medicine, to make sure that I catch it early if disease activity comes back. That, to me, was one of the implications of the DISCO-MS trial, to catch it if it starts to occur.
There's one other group, but I didn't want to go there. And that's probably the most difficult one, and that is the futility group. The ones that are not having activity but are progressing along, and your concept is the drug isn't doing anything for them. And it's very hard to convince them that the drug is not doing anything for them. Maybe it's protecting me anyways. How do you know? And they don't want to be without something. So I have a hard time with that group.
Okay, I know we're in Florida, but there's a question here that says, how is your experience or opinion about the use of hydroxyquinoline in active chronic lesions? Someone want to explain the question? Feel free.
It's like COVID.
Yeah, we're in Florida, you're safe. You may get measles, but... Okay, so we have no experience. Anybody down there on the faculty? Yeah, can't help you with that one. So I have more questions one we'll get to later, but so for lunch from 12 to 1:30, we have 2 special lectures. And so I want to stop now so you can go out and grab your lunch and bring it back in here, and then we'll have these next two lectures. But I want to give you enough time to get your lunch and get back in. So thank you very much to the panel. And we're going to reconvene while you're eating at noon. Oh, you made my job easier in part.
I was thinking last night.
Mic's on. All right, we're ready to resume. So what we're going to have now are two special lectures, and I'm going to introduce them both so they'll flow more seamlessly and I don't have to run up here in between the two. So the first is going to be differentiating S1P-based therapeutics for the treatment of patients with multiple sclerosis. That will be Dr. Friedman again. That talk's supported by an educational grant from Bristol Myers Squibb. Immediately following him, my good friend and colleague from Mount Sinai, Aaron Miller, will discuss review of new and emerging therapies that improve tolerability and adherence in patients with relapsing multiple sclerosis. And that's supported by an educational grant from Mylan Specialty, Viatris Company. So Mark, come on up, you're on, and then Aaron will follow.
Thanks, Fred. Welcome again. I think we've had a little attrition. Probably, we should probably put a speaker out by the pool or something for all the people who are not here. So my job in the next 30 minutes or so is to sort of tell you about the S1P story and how it's evolved over the time. Okay, let's see if I can make this work. Okay. So I'll review some of the pharmacological differences amongst these drugs, look at some of the data for especially the longer-term safety and efficacy that's been shown from the trials, and then try to integrate them a little bit into a treatment plan, playing up on what you've heard already earlier today. So we've got now essentially 4 drugs that we're talking about. I kind of put siponimod in brackets because although its phase 2 study was actually tested in relapsing disease, the indication, though, is for active secondary progressive MS. So in this country, you could use it for a relapsing remitting patient, though in other countries that's not available to you. The receptors that we're talking about here are the S1P receptors. They're all G proteins. They're linked to all sorts of subcellular events. And the binding of these various proteins not only serve to look at the potential for efficacy, but the big one is also safety. And so when you think about the S1P receptors and where they are and what they do, some of them are actually in the brain, on the CNS. And this slide sort of summarizes some of those receptors and what they might do. So you can imagine then if the molecule is small enough and gets entry into the central nervous system, there is a potential that stimulation of the S1P receptor on that particular cell, say, for instance, the oligodendrocyte, where it's been shown to improve the survival, the proliferation, the migration, and the basic function of the oligodendrocyte, might actually be something that it could promote. And so the hope when these drugs first came out was similar to what you've heard about the BTK inhibitors. They can, with one mechanism, control the inflammation from without, but if they can get into the CNS, some of the things that they might do through the same receptors or different receptors on the cells of the central nervous system is to promote survival, repair, protection. So here are the 5 receptors that we're talking about here that are of interest. S1P2 is more or less, with any of these drugs, not really something that is hit from the non-selective receptors and the modulators, which is, in this case, fingolimod. So the 1 and 5 are the real main ones. The one we worry about is the 3. And this is where the problems came with fingolimod, because 3 is on cardiac myocytes, and when you stimulate that particular S1P receptor, it leads to bradycardia and some other heart arrhythmias. And so the whole idea of the newer generation of S1P receptor modulators is to kind of do away with this sort of effect on S1PR3 and really maintain the effect on 1 and possibly 5, although this is the one for which we have very little proof. And so this is where the selective S1P receptor modulators come in. And I'll talk in a minute about how it does the lymphocyte retention. I won't go much into R5 because the data is all out of animal models mostly. There's very little human data to support an effect, a positive effect. There's some suggestive things, and I'll touch on those as we go through some of the trials. So when you think about the binding to these receptors, when the numbers are very high on these EC50 graphs, it basically means there's no binding at all for this. And so when they're very low, it means very low concentrations can occupy the receptors. So you can see 1 is hit by virtually all of the drugs, 2 by virtually none of the drugs, which is why I kind of faded it out. 3, mainly fingolimod, a little bit from ponesimod, but mostly from fingolimod. 4 is also on lymphocytes, but probably has little role. And then 5 is the one that's inside the brain, and they all have the potential for binding. So these are the 3 that we're going to spend a little bit more time about. What happens to the lymphocytes as a result of the stimulation of the S1P1 is that this is, think of the lymph node as Hotel California. And when the lymphocyte comes in, because it goes down a gradient requiring the expression, the increased expression of S1P1 to egress the lymph node, if the S1P1 is not expressed, basically the lymphocyte will come in and not be able to egress. So Hotel California, you can check in, but you can never leave, right? Okay, so that's how this works. And really it affects any cell that will express the S1P1. So not surprisingly, there's effect on both B and T lymphocytes when you use the S1P receptor modulators. On the effects on the immune system are multifocal, and I don't know which of these mechanisms may also be at play, but this is what's been seen. So Th17s are thought to drive the disease. Central memory and B cells have all been looked at. So these are the cells that are sequestered. Doesn't affect, though, monocytes, NK cells, and neutrophils. So this is part of the innate immune system. So it's allowing some surveillance of the body. So it's not nuking the entire immune system, but it's selectively pulling out certain types of T and B cells, or the killing of cells as required for cytotoxic T cells. So a lot of the preservation, and this is why these particular drugs have some interesting potentials. The differences are seen here, and there's some important differences I just want to point out. The half-life is variable. So fingolimod we're used to. Ponesimod and siponimod are really short half-life drugs. And then the ozanimod has a short half-life, but because of this metabolite that's seen here at the very bottom of the chart, you get this variable effect on lymphocytes should you stop the drug. Fingolimod, typically 6 weeks, and the lymphocytes are out of the lymph nodes again and fully recovered. Much faster with ponesimod and siponimod within 1 week. And then ozanimod is anywhere from 1 to 3 months, depending on the activity of the metabolite. And that's important implication when you thought about my last lecture, where we were talking about sequencing and transitioning. If you're using one of these drugs, you have to be cognizant of when the lymphocyte recovery will be there, depending on what you're going to use after this. You can't read this, and I don't expect you to read this, but this is the efficacy data that more or less drove these drugs that are on the market. Fingolimod, even now generic. So many studies. There were 2 made, two with ozanimod, 1 with ponesimod, and 2, if you want to say, with siponimod. 1 called the BOLD study was a phase 2 short study to look at dosing, but EXPAND was the one where it looked at secondary progressive MS, which I'm not going to really talk about. So I'm going to focus now on ozanimod and ponesimod. The differences are really minimal between these two drugs. They're highly selective. And I'm just going to point out that there have been some studies that try to look at the outcomes of these drugs in the patients. And I can tell you that although there was a little bit of a difference, it wasn't statistically significant on relapse rate, at least in this particular evaluation. Although when they looked at brain volume changes, there was a slight advantage here with ozanimod over ponesimod. One of the other things that distinguished these two new drugs from the fingolimod is that they also focused on other aspects of the disease that had yet to be really impacted by any of the drugs we had for MS. In the case of ozanimod, they looked specifically at cognitive function. I know that question came up a little bit earlier. And something else that has been poorly addressed in really MS in general, but in clinical trials, is the debilitating symptom of fatigue. And so these were considered upfront as part of a secondary analysis of the studies. In the case of fatigue in ponesimod, it was really actually in a hierarchical type of statistical analysis. After the relapse, they looked at an effect on fatigue, and if they hadn't seen an effect, they couldn't go on and do any of the other secondary analysis. They did do the similar kind of analysis with the ozanimod, where they looked mainly at the SDMT change as a measure of cognition. And I'll come back to that in a moment. So the problems with fingolimod, and there are other issues that have been looked at in terms of safety, and I'm just going to point most of these out to you. The first dose bradycardia was profound with fingolimod to the point where everybody had to be observed. That is no longer the case for any of the newer drugs. Same thing with macular edema. When we started using fingolimod, patients needed an OCT within 3 months to pick up macular edema. It's much less prevalent in the cases of the newer drugs. We've seen some changes with LFTs, but mainly it's not been much of a problem. The lymphocyte depression is really, I'd have to say, relative, because if you stop the drug, the lymphocytes come back, and they're not being generated de novo from the bone marrow. They're allowed to exit the lymph nodes so that their sequestration has been stopped, and the lymphocytes that were always present are now back in circulation. So that's really, they're not truly lymphopenic. There has been PML, at least with 2 of the drugs. Fingolimod, there's been a number of cases, and there's at least 1 known case with ozanimod. The rebound has been present mainly with fingolimod, and I'll show you a little bit of data with ponesimod, but it has not been seen with the newer agents. So with regards to the bradycardia, this is what we typically saw with fingolimod on the bottom, and this is now the case for ozanimod. You really don't get the bradycardia because there's now much less effect, because there's no specificity for the S1P3 receptor, which is the one that mediates the cardiac effects. And the same thing is true for ponesimod, which also has built in a titration curve that allows you to build the drug. And if you do that, you don't see the bradycardia in these patients, so they don't need first dose observation. The rebound we've seen with fingolimod time and time again is really sometimes profound. We've seen these even big tumefactive lesions in somebody within 6 to 8 weeks post fingolimod, so you really need to plan for that. What about the newer agents? Well, at least in the ponesimod studies, we looked, and I presented this a couple of years ago, where they looked at all the patients who actually showed a return of disease activity in the 182 days that they actually looked at these patients. These are patients who stopped the drug for various reasons, some of them from a side effect, others for whatever choice they happen to have had. And then on treatment, they looked at relapses. There were 8 confirmed in 5 patients. And then post-treatment relapses in the 8 patients, there were some confirmed and some unconfirmed. And they looked at even at severity through the EDSS change. Most of them were a 1-point change. 4 of the patients actually had relapses with no changes. So in the end, the results are really, and this is post hoc, in the group of patients who had stopped the ponesimod, there really wasn't any indication of this rebound. And the implication of rebound is that it's not just a return of prior disease activity, it went way beyond what the patients had when they first brought to the trial. So there really wasn't an indication for post-treatment rebound. Whether the same has been seen for ozanimod, I don't know. At least there's no data out there. But there was no pattern we saw with ponesimod. What about the longer-term studies now? So we do have a study called long-terms from fingolimod. It was a 10-year extension data. There's now 5-year follow-up data from the Daybreak. It's called Daybreak from the original 2 Radiance and Sunbeam studies. And there's some long-term results from the Optimum study in ponesimod. And you're looking at these patients down the road. Remember, there's no more placebo to compare them to, but they're looking at mainly safety and whether or not you're maintaining some semblance of efficacy. So, in fact, the ARR continues to go down in both of these groups. It remains quite small. And in case of ozanimod, at 48 months, 71% of the patients are still relapse-free, 64% for the ponesimod study over 8 years. Then they looked at some other features here. So this is in Daybreak, and this is based on a cutoff of 2021, and I think in 2022 for the case of ponesimod. So here are the adverse events that have been seen that are at least of interest in most of these studies. Lymphopenia, which is expected because that's how these drugs continue to work. One sees this in about significantly, I guess, in 10%. So these are occurring in at least 5% of patients in Daybreak, similar for Optimum open label extension study here. The comparator in both of these was I think it was teriflunomide in ponesimod and interferon beta 1a in the ozanimod study. So the comparator isn't as relevant, but the actual drug is. So about 10% for one drug, about 14% for the other. When we think about LFT increases, they were not surprisingly more with teriflunomide than you were with ponesimod, but that's a known problem with teriflunomide. It's why we monitor liver function studies in the group on teriflunomide. What about cardiac events? Very, very, very few in the case of ozanimod and in the case of ponesimod. You can see that any bradyarrhythmias that we're seeing were no different really than the comparator for teriflunomide. There are a couple of other entities, especially serious infections, because you are, in some cases, compromising the immune system. So most of these are random type of things, pneumonia, appendicitis, but there was, in the case of ozanimod, 1 case of PML that was reported, some herpes. We didn't see very much in the way of serious infections with ponesimod. You heard about macular edema. That was very common in the cases of fingolimod, so much so that you had to monitor for it. There were some cases of confirmed macular edema in the ozanimod study, and it was some cases they were actually at the end of the study where the interferon arm got switched over onto ozanimod. And you can minimize the risk of macular edema by, of course, choosing patients who are at lower risk. So you stay away from diabetics, stay away from people who've had a history of uveitis. And the numbers were actually quite small and no different in the case of ponesimod. Okay, so choosing that therapy for your patient, I don't want to reiterate what was seen this morning. A lot of things go into the choice of therapy, including patient characteristics, risk aversion, how strong a drug that you want to give to a particular patient, and I don't want to rehash that. But essentially what you're looking for is control of relapse, slowing disability, maintain as much as possible brain substance or loss of brain volume, and is there something that might address some of these so-called hidden symptoms of MS, such as the cognitive concern and or the fatigue. So, there's lots of benefits Interesting study. I just, again, hard to read here, but someone actually, in the case of the Netherlands, they did this sort of cost analysis of the various drugs. So this is fingolimod, ozanimod, ponesimod, or a clustered response. And they looked at, in and amongst the other drugs that are used to treat multiple sclerosis in that country, which product might be the most cost-effective in terms of not only the cost of the drug versus preventing, ultimately, disease progression, which is what they were looking at. I don't know what the price of the drugs are in the Netherlands compared to the other drugs, but based on this, they showed that actually ponesimod was the most cost-effective amongst the S1P receptors because of cost and the effect on in this case, ARR. Here's the hazard ratios. So you can see actually ponesimod didn't come out, but it came out the best in terms of 24-week confirmed progression based on the data that they looked at from the clinical trials and in these many thousands of patients who actually took the drug in their country. So now we talk about choosing the best therapy for the patient. We talked about induction versus escalation and all the other factors that are already on this page that we discussed a little bit earlier. It's generally agreed, and we had a question that came up that Fred posed to everybody, that if you can institute a higher efficacy therapy to begin with, then you're looking at the best long-term result for these patients. Could you introduce a therapy such as S1P receptor modulators, which have a safer profile compared to the non-selective fingolimod and get that kind of advantage? That's the purpose of this. So the idea is to at least become familiar with the newer drugs. I heard, I don't know if it's true in this country, that ponesimod is not available. It never even looked for approval in Canada. So meaning for reimbursement from the government. It's approved by Health Canada, and if you have private insurance, you can actually get either drug, but neither company pursued the reimbursements from the government agencies. They all have, the newer drugs, an advantage over the non-selective fingolimod in that there's a few things. One they didn't talk about was that fingolimod is actually a prodrug and needs to be phosphorylated in order to become active. That is not true of the newer S1P receptor modulators. They're pre-phosphorylated, so there's no sort of warm-up in the body that's required. They have shorter half-lives, so recovery of the lymphocytes should be faster. There were some advantages that are obvious, such as not needing first dose observation, which was true for fingolimod. Although there's limited data on the long term, with only one case of PML that we know of and fewer opportunistic infections compared with fingolimod, they're probably safer. And from a planning standpoint, you don't have to worry about the potential for rebound should you stop somebody who's been on it a long time. That was definitely true for our patients who were on fingolimod. We had patients on fingolimod from the early 2000s when they were in the clinical studies. And when you think about it, it was probably the first oral drug available for MS. And so there were a lot of patients who didn't want to take the injections who went on to fingolimod, not necessarily because it was more efficacious. They did it because it was more convenient, and they didn't want to take the injections. So you had a whole bunch of these people who, for 20-odd years, or 20 or 30 years, took the drug because it was oral. And now they're into that range and age where we start to worry about the effects of the drug long-term. You want to get them off of it, and rebound was an issue for those individuals. In some countries, not all countries, you can use S1P receptor modulators first line, like you can with some of the anti-CD20s. So in that sense, these drugs offer an advantage and a choice for a higher efficacy therapy to start. And I think I'm pretty well on time, so I'll stop here. Thank you.
Well, I too want to thank the organizers, Academic CME, Dr. Lublin, for the invitation to talk. I wasn't so thankful when I saw the title of my talk, which has the distinction of undoubtedly being the longest title of any talk I've ever given, or in this. And I didn't know what he was talking about, so I made it all up. I'm going to talk about a potpourri of subjects. First, the results of the GA Depot studies. Then I'm going to talk about subcutaneous ocrelizumab, extended interval dosing of natalizumab, what to do about cladribine, autologous hematopoietic stem cell transplantation, and I'll finish up with the DISCO MS study. Now, fortunately, a lot of what I have to say has been introduced, at least in concept, by some of the earlier speakers, but not GA Depot, so let's start with that. But why are we interested in all this? It's because we, as physicians, want our patients to have more highly efficacious therapies, safer therapies, and therapies that they actually want to take and will take. The pharmaceutical industry, of course, is interested because this is an enormous market. $10 billion in the United States, over $30 billion in the entire world. That's a lot of chunk change. So most of the speakers, as you've probably noticed, if we have hair, it's gray. And those of us with all these gray hairs have lots of experience with glatiramer acetate over the years. I know many of the young people in this audience have swallowed the Kool-Aid that everybody needs to be on a highly efficacious therapy, but as some of the earlier speakers have suggested, that may not be the case. So GA, and I have patients who have been on GA for over 20 years and are still doing extremely well, even a few that I sometimes ask myself, was I actually correct in making that diagnosis? So GA, as Copaxone, was introduced as a 20 milligram daily sub-Q injection in 1997, and a big improvement came about in 2015 after the GALA trial, which demonstrated that 40 milligrams 3 times a week was effective, and so essentially just about everybody stopped using daily injections. Generics were first introduced about 5 or 6 years ago, and I'm going to talk about GA Depot, which is a 40 milligram intramuscular injection that has just completed its phase 3 trial. It's given once a month, and it has an FDA PDUFA date currently scheduled for next month. So GA Depot is a preparation of slow-release microspheres that is administered intramuscularly once every 28 days. The preliminary studies were done in the EAE model, which incidentally is what led to the initial use of glatiramer acetate in MS. And as you can see from the black portion of this curve, the results were the same as for other preparations of GA that are administered on a more frequent basis. This is the in vitro release profile, which demonstrates that over about a month, about 90% or more of the GA is released from this depot preparation. So GA Depot underwent a phase 3 randomized placebo-controlled trial that followed the traditional guidelines of most placebo-controlled trials. Because it was a placebo-controlled trial, this was mostly conducted in Eastern Europe, though there were a few sites in the US that contributed a handful of patients to the study. By the way, I think this is the only trial, randomized phase 3 trial of which I'm aware that successfully was completed in the context of both a pandemic and a war. So kudos to all of those centers that were able to accomplish this. And it was the placebo-controlled portion of the trial was a one-year study. The primary endpoint was efficacy as measured by the annualized relapse rate, and the secondary endpoints were MRI, and there were a number of there was one key exploratory endpoint, EDSS, and a number of other quality of life measures. So this was the primary endpoint. There was about a 30% reduction in the annualized relapse rate in the GA depot group. This is comparable to what was seen in all the other earlier studies with different preparations of glatiramer acetate. I want to point out one thing that to me is one of the most striking things about this study is look at the purple dots on the bottom of this curve and look at the annualized relapse rate. This is admittedly only for 1 year. There's an extension study of this trial going on, or just being completed, results not yet available. But the annualized relapse rate here is remarkably low, comparable to what Mark just showed us for the several S1P receptor modulators, and what we expect now out of our highly efficacious therapies. Now, I don't want to make an argument, because it would be specious to suggest that GA depot is comparable to some of our more recently developed highly efficacious therapies. But I think in select patients, this is probably does very well, and these are not select patients. They're selected only by the fact that they had clinical disease activity in the year or two prior to entry to the study. So it was an early separation by week 6, and then a prolonged low annualized relapse rate. There was a statistically significant but relatively modest reduction in new gadolinium-enhancing lesions, 28.5%. This, too, is relatively comparable, although slightly lower than was seen in some of the other studies with GA. One of the remarkable phenomena about GA, which I personally have never understood, is that in virtually all studies, mostly compared to interferons in the earlier days, GA has performed comparably in terms of relapse rate reductions, but has underperformed some of these other agents in MRI activity. I don't know what that means, and I welcome any suggestions from the other pundits in the audience. There was also quite a modest reduction, but a significant reduction on a post hoc analysis for new or newly enlarging hyperintense T2 lesions in this specimen. Now, hardly anybody in the trial, be it on placebo or on GA depot, progressed by 52 weeks in their EDSS, but nonetheless, there was a statistically significant numerical benefit at week 52 for GA depot over placebo. And also in a post hoc responder analysis, there were about 5% fewer patients who progressed on GA depot than progressed on placebo. But again, to emphasize, very few people are progressing in this one-year trial. As one might expect, one might have an advantage in terms of local reactions because of the relative infrequency of this treatment. I don't know if I emphasized before that this is an intramuscular injection, and in this study it was administered by healthcare providers. If this drug is approved by the FDA and comes to market, it's not yet certain what would be the recommended mode of administration. It might be perhaps an arrangement for a nurse to go to the patient's home to do the administration, might be for the patients to come to a provider's office. That remains to be seen. But one of the big bugaboos about glatiramer acetate, which has very few in terms of safety issues, has been the development of local skin reactions in patients taking these drugs over many years. Lots of fibrosis and difficulty injecting the drugs, lots of lipoatrophy in patients, particularly when the drug was being administered on a daily basis, less so with 3 times a week. But this study shows that the number of injection site reactions diminishes over time, becomes quite small in the GA depot arm. And looking here in the left-hand panel, you can see, as expected, the injection site reactions with a monthly injection are probably going to be much less frequent than they are with the other preparations of glatiramer acetate, specifically Copaxone, where they're extremely common in the daily injections and a bit less common, but still very common in the 3 times a week preparation. The incidence of serious adverse events with GA depot was quite low. There were a few patients who were described as having abscesses at the injection sites. In reviewing that data myself, I was the PI for this study. I'm suspicious that these were not actually abscesses, but they were coded as such by the local investigators. Many of these patients continued on drug. Most of those so-called abscesses were neither drained nor treated with antibiotics, so I'm quite concerned about whether or not they were miscoded. As you probably know, with glatiramer acetate subcutaneous injections, one of the things you need to advise patients about is this thing that's referred to as an immediate post-injection systemic reaction, which occurs within a few minutes of the injection and includes tightness of the chest, palpitations, flushing of the face, sometimes shortness of breath, and a feeling of anxiety. Disappears in about 10 to 20 minutes, doesn't actually require any attention, but many patients who aren't aware of it end up in an emergency department because they're worried about a cardiac event, which it's not. Interestingly, virtually no immediate post-injection reactions occurred with this depot formulation. Okay, so up till now I've presented data. Now I'm going to present opinion, and that is who might be candidates to use GA depot. Well, there is still a very substantial percentage of patients who are continuing to use glatiramer acetate around the world, partly because it's been available for so long, partly because many patients are doing well on it, and partly because it's the safest, I think it's fair to say, the safest drug in terms of serious adverse events that's on the market. So one potential candidate for this agent would be patients who are currently taking probably 3 times a week sub-Q glatiramer acetate. This is a great drug potentially for women who are contemplating pregnancy. We have very few good options for women who want to get pregnant at the present time in terms of safety, and this is a good one. There are still some patients who, particularly those who have mild MS, who are very risk-averse about drugs, and if they want to start out with a drug that has very minimal risk, albeit modest efficacy on average, this is a good potential drug to use in that circumstance. And possibly older patients who have stable disease, I'm going to talk about disco MS later, but who might not want to come completely off drug, but might want to switch to something that's safer and that may hold them. This is a hypothetical. Okay, so let's turn now to another potential new formulation that may come to market, and that is subcutaneous ocrelizumab. We're all familiar with the very high efficacy of ocrelizumab as well as other B-cell depleters. Ocrelizumab, as you know, is given by intravenous infusion every 6 months after the first infusions, which are divided in half 2 weeks apart. So this is a new formulation of ocrelizumab designed as a subcutaneous, I don't know whether to say injection or infusion, take your pick, because this is a 23 ml volume that's injected. Hard to think of it exactly as an injection, but it's a subcutaneous administration, so hard to think of it as an infusion, so maybe we need a new term for these kinds of administrations. But it is given in that formulation every 6 months, usually in the abdomen, subcutaneously, in this 23 ml volume. And so this is a study that is going on for approximately 2 years, but the data I'm going to show is for a shorter period of time. And this was a comparative study of the sub-Q version, which is, I think, 920 milligrams, versus the intravenous preparation, which is 600 milligrams. And this is the 24-week analysis that's been presented, and there are about 63 patients in each group that had completed that. The baseline data shown on the left indicates that the two arms were quite well matched. Most of the patients were relapsing remitting MS, though roughly 10% of them were primary progressive MS. This is the PK data, which demonstrates that basically, whoops, I'm sorry. How do I go back? Yeah, sorry. That basically you've got just as much ocrelizumab in the circulation with the sub-Q version as you have with the intravenous version. The area under the curve for the first 12 weeks was actually slightly better for the sub-Q version, and the maximum concentration reached was essentially the same with the two preparations. And the impact on the reduction of CD19 positive B cells is remarkable and essentially identical with the two preparations. The data in terms of gadolinium enhancing lesions is essentially the same, very dramatic reduction, lesion rate of 0.1 at week 8 and 0 in either group at week 24. The number of new or enlarging T2 lesions similarly remarkably low, as we've come to expect from the B-cell depleters. And most patients, of course, had no relapses. The adverse event profile was not remarkably different between the two arms, the sub-Q or the intravenous arm. And over the short period of time, there were hardly any serious adverse events, and those that did occur were, for the most part, probably not related to the drug. As you can see in the IV arm, there was an appendicitis, a staph cellulitis, I guess new onset diabetes, pneumonia, and one sub-Q abscess, presumably all unrelated to this intravenous preparation. And in the sub-Q formulation, anxiety, eye pain, and MS pseudo-relapse and an MS relapse. So again, probably not related to the drug. There were non-serious, mild, and moderate AEs that were essentially similar as well. So this agent may be coming to a pharmacy near you in the near future. I personally have no experience with this drug. I was not an investigator in these trials, so I don't really know how well this drug is actually going to be accepted or how many patients are going to prefer to choose a 23 ml subcutaneous, whatever you want to call it, over the intravenous preparation, but it will present an option. Okay, let's speak for a few moments about extended interval dosing of natalizumab. So as we all know, the main concern about natalizumab, at least in JC virus antibody positive patients, is the occurrence of PML. And a number of preliminary studies, retrospective studies, some years ago had suggested that extended interval dosing of natalizumab might reduce the occurrence of PML. Dr. Ryerson did a much larger study amassing data from the TOUCH program, looking retrospectively at the occurrence of PML in patients who, by accident or for whatever reason, turned out to have extended interval dosing compared to the standard every 4 weeks dosing. And this wasn't a huge increase. These on average were a little over 5 weeks, somewhere between 5 and 6 weeks. But there was a remarkably lower PML incidence. I don't personally or think anybody actually knows the reason why this might be the case, but it seemed to be a phenomenon. And that led to the performance of the NOVA trial, which compared extended interval dosing, that is every 6 weeks dosing, to the standard every 4 weeks dosing. I won't belabor this slide, but again, the baseline data indicated that the two groups were very well matched. And you can't read this, but basically focus on the zeros. For the most part, extended interval dosing compared to standard dosing was not different in terms of patients having gadolinium lesions. However, the statistical analysis did not prove that extended interval dosing was better or was equivalent, because there were two outlier patients who had enormous numbers of new gadolinium-enhancing lesions. One of those patients had actually already discontinued drug and had rebound, basically. And the other patient actually had PML. And by the way, the only PML case in this NOVA study was in an extended interval dosing patient. So because of the design of the study and the intent to treat analysis, those two patients who were outliers had to be included. And that's probably what resulted in the rejection of the hypothesis that extended interval dosing was as good or better. So you can reach your own conclusions about whether or not you want to use extended interval dosing and under what circumstances. My personal reservations about extended interval dosing, and now I'm away from fact and onto opinion, my own personal viewpoint is my concerns are not about the every 6 weeks infusion. It's about those patients that don't get their infusions at 6 weeks. I'm sure if your practice is anything like mine, you have patients whose insurance lapses, who go on vacation, who miss their doses, and these are my every 4-week patients. And if they start missing their 6-week doses and get extended beyond a couple of months, now they're running into the potential for rebound because they're no longer saturating those receptors. The clinical results basically were virtually nobody had relapses. It didn't matter which group you were in. All right, let's turn for a few minutes to the question of cladribine. And I'm not going to address whether or not or when you should use cladribine. I'm going to look at the question that I've had in my mind is, what do you do after you've given 2 years treatments of cladribine? So just to remind you about how cladribine is dosed, the recommended cumulative dosage of cladribine is 3.5 milligrams per kilogram of body weight. This is our currently only drug that's dosed by body weight. It's administered orally and divided into 2 yearly treatment courses, each of which is 1.75 milligrams per kilogram. And each of those courses is divided into 2 cycles. You start your first course. Depending on your body weight, you take 1 or 2 tablets a day for several days. And then you complete that first course about 4 weeks later, between 3 and 4 weeks later, and you take the rest of your dose. Then you come back a year later, and you do the same thing again. What do you do after that? Basically, we don't have good guidance about what to do, and I've always been personally a little bit bothered by therapies that say, give the drug and then wait till something happens. Well, the something that's going to happen statistically is going to be an asymptomatic silent lesion that you're going to pick up on MRI, because early studies of serial monthly MRIs showed that new MRI activity happens 5 to 10 times more often than either the patient or the clinician is able to recognize that anything is happening to the patient. But that's not always the case, and the event might be a relapse, and sometimes relapses don't recover. So what to do? Well, this is what the prescribing information in the United States FDA-approved drug says. It says, following the administration of 2 treatment courses, do not administer additional cladribine treatment during the next 2 years. Treatment during these 2 years may further increase the risk of malignancy. The safety and efficacy of reinitiating cladribine more than 2 years after completing 2 treatment courses has not been studied. So what do you do? Well, there are questions that could arise at various times in the course of the administration of cladribine. What if you have disease activity during year 1? What if you have disease activity during year 2, 3, or 4? What if you have disease activity in year 5 or later? And if you do give additional courses of cladribine, how many courses? Well, a recent publication by Oreja Guevara and colleagues, published last year, convened a panel of mostly European experts to discuss these questions. So this is a consensus opinions. Apparently, in the European label, there's nothing commented upon about not giving additional courses of therapy. But I just showed you what's in the US label. So if you're going to give an additional course during that immediate year or 2 after 2 years, I would suggest that you have on retainer a good malpractice attorney, because should your patient happen to develop cancer, and I don't believe there actually probably is an increased risk of cancer with cladribine, but that's in the label. If they do get cancer and you ignored this warning, I would not be the one who wanted to try to defend you. But in Europe, everybody agreed that if you have disease activity in year 1, you haven't yet completed your course of cladribine, go ahead and give the second year treatment. They said, however, if you had activity at the end of year 2, and they saw that in roughly 15% of patients, or in years 3 and 4, give an additional course of cladribine. And this is their quote: there are no label contraindications for additional courses of cladribine. Not true in the United States. Or you can switch to another disease-modifying therapy. If you have disease activity in year 5 or later, and 30 to 50% had that within 5 years of the last dose, they recommended giving additional courses of cladribine to those patients who were long-term responders, that it had been disease-free for 4 years or more, and they felt there was no contraindication to additional courses of cladribine. They're clueless, as are we all, about how many more courses of cladribine might be safe, so they advised only giving 1. So if you're in Europe, you might want to do this. If you're in the United States and you believe what the Europeans say and you're not worried about something bad happening like cancer, go ahead and do it. But I think we're still in a problem zone here. Okay, let me turn to autologous hematopoietic stem cell transplantation, and let me acknowledge that there are several people in this audience including Dr. Friedman, who's been very active in this field, and Dr. Cohen, who's the principal investigator of a trial that I'm going to talk about in a few minutes, who know much more about this subject than I. So what is this procedure? So the first thing you have to do is mobilize the patient's stem cells. And during this period, you give granulate stimulating factor, and you usually give some cyclophosphamide, which helps prevent patients from having relapses during that time. You then harvest and cryopreserve these cells and grow them up to the numbers that you need. This takes a few weeks. So these first two steps are generally done out of the hospital. And then comes the big bad period where you have to deplete the patient's immune system. And there have been various, and there are various regimens for doing this. Some are considered higher intensity than others, and the higher intensity ones, not unexpectedly, have greater risk. And during this period, the patient is basically without an immune system while these cells are all engrafting. And during that time, they're, of course, at risk for serious infection or even death. And during this period, they're in the hospital for several weeks, typically 2 to 3 weeks. And then they recover. Well, this is a kind of heroic process, but it has the advantage, potentially, of leaving the patient free of disease for many years to come, and also free of expense for many years to come, because you don't have to keep taking medicine. So it essentially gives you an increased upfront risk for the sake of being not burdened by having to take other medicines over years and not having the continued risk of those treatments. This is a table that we published in a paper that came out of the National Medical Advisory Committee of the National MS Society, which I was chairing at the time, that looked at some of the earlier studies. What I want to call your attention to is the sample size numbers. So these are all almost all retrospective single-arm studies with very small numbers. And we still lack large numbers from controlled trials. Having looked at all of the literature, these were the recommendations that the National MS Society Committee made for who should be candidates for autologous hematopoietic stem cell treatment. One was patients who had substantial breakthrough activity despite treatment with high-efficacy disease-modifying therapies or contraindication to high-efficacy disease-modifying therapies. They should be young patients, we suggested younger than 50 years, and with a relatively short duration of illness of 10 years or less. The transplantation should only be done at centers with experience and expertise in both MS care and stem cell treatment. Ideally, people undergoing that treatment should be entered into a single database registry for long-term follow-up. We still need more research about standards for cell mobilization and the immune conditioning regimen, and we need continuing research on comparative effectiveness of autologous hematopoietic stem cell transplantation and high-efficacy disease-modifying therapy. I want to call your attention to a really excellent recent review just published from Jeff Cohen's group. Lindsay Ross is the first author. That diagram I showed you, I stole from their publication. And this is their recommendation for most appropriate patients for autologous hematopoietic stem cell transplantation. There are some slight variations here from the recommendations the National MS Society made, but I think for the most part, there's pretty much agreement. Increased likelihood of benefit for younger individuals. Recent disease onset, they suggested less than 15. We had suggested less than 10. Patients should have mild to moderate disability. If you're already at an EDSS of 6 of 6.5 or worse, you're probably not going to benefit from this therapy, and the chances are that your risk for very bad complications is going to be worse. And you should have relapsing disease, not progressive disease, and continuing disease activity. And as is usual, if you're older and sicker, you're probably going to do worse and be a worse candidate for this treatment. Jeff is the principal investigator for the BEAT-MS trial, which is a very important trial that's looking at the question of whether or not autologous hematopoietic stem cell transplantation, or how it compares to best available highly efficacious therapy. So patients who are 55 or less, still ambulatory without AIDS, and have had very active disease, and remain a candidate for at least one highly efficacious therapy, which in this study includes all of the monoclonal antibodies and cladribine, are eligible for this trial, and then they're randomly assigned to one of the agents. There are a few other trials going on that also in one way or another address this question. But just to illustrate, this is a very, very difficult trial to enroll because of the stringent entrance criteria and because probably of the fearfulness of the procedure. For example, 2 days ago, I offered this trial to a 30-year-old woman who had been on dimethyl fumarate for a number of years, did reasonably well, then had a clinical relapse and was switched to an S1P receptor modulator about a year and a half ago. She's recently had, after an attack, she's recently developed 2 new lesions on our MRI scan, so she's eligible for the trial. She's an EDSS of 0, and needless to say, she was reluctant to do the trial. And actually, she preferred actually to continue on her S1P receptor modulator a while longer to see if she has more disease activity. But so even if you find patients who are good candidates, getting them to enroll is a challenge. But I think this is a critically important trial. Okay, can we discontinue disease-modifying treatments? And the best data we have so far, and we need still more data, is from the DISCO-MS trial. This is a somewhat complicated trial because it is a non-inferiority, not a non-interiority trial. I just noticed that typo. But this was a trial directed by John Corboy at the University of Colorado. It was a multi-center randomized controlled rater-blinded phase 4 non-inferiority trial. To be eligible, you could have any MS subtype. You had to be at least 55 years old. You could not have had a clinical relapse for 5 years. You could have no MRI activity within 3 years. Originally, it was 5 years, but enrollment was a little lagging, so it was changed to 3 years. And you had to be continuously taking an FDA-approved drug for 5 years at least, and it had to be the same drug for the last 2 years. The primary endpoint of this trial was new disease activity, either clinical or imaging, over the next 2 years. And to give you an example, our center contributed the most patients to this study, about 40 patients. I offered this trial to many patients, and I would say a little bit over 50% of the patients declined to participate. So patients very often have the position, if it ain't broke, don't fix it. I'm tolerating my medicine. I'm not having disease activity. I'm reluctant to change. So not everybody wants to change, but the people that did want to go into the trial all wanted to be assigned to the discontinue arm. So this is, as Mark said, I think in his talk, one of his talks this morning, this is really a time for shared decision-making. So I'm not going to go into exactly how a non-inferiority trial works, but the bottom line is that this study was not able to prove non-inferiority of discontinuing therapy. There were almost no relapses in this trial, a total of four relapses over the 2-year follow-up in this roughly 260 patient trial. But the trial did not prove non-inferiority because a few more patients had disease activity on MRI in the discontinuing arm. So I think there were 5 patients in the continuing arm who had new disease activity and 13 patients in the discontinuing arm. So it's only a relatively small percentage of patients who had any disease activity, but a few more in the discontinuing arm. We can skip that slide. So my own view of this study and how I talk to patients is, if I see a patient who is older than 55 and has been completely stable and expresses some interest in potentially stopping drug, I tell them, look, if you're somebody who really hates taking this medicine, you're probably going to be safe if we discontinue the drug and continue close clinical and MRI surveillance. On the other hand, if you're somebody who says, I could take it or leave it, it doesn't really bother me, then I say, you probably should remain on the drug. It's a little bit safer than discontinuing. The adverse events, are basically related to whatever drug you're on, so discontinuing doesn't produce any new kinds of adverse events. Okay, so I think I finished well on time with my potpourri, and I'm happy to take any questions if we have time.
First, hypodermoclysis,
Oh, that's good term, yeah.
or just shortened. It's
Yeah, I
like-
think that's what we give our cats and dogs when they got to be
Yeah,
treated.
Clysis. Okay, I have a question, and that is, how long do the GA nanoparticles stay in the circulation?
I'm not sure that that's actually been looked at, but the nanoparticle technique has been used for some other drugs, so I don't think the nanoparticles are a problem. And the GA is in the circulation continually over the month.
So I raised the question thinking about pregnancy. So the GA we have an idea about, but I don't know if we know anything about nanoparticles.
Right. True.
Okay. And then there's a question here, as a follow-up to the depot GA, would you offer to patients currently on GA sub-Q, and do you anticipate real-world clinical tolerance experiences like patients experience with Plegridy?
Yeah, so I will definitely offer it if it's available as an option for patients who are on 3 times a week sub-Q GA. I'm not sure what the relevant tolerance will be. My experience with Plegridy, remember, Plegridy was initially a sub-Q preparation like the other interferon, well, like the other, like Rebif, but it's now available also intramuscularly. In my experience with Plegridy, the reason patients did not like it often was they had very prolonged and pronounced flu-like symptoms. So I don't know what's going to be the relative tolerability, but my guess is that patients are going to prefer a once-a-month injection.
Okay. And there's some questions that don't relate to your talk, but we would benefit from your wisdom. So how often should we repeat MRI of the brain?
How often should we repeat MRI of the brain? As often as needed. I think on routine surveillance in a patient who's doing well, I think most people get an annual MRI. I think there's probably a difference of opinion, an annual brain MRI. There's probably a difference of opinion about how often to do a surveillance spine MRI. My personal practice is I tend to do them every 2 years rather than every 1 year, just because the yield is much, much smaller if you're asymptomatic. As Mark said earlier, if you put lesions in the spinal cord, you're much more likely to have symptoms than if you put lesions in the brain. I don't do routine surveillance of thoracic MRI because I have so much difficulty interpreting thoracic MRI, and the frequency of lesions is much smaller. Of course, if there's clinical reasons to do MRI sooner, we need to do it sooner. I think one thing that's very important to emphasize is getting new baseline MRIs after when you start a patient for the first time or when you switch therapy. And I usually do that 3 months after the patient starts the new therapy. There's some recommendation for doing more frequent MRIs for PML surveillance in patients on natalizumab. I personally think that's really important for people who may be JC virus antibody positive, but I personally basically don't treat patients who are JC virus antibody positive with natalizumab, so I don't need to have the frequent surveillance.
Okay, and are there any thoughts on using neurofilament light chain to guide de-escalation or discontinuation of a disease-modifying therapy? And after you give your answer, I'll let Mark yell his answer.
Well, I would certainly say at the present time, no. Subsequently, I don't know. I think that's a question that could be studied and potentially answered. Mark, you want to comment?
Actually, it was studied, and a publication just came out this past year, again from the Harvard group, where they looked at NFL following patients stopping their medicine and whether the NFL would go back up again. It was a good surveillance, and I think it was in CRD, if I'm not mistaken.
But that's not using it to predict whether or not you should de-escalate.
To de-escalate, yeah. Yeah. So the answer for those of you online who asked us to repeat this is we don't have an answer to that question. And with that, thank you very much. Okay, and so we're going to move on to our next talk from Dr. Altanedo from the Cleveland Clinic, who's going to discuss symptom management.
All right. Well, I want to start off by thanking Dr. Loveland for the kind invitation to present today, and also to the organizers of Academic CME. The meeting has been great so far. And we're going to change gears a little bit, and I'm going to talk to you guys a little bit about symptom management in multiple sclerosis. We've spent the better part of the entire morning discussing disease-modifying medications for MS. And now in 30 minutes, I'm going to teach you everything you need to know about symptom management. You know, right before I start, kind of as part of my disclosures, I do have to say that many of the slides that I'm going to present are taken from other people, predominantly from Dr. Stephen Krieger and Dr. Jeffrey Cohen. But I think the probably greatest disclosure I have to make is that I learned symptom management from Marie Namey, who was a nurse practitioner at the Mellon Center. And when I started as a faculty member, I inherited a large number of patients from who was previously at the Cleveland Clinic, Rip Kinkle, and Marie managed approximately 1,000 patients, and day in, day out, staffing patients with her. She really taught me how to do this. So we're gonna go through this and a little bit of teaching points regarding symptomatic treatment. So when we think about how to treat multiple sclerosis, when I talk to patients, I kind of divide it into kind of what we do as clinicians as three main themes. One is kind of disease-modifying medications. We've already covered that. Second is treatment of relapses, and hopefully as we're using more and more highly effective therapies, we're going to do less and less of that. Previously we had to hospitalize patients. Then we could give infusions in an infusion suite. Now we can give them oral steroids. But as we use more medications that control inflammatory disease activity, we will see less of that over time. And then last is symptomatic management, which I think is a bulk of what day-to-day clinical practice is for those seeing multiple sclerosis patients. And so I think there's a couple principles about symptomatic care. It's of course difficult to cover all of this in a single 30-minute talk, but I think one of the things that we have to recognize is that symptom care is probably one of the most important things we do because it will directly affect the patient's quality of life. Many times patients won't forward these independently. Many times one has to inquire about them, and so one has to develop a skill to inquire about these things at every patient visit. And then one of the kind of leading principles that we have is that we have to contribute factors to eliminate. That is, you can't do everything at the same time. I always say that with symptom management, you try to keep things simple. And the typical case is a person who comes in, you're seeing them for the first time for a follow-up visit maybe that you're starting in your fellowship, and it's a secondary progressive MS patient who's in a wheelchair, and they have 30 different problems, and so you have to try to address those. Of course you can't address 30, so you have to try to simplify as much as you can. And you do this by prioritizing which are the symptoms that are most important to patients, and it's very easy to ask them that. So many times when I'm in a visit like that, I can ask a patient, what is the number one symptom that is bothering you right now? Or what is the one thing, if we need to address today in this visit, can we address? When possible, we like to just use one medication at a time when we are treating these. Of course, many of our patients are going to be on a large number of medications, so one wants to decrease the total number of medications one uses. And also, we try to use medications that might affect more than just one symptom at a time. This is kind of rational use of therapeutics. And then kind of one of the principles we also talk about is that generally with symptomatic medications and generally with these interventions for symptomatic care, you want to try to go slow and taper things up over time unless they're urgently required to be addressed. And I think one of the things we have to remember is that the ultimate goal here is to improve their function. So it's quite different than talking about disease-modifying therapies, where you're saying, I'm going to start this medication, it's going to prevent disease activity, and you're supposed to stay on this medication no matter what you feel like. These medications are quite the opposite. We say, we're going to start this medication for symptomatic care, but many times you're going to tell me if it's helping you enough that it requires us to continue it. Otherwise, we will just stop it. And so kind of thinking about that in a slightly different way, I think is important. And when we're talking about symptomatic care, well, I guess the first thing we need to know is which are the symptoms that patients report the most. And the number one symptom that MS patients report is fatigue. This is quite a large study, 656. It was a survey of patients. And clearly you can see that fatigue is among the most common. Balance issues, weakness, bladder and bowel dysfunction, spasticity, numbness, pain, depression, memory problems, vision, tremor, speech, problem solving, emotional ability. All of these are symptoms that patients frequently ask about. And then I also would encourage you to think about what we talk about as hidden or silent symptoms of multiple sclerosis. One of the problems we have with the diagnostic criteria is that many of these symptoms that I just listed, and somebody asked a question about individuals who just present with cognitive dysfunction or individuals who just present with fatigue, they currently can't be diagnosed even with MS. So we kind of call these symptoms silent or hidden. And just to remind you that these can occur along the spectrum of the disease itself, all the way from a prodromal phase of MS, if you like, all the way from RIS, CIS, and MS itself. This might change with future iterations of the diagnostic criteria as we liberalize in what clinical contexts multiple sclerosis can be diagnosed. One key question to ask is, well, how do we measure these symptomatic issues? And you can ask about it as a clinician. That tends to take some time, but there's also some validated scales to do this. What we use at the Mellon Center is something called NeuroQual. This is a quality of life database repository that has been created as part of the NIH toolbox. And these are validated scales for neurological disease, and they cover different spheres: physical, mental, and social health. This is computer adaptive testing if you have that available, and therefore can be conducted in a very short amount of time and will give you granular information about each system. When we think about symptomatic management, we also think about next generation tools to take care of MS symptoms. And so one can look at experience sampling, and so this is typically done with surveys, but one can also do active tests, looking at cognitive function, looking at how the function of upper extremity and lower extremity might look. These are digital adaptations many times of what we previously described as the multiple sclerosis functional composite. a manual dexterity test, a test that measures the walking speed, a test that measures processing speed using a digital application. And then we have certain measures that we can do paper pencil for gait and posture, such as the timed 25-foot walk, the up and go test, and the 2-minute walk, which perhaps is a better reflection of long-term walking than what we typically do in a clinic, which is measure how quickly they walk 25 feet. That for us might mean something, but for a patient who is walking on a day-to-day basis, 25 feet isn't going to make or break the deal. It's how do you do when you have to walk from here to the grocery store, for example. And then finally, there's some passive monitoring that we've started to incorporate, stuff that digitally can capture what we're doing. Our telephones on ours, and sometimes our phones and even watches are going to be capturing all this data in real time. And of course, that data can then be ported back into the medical record and be used to monitor how symptoms are going. Well, who's in charge of symptomatic care? This is kind of one of the fields that is quite interdisciplinary. So it's not just the neurologist who's doing this, it's actually a team of people. It's multifaceted, and I think when we think about medical care and prescriptions, we're many times thinking about the neurologist, but also don't forget advanced practice clinicians, including physician assistants and advanced practice nurses, and even regular MS nurses as well. Rehabilitation plays an important role, physiatry, and they also have mid-level providers associated with physical medicine and rehab, and then individual physical therapists and occupational therapists. Health psychology and psychiatry play an important role, especially for the mood symptoms related. Neuropsychologists, which will help measure cognitive function and can also inform cognitive rehabilitation. A social worker that takes care of the surroundings of the patient, I think, is really important. And then collaboration with services that are not specifically neurological or neurodomains, such as urology, GI for bladder bowel dysfunction. An important thing to consider is access. How do these patients arrive at the MS center, especially those that have a little bit more disability? And then finally, education. So I think one of the things that I spend a lot of time with my new patients is educating them on what type of symptoms are you likely to experience, what symptoms can we actually address, so that they can mention them to me on our follow-up visits. So I'm not going to talk about every single symptom of MS, but I'm going to talk about the ones that we probably have most information on, and perhaps the ones that we have good therapies for and are the ones that come up most commonly in an MS clinic. So fatigue in MS, there's different types of fatigue. We kind of understand that fatigue can occur as an effect of deconditioning in a patient who might have had a recent relapse or has decreased function. There's also something called handicap fatigue, which is when a patient requires more effort than they normally would require due to the fact that they have some fixed disability. That is, walking for any of us might be easy from here to the back of the room. For a patient who has hemiparesis, they will probably expend more energy doing that, and therefore their fatigue will be greater. There's also kind of what we consider neurophysiologic fatigue, and that's motor fatigue. So that's a decrease in motor performance as effort is sustained. We typically see this in MS patients. We know that heat intolerance can play a role. We know that as ambient temperature increases in demyelinated axons, there is a reduction in the velocity in those demyelinated axons, and therefore an increase in symptoms. And then rate or temperature-dependent conduction failure may be subclinical and might worsen in exposure to greater challenges. And then also we have to remember that some of this might be related to neuroplasticity. It was talked about already, what happens in post-polio syndrome, especially as patients have had the disease for a little bit longer. We're not exactly sure why this occurs, but it's certainly true that patients who have typically high cervical lesions, there's going to be a degeneration of those axons, and there's going to be a loss of neuroplasticity over time. There's going to be energetic failure within those axons themselves, and therefore will result in greater symptoms over time. And then there's also systemic fatigue, which sometimes has been described as lassitude, and these kind of include effects that we think might relate to the infiltration of inflammatory cells directly in the central nervous system, or soluble immune mediators that might be present as part of inflammatory cascade. All of you are probably familiar with this after you got your COVID vaccine. Many of you probably felt this lassitude yourselves. So when we think about how we measure fatigue, of course, there's different scales to measure fatigue, and the majority of these are going to be self-report, and I think that the data demonstrating that these are meaningful for patients are important, and We use NeuroQual, but of course you can pick any one of these domains any one of these tools that you might measure fatigue, and they will give you actually a reliable measure. The first thing I think when we're addressing fatigue is rule out and address contributors. I think that's the most important thing. Make sure that there's no concomitant issues associated with the MS that need to be optimized before considering the fatigue to be purely related to multiple sclerosis. The type of stuff we think about is sleep problems. So if a patient certainly is not sleeping, if they have obstructive sleep apnea, that of course can increase your level of fatigue. Depression, we typically screen for that using the PHQ-9, but you can use any depression battery to do that. And then other metabolic abnormalities, vitamin deficiencies, thyroid abnormalities, and anemia. So think about the general medical things that might cause fatigue in any person before you blame the fatigue on multiple sclerosis itself, because those typically can be treated. One of the things that we do first when we're addressing fatigue is heat management, and heat-related increased symptoms generally are self-limiting, but they can be quite disruptive and decrease quality of life. We ask patients to limit activities in hot environments, use air conditioning, use cooling vests, cool bath shower as needed, and there has been some people that have used aspirin also to treat that heat intolerance. Exercise is also an important tool that is a non-pharmacological tool to address fatigue. There's approximately 45 trials that have evaluated different types of exercise interventions, a total of 69. These have included stuff like endurance training, motor power training, task-oriented training, and other mixed formulations, including stuff like yoga. And based on 26 trials with a non-exercise control, it has been demonstrated in these meta-analysis that there's a significant benefit of exercise. And you can see here a statistically significant effect in that meta-analysis. And the mechanisms through which this happens haven't fully been elucidated, but might include muscular conditioning, cardiovascular conditioning, production of immunomodulatory and neurotrophic factors. So we know exercise helps. There was a time back in the 70s when neurologists would tell their patients, don't do any exercise because we actually think that's hurting multiple sclerosis. We now know that that's not true, and there's basic science evidence that demonstrates that exercise actually can promote remyelination itself. And in the main ACTRIMS forum session we are going to be tackling, there's a specific session on rehabilitation where several of these topics are going to be touched. Medication management, this is management number 1. This is the medication I probably use as my first line. It's a medication called amantadine. Was discovered when a patient had kind of responded that when using amantadine for viral prophylaxis of influenza, they had improvement of their fatigue. And the treatment has been shown to be effective in randomized controlled double-blind placebo trials. It's an antiviral agent, as many of you probably know, and it's also a dopamine agonist and an anti-glutamate properties. About a third of patients with mild to moderate fatigue report short-term improvement when this medication is used. The dosage we typically use is 100 milligrams twice a day. And typically what we do is we ask them to take the first dose early in the morning, and then the next dose I typically tell them to take it around 2 p.m. or so early in the afternoon to maximize their effect. You can use drug holidays from time to time if they're noticed that the medication is no longer effective, and we typically do that to prolong the effect of the medication. Of course, like any medication, it might have some side effects, including nausea, lightheadedness, insomnia. We typically follow liver function tests. There can be confusion, hallucination, dry mouth. Levator reticularis, which is what I am showing in the figure right there, is a known side effect of this medication, and every time I'm starting this medication, I'm telling my patients about this. It typically reverses once the medication is stopped, but if it is not stopped, sometimes it can leave permanent skin damage, and therefore it's important to counsel patients about that. Medication management number 2 are stimulant medications. Stimulant medications are approved for narcolepsy and excessive daytime sleepiness, as well as shift work sleep disorder. The 2 medications we use the most are modafinil and armodafinil. The doses are listed there, 100 milligrams every morning or 200 twice a day. And once again, that middle dose, typically don't give it at night. You typically give it around the midday time. And these medications have a little bit more of an on-off effect, and they also have a little bit more of a discomfort situation, can produce a little bit of tachycardia, and sometimes produces a little bit of a sensation that the patient is a little bit revved up, which some patients do not like. Side effects: headache, nausea, anorexia, constipation, nervousness, anxiety, insomnia, the typical stuff that you would expect. There can be hypersensitivity reactions such as Stevens-Johnson's, so I typically counsel patients about that. Psychosis can occur in hallucinations, suicidality, and dependency, and therefore one has to really do a careful job of interrogating any associated mood disorders before starting this medications. And so, as I said, the effects of modafinil especially are quite on and off. They're quite quick. And our modafinil has a slightly more attenuated response over time, and different patients respond differently to these medications and might have a preference. And once again, holiday can be used. Methylphenidate is another type of stimulant medications. Indications include ADHD, narcolepsy, and daytime somnolence. The doses, once again, are listed there, can be used BID or TID for the immediate release forms, and can be used QD or BID for the extended release forms. Medication is a DEA Schedule 2, and therefore one has to be a little bit more careful with this. And once again, the side effects are very similar to the modafinil and armodafinil. And I think here with this medication even more, one has to be very careful about associated mood disorders. I have to say that this is not a medication that I'm typically using. Typically I try non-pharmacological things first. If that doesn't work, I typically try amantadine, then I go to modafinil. I typically don't prescribe methylphenidate myself. If patients come on it, sometimes I continue it if there's really no other option. I think the side effect profile of this medication makes it a little bit harder to use. And so across these lines, we've always kind of had known that these medications work, and each individual observation has some clinical trial data associated with it, but there really haven't been large comparative trials. And this was a trial that was done by the group at Johns Hopkins and was published in 2021. It was a randomized double-blind crossover 4-sequence multi-center trial. So 141 participants were enrolled. They treated patients for 6 weeks, separated by 2-week washouts with one of 4 treatment arms, either amantadine, modafinil, methylphenidate, or placebo. Interestingly, when they compared these, they found no benefit on the primary outcome, which was the Modified Fatigue Impact Scale, or secondary outcomes, which was the Epworth Sleepiness Scale, Hospital Anxiety and Depression Scale, Neuro-QoL Fatigue Item Bank at the group level. Amantadine, modafinil, and methylphenidate were not superior to placebo in improving MS-related fatigue and caused more frequent adverse events. And so the reality here is that although we don't have good clinical trial data to support the use, for example, in this comparative effectiveness study, remember this is only 141 patients, and remember that this is not like a disease-modifying treatment. This medication is used to improve a symptom. If it improves the symptom, it's achieving its goal. It's not like a trial where you need to know if the medication is going to decrease long-term disability. So since your outcomes are so immediate with many of these symptomatic therapies, many times you don't necessarily need a clinical trial. You just need your clinical judgment. Next, I want to talk a little bit about spasticity management, because it is certainly a common occurrence in patients with pyramidal weakness. The studies that have reported on the prevalence of these are a little bit old, but you can see prevalences that range from 70 to 85%. Across approximately 21,000 individuals who've been treated with MS. And the goal of treatment with spasticity is to improve mobility, also to improve sleep, perhaps decrease pain, and facilitate hygiene. How do we measure spasticity? So in the clinic, something that we don't teach our neurology residents to do well, we teach this generally in the neurology fellowship, is the Ashworth scale of spasticity. And so here it is. It goes from grade 0 all the way to grade 4. And this can, of course, be done in a slightly more kinematic way, which is a little bit more data-driven. But generally, we use this and we track it in our patients, specifically on the physical medicine and rehabilitation side. So general approaches for this, I think one of the most important tools that we have to address spasticity is prompt referral to physical therapy, address concomitant medical issues, which may increase tone, stretching, that is what something the physical therapists do, has to be directed by then. It has to be frequent and targeting the important muscle groups that are causing the spasticity. And the only way to do this is to do a detailed spasticity examination. I always remind patients that it is really important to do stretching multiple times a day, or else the effect of the stretching exercise really doesn't provide significant benefit. I think one important thing here is to exhaust non-pharmacological approaches first. Why? Because the medications we're going to use for spasticity are medications that induce muscle weakness. They're decreasing muscle tone. And a patient who already has some pyramidal weakness, increasing their weakness with the medication, one, can make them a little bit more unstable in terms of their walking, and two, can have associated effects in the central nervous system. If pharmacological therapies are needed, monotherapy is the best way to start. If monotherapy doesn't work, you can add a second treatment, and then that's where you really have to play with the timing of the doses that you're giving patients. And then finally, surgical and interventional approaches can also be used. Medication management for this, we're going to go through a couple of the medications that we most commonly use. The number one is medication that we most use to treat spasticity is baclofen. This is a GABA B agonist that is active in the spinal cord and the presynaptic inhibition, and therefore it is exerting its effect exactly where we think spasticity is coming from in multiple sclerosis. We actually recommend that the dosage is started low, somewhere between 5 and 10 milligrams BID or TID, and it can be adjusted up as high as 80 milligrams per day. Overall, the medication has low CNS penetrance, and therefore you have to use relatively high doses of it. And when that occurs, you tend to see fatigue, somnolence, dizziness, and GI symptoms, and can worsen pre-existing weakness, as I already described before. Remember that PM dosing may be helpful because it can increase or improve sleep, and it helps with early morning spasticity, which is a common occurrence in MS patients. Medication number 2, which is generally my second line of treatment that I go to, is a medication called tizanidine. This is an alpha-2 adrenergic agonist. Once again, we typically start low with this medication. 2 milligrams HS is typically where we go, and then you titrate 6 to 36 milligrams divided in Q8 or Q4 hours. Side effects of this medication include dry mouth, sedation, dizziness. Typically, you do have to monitor CBCs and LFTs when using this medication, and it can accentuate weakness and ataxia, but it does so less than baclofen, and so that's kind of one of the reasons we're adding it on. It can also help ease back pain. It can also help with headache, RSD, and neuropathic pain, so think about that when using it for more than one indication. Other medications that we can potentially use for spasticity includes benzodiazepines. They facilitate GABA throughout the CNS, and the problem is that they have a powerful sedating effect, which tends to be dose limiting. HS dosing, of course, is beneficial, giving the dose at night, and long-acting medications such as diazepam are preferred over short-acting medications, as one would expect. Gabapentin, when used at slightly higher doses, has a GABA agonist effect, which can induce muscle relaxation. So in a patient who has a comorbid condition associated with pain or sensory symptoms, sometimes it's a good choice. Dantrolene depresses excitation contraction directly at the muscle level and therefore has less CNS effects, and therefore can be used when CNS inhibition is one of the problems that one is having with these treatments. But it can cause significant weakness, and of course there's a lot of GI-associated side effects. Cannabinoids are medications that many times I think anybody who's seen an MS patients will get the question about cannabinoids. We think that the CB2 receptor effects will decrease spasticity and may help with pain, tremor, and ataxia. Certainly in the US, we don't have an approved therapy that targets the cannabinoid receptor, but that is available in other countries, and certainly in places where medical marijuana can be prescribed, is many times used for patients. In terms of the interventions, when these medications are not working or are having side effects that are resulting in non-tolerability, Botox is an interesting approach. It blocks ACH release presynaptically. The advantage of Botox is that it will have little systemic side effects. The one problem with it is that if you're producing significant weakness in given muscles, it might affect gait. But the advantage of Botox is that you can target very specific muscle groups at a time. Disadvantage is that treatment has to be repeated at 3-month durations. May be difficult to get insurance approval for this, but once again, this is something that can be done by the neurologist or by your PM&R specialist. So we tend to use this medication with PM&R, typically when there's treatment-resistant spasticity. Intrathecal baclofen is an important type of intervention. Why? Because we know about the systemic side effects of baclofen. We have to use relatively high doses to establish CNS penetrance. Using intrathecal baclofen, one can use a very small dose of baclofen that typically will stay in the spinal canal and will not produce as much sedation. This is administered through a test injection, and then one has to perform a surgical procedure to install a pump that delivers baclofen intrathecally. The pump, of course, requires refill and needs to be turned off, and one can experience infection in those pumps and also in the wires that lead the medication into the spinal canal. Watch for withdrawal overdose, which can be life-threatening with this medication, so it has to be managed very carefully. And one of the issues with baclofen is that since it's so powerful and it produces so much muscle relaxation, generally it's something that is reserved for patients who are typically no longer ambulatory. It's a great option for a patient, for example, who needs help with their spasticity for typically hygiene effects and also for comfort in a patient who's already wheelchair-bound. All right, shifting a little bit to bladder dysfunction, which is a common symptom of MS. This can occur as a product of impaired storage, and this is something we term detrusor hyperreflexia, or a spastic, overreactive bladder, as you would expect, or it can also occur as a problem with emptying. And that can range from basically a low stream of urine to a complete retention that I'm sure many of you have seen. There can also be a completely flaccid bladder. And then finally, outlet obstruction due to structural detrusor sphincter dyssynergia can also occur. And many times, these pathologies are going to be combined. And so, depending on where the nervous system is being affected, you can either have an overreactive detrusor or underreactive bladder. And these all have to occur in a synergistic way in order to allow normal voiding. And many times, that does not happen. General treatment approaches with bladder, same as what we've done with all our others, is try to think about the things you can do without medications first before you try thinking about medications directly. Schedule voiding sometimes help, distraction strategies, Kegel exercises, avoiding irritants such as spicy food and certainly diuretics, fluid management and restrictions, DDAVP can be used, management of constipation, weight loss, and smoking cessation all have been shown to be effective in overactive bladder. When there is hyperactivity, anticholinergics such as oxybutynin, tolterodine, tropsium, darafenacin, and sulfasenacin all can be used. Tricyclic antidepressants and also effective for this hyperactivity with its anticholinergic effects. And when there's impaired emptying, one of the easy ways to treat is with increased Valsalva, the Credé maneuver, which can be taught to patients, and our physical therapists many times do that. Thinking about an impaired emptying, cholinergic agents that might increase the flow. Bethanacol is one of the ones that we use. And then catheterization, which can initially be intermittent and sometimes requires chronic. And finally, urinary diversion is something that we also use when bladder management becomes an issue. Certainly with outlet obstruction, alpha-adrenergic medications, intermittent cath, and diversion are our mainstays of treatment. Other interventions that we can do, similar to what we do for spasticity, essentially what you have is an overreactive muscle. So you can also give intradetrusor Botox, and this can be used quite effectively, typically done by urology. And then something else that can also be done is sacral neuromodulation to affect bladder function. Other symptomatic approaches, I've kind of listed these out here kind of as a review or summary. Mobility issues, typically we think about rehabilitation and then pharmacological effects with 4-aminopyridine and dalfampridine to increase walking speed. We want to address depression and mood disorders with psychology, and when psychology is not enough, typically address pharmacologically, tricyclic antidepressants, SSRIs, SNRIs are of course important. Pseudobulbar affect can happen in MS, and we do have medications that are effective against that. Dextromethorphan and quinidine combination is quite effective at treating pseudobulbar affect. And then pain, I would say, is common in MS, and I think one of the things that is important is to address psychology early on for patients who have pain, because a lot of the component of chronic pain actually can be modulated through psychology. If that doesn't work, pharmacological therapies that address neuropathic pain are important. Include tricyclic antidepressants, anticonvulsants, SNRIs, SSRIs can all be used. We have a rule that we do not use narcotic medications to treat MS-related pain. At some time, many MS clinics had a lot of patients who were on chronic opioids, and I think the field has mostly moved away from that, and now it's actually a rare occurrence. And then for cognitive dysfunction, always, of course, think about cognitive rehabilitations. So in conclusions, when we think about symptomatic issues, assess symptoms at every visit, assess them frequently, embrace a multidisciplinary approach, prioritize the most bothersome symptoms and address them one at a time so that you're not encouraging polypharmacy. Have a systematic approach to or a system of how do you approach every problem. And this sometimes sounds a little bit like a trick, but what I tell my fellows is you need to know what are the 3 things you first do for spasticity. You need to know what are the first 3 things you do, for example, for an overactive bladder. And if you have a system for it and you apply it over and over, you'll generally get better at it. Prioritize interventions that affect more than one symptom, monitor the effectiveness of treatment frequently, always try non-pharmacological approaches first, avoid polypharmacy, and at all costs, avoid narcotics. And with that, I'm going to thank you for your attention.
Okay, so any questions from out there while I look to see if there's any online? Okay, let me just see. Okay, we have two. What are your thoughts on inclusion of an MS neurology clinical pharmacist in the practice?
Yeah, so I think a pharmacist is really helpful for several reasons. I think on the one side, a pharmacist will be helpful in guiding how we use disease-modifying medications, and a lot of the job that our pharmacists do relate to making sure the medication gets approved, making sure the monitoring is done. But I think the second thing that a pharmacist is quite effective at is managing polypharmacy. Typically what we do is when we have patients who are on a lot of medications and we're considering institution of a new medication, that's typically when we put a referral out to our pharmacist. We say, hey, I'm going to start this new medication. I'm a little bit worried because this patient is on a very large number of medications. Could you please take a look through and see what you can prioritize? So I think he's part of one of the players of the multidisciplinary team.
Okay, and then there's been very little discussion around drug-drug interactions in spite of potentially relevant reactions between DMTs and commonly used symptomatic therapies.
Yeah, this is a great point. I think that in any patient that is using a very large number of medications, one has to think about drug-drug interactions. Fortunately, for the vast majority of the medications that we use from a DMT standpoint, we do a very careful screening, typically with a pharmacist, on what medications could be contraindicated. I think this is most notable for typically our S1P modulators, and we've already heard a little bit about the effect that those medications have on the heart. And so I think keeping attention to those, because many of our medications that we just described might have concomitant heart effects, are important. Certainly, I think the key thing here is that you have to go back to your days of a medical student and make sure that you put your patient's medication lists in the up-to-date or whichever software you might use to look for contraindications between medications, but that's probably the best place to start.
And there's a reverse phenomenon, that is using a medication that has multiple actions to take care of things. And the one that sticks in my mind is tricyclic antidepressants for a patient who's not sleeping well, has pain, and has a hyperactive bladder. So try and take care of multimodal effects of the medication. Last question will be, how much effect has cognitive rehabilitation been shown to have in MS patients? What's your experience?
Yeah, so we don't have a lot of experience running trials in cognitive rehabilitation, but there's certainly been a very large number of trials. A multi-center international trial that was just published in Lancet Neurology just this last year, and basically showed that cognitive rehabilitation has a significant of loss in patients with multiple sclerosis. So there is good clinical trial data on cognitive rehabilitation. My personal experience with cognitive rehabilitation is that for patients that have frank cognitive dysfunction, they many times find it quite helpful to do cognitive rehab because it focuses on things that they can notice an effect on. Where it's a little bit harder to do is in individuals who are very high functioning, who have cognitive deficits that are perhaps very mild. You send them to do cognitive rehabilitation, and many times their answer is, you know, I'm a lawyer. The type of things that I'm doing in cognitive rehabilitation are not the type of things that I have problem with. I think much more, you know, we have to put a whole lot more effort in that type of cognitive dysfunction in our field.
One last quick one, approaches for safely managing spasticity in pregnancy.
Yeah, so that is certainly a challenge because many of the medications that we use for spasticity are contraindicated. You know, certainly medications that might have less of a systemic effect can be an option. So, you know, occasionally Botox given focally is an approach that we take. And really, I think you have to double down on the physical therapy side of things.
Great. Thanks so much, Dan. Okay, moving along, our next talk will be on family planning from Amy Perrin-Ross, an advanced practice nurse from Loyola University in Illinois.
Well, thanks, Dr. Lublin, and I'd like to also thank the academic CME folks for inviting me to do the presentation today. I have all of 20 minutes to go through everything you ever wanted to know about family planning. And looking at my practice, I think that many of my patients have learned everything they needed to know about family planning in 20 minutes, if not more. So thinking about family planning, honestly, it's a vital component of comprehensive care for MS, and I think that's one of the things we've really addressed a lot today. But we need to think beyond planning for pregnancy. We need to think about things like surrogacy, things like adoption, other family building methods, including involving same-sex couples, single individuals with multiple sclerosis, as well as individuals with fertility issues. So until the 1950s, women were actually advised not to have children. But attitudes have changed dramatically, and I remember when I started in the mid to late 80s in multiple sclerosis, I worked with a very visionary chairman who used to advise all of his women that permanent pregnancy was the cure for multiple sclerosis because we didn't have disease-modifying therapies. We were at least 10 years away at that point in time. So the attitudes have changed dramatically. We no longer dissuade people from pregnancies, but what we try to do as clinicians is help people think about the whole broad spectrum of not only pregnancy, but family planning and what it means after you have the child and the concept of raising the child and all of the things that go with it. So there's a lot of optimism and a lot of hope for people who want to have children these days. So we know that MS is an immune-mediated chronic disease with a significant female predominance. Now, it primarily affects women in the reproductive years, but some of the things that we're increasingly learning these days is that pregnancy involves a state of immune modulation rather than immune suppression. And I know sometimes we get caught up as clinicians about what's suppressing the immune system, what's modulating the immune system, what's tweaking it, and so on. So you can see the multiple different hormones that are included in pregnancy, and these hormones basically increase in pregnancy and decrease after delivery. So let's think about contraception. About 87% of women in the United States use contraceptives during their lifetimes at some point in time. And recent United States CDC guidance offers or considers most forms of contraceptives safe, but they do note that we ought to be thinking with caution about our patients who are experiencing prolonged immobility combined with hormonal contraceptive use in terms of the increased risk of thromboembolic events in those patients. There's also a discussion that current disease-modifying therapies do not impact contraception, and potentially negative oral hormonal contraceptive interactions with many of our, not just our disease-modifying therapies, but with our symptom therapies that we've talked about all along. So we have to think about that interaction. When we're thinking about contraception, the goal obviously is to avoid accidental pregnancy exposures, and it's really important to have this discussion, and not only to have it once, but to repeat it and to reinforce that information in our ongoing contact with our patient population. Now, long-acting reversible contraceptive is preferred for its high efficacy and its ease of use. So the long-acting reversible contraceptives, including the subdermal rods and the IUDs. So going from contraception to thinking about fertility and fertility treatments in terms of family planning, a greater proportion of women with MS have had a diagnosis of infertility compared to those without MS in a small study that was reported in the article by Molman and colleagues that was just released in Practical Neurology, January, February 2024. And I would like to point out that Dr. Molman is a MS fellow, and her two co-authors were neurology residents PGY3 and PGY4, all from the Rocky Mountain MS Center in Colorado, and they've done a superb job of putting the article together about family planning. A recent study reported no increase in relapses after a variety of fertility treatments, including in vitro fertilization. And the calls that I'm getting more and more recently about fertility and fertility treatments go back to OBGYNs that have a lot of old misconceptions about, number one, fertility treatments, but also about pregnancy in women with MS, about anesthesia in women with MS. Women with MS, just because they have MS and may happen to be pregnant, do not constitute a high-risk pregnancy. And that's something we tell our patients over and over again. So what about pregnancy planning? As I mentioned, we should be discussing this not just the first time, not just when it's, some patient brings it up, but we ought to have this discussion with our patient population on a repeated basis. We do know that pregnancy is associated with a decrease in relapse and MRI lesion activity, which tends to be most marked in the third trimester, and this may represent the hormonal and immune shift. So what about some of the issues for counseling our patients with respect to pregnancy? Well, MS typically has little impact on fertility, pregnancy, or fetal viability. There doesn't seem to be an increase in birth defects just based on MS alone. There's no increase in either abortions or ectopic pregnancies, and no impact on the type of delivery. And again, I get a lot of these questions because patients are told by their obstetrician that they need to have a section and they need to, because they are at high risk and whatnot. So we try our best to work with our obstetrician colleagues. No limitations on the type of anesthetic used for delivery, and actually no negative impact from a father with MS. Some additional issues for counseling. Pregnancy does not worsen the long-term MS prognosis, and actually a few studies say that the prognosis may actually improve. I think back to one of the patients that we saw back in the 90s who took my chairman's advice about multiple pregnancies very seriously. She ended up having 12 children, and she actually runs a horse farm way out in rural Illinois where she does hypnotherapy for people with multiple sclerosis, but she tended to do quite well despite 12 pregnancies. I don't know that I would do that well with 12 pregnancies, and I don't have MS. So, what we saw was that MS disease activity decreases during pregnancy, again, typically during the third trimester. However, relapses can and do occur during pregnancy. So what about relapses and family planning? Well, relapses, we know, tend to be less common because of the hormonal and immunologic changes during pregnancy. But the result from the PRIMS, or pregnancy in MS study, showed a drop in annualized relapse rate from 0.7 prepartum to 0.2 in the third trimester, which was a 70% decrease. If a relapse occurs and treatment is needed, steroids including methylprednisolone and prednisone are preferred over dexamethasone, which can actually cross the placenta. And the ideal time, if we've got to treat a relapse, there's no ideal time for a relapse at any point, but if we're treating our patients, the ideal time would be after that 10th week of gestation, just in terms of fetal development. Plasmapheresis for our pregnant patients, if that's needed, has been shown to be safe, but we really do need to pay attention and watch for rapid fluid shifts. So what about MRI during pregnancy? Ideally, if we've got somebody who tells us that they're planning pregnancy, we would have a preconception MRI done. Thereby, if we had an episode where we felt there might be a relapse during pregnancy, we could do a non-contrast MRI. And if we saw even new T2 lesions, we wouldn't need the contrast to tell us that, yeah, that's probably a new relapse. So just a note that there are the 2018 AAN practice guidelines for MS disease-modifying therapies, and hopefully some updates relatively soon. So let's think about MS DMTs. And again, Dr. Coyle, who's part of our faculty today, has done quite a bit of work in presenting on this the concept of DMTs, and I'm always quite impressed when she's presenting, because she's always updating her information and therefore her recommendations. These recommendations not only come from stuff that she has presented, but stuff that was presented at ECTRIMS and some of the more current work from the Molman publication. So there have been thousands of episodes of human pregnancy, particularly with exposures to gluteramine acetate and the interferon beta, with no teratogenicity. We talked about that a little bit earlier this morning. Our experience in my own practice is that in the event of us feeling that we need to treat a woman during her pregnancy, regardless of what she was on pre-pregnant, we've gone to gluteramine acetate, and we've done it successfully in terms of managing the disease as well as looking at happy, healthy babies and successful pregnancies. There is no washout requirement with GA and the interferons, and it can be used during pregnancy and breastfeeding. Washout has been recommended with the S1P receptor modulators. If we are using teriflunomide, pregnancy should be excluded prior to starting it, and if the woman chooses to plan a pregnancy, it's recommended that she undergo the accelerated elimination process. And there is no washout for dimethyl fumarate because of the short half-life. You can see the recommendations for cladribine, and we've talked about that. Notably, in terms of natalizumab is often used without a washout and sometimes continued into pregnancy. In terms of breastfeeding, no evidence for negative effect of things like gluteramine acetate and interferons. Most, but not all, studies do report a decrease in disease activity in women who are breastfeeding. But when we talk about breastfeeding, we have to emphasize with our patients, this has to be exclusive breastfeeding. This is no, 2 bottles a day and a little breastfeeding right before bedtime at night. This has to be exclusive breastfeeding to get all of the benefits here. The degree of suppression of disease activity really is unclear. It hasn't been studied, but breastfeeding for around 15 months actually may lower the maternal risk for MS, and it may also lower the infant risk for MS. If the woman needs steroids for a postpartum relapse, they can breastfeed with steroids after a period of 4 hours. They can also breastfeed with the interferons as well as glutathione acetate. And there are a number of folks who will be comfortable with the concept of breastfeeding with the monoclonal disease-modifying therapies. So looking at postpartum issues, one of the things with respect to postpartum is that often MS symptoms and postpartum issues are not easily differentiated, especially if this is a first pregnancy. How much of what the woman is experiencing may actually be MS symptoms, may be postpartum depression, may be just hormonal changes as time goes on. Very difficult for the woman herself to be able to identify, certainly difficult for us as clinicians to identify. Some of the things that were previously talked about with respect to symptom management, fatigue, sleep disruption, and cognitive changes are common. They're common postpartum, they're common in MS. We put the two together, and often they are worsened in that time period. We can also see numbness and increased in spasticity, as well as bowel bladder changes that can and do occur postpartum. And so what's very helpful is that a third trimester visit with the MS healthcare provider can sort of help to establish a baseline, if you will, and we talk about strategies for after delivery management. We talk about what decisions the woman has potentially made with respect to breastfeeding. Does she want to continue? Does she not? What are we going to do in terms of restarting disease-modifying therapies? The sooner we do that in some situations, the better. But we also can talk about the fact that peripartum depression and anxiety are a very substantial concern. Premorbid mood disruption actually is the greatest risk factor for postpartum depression. And finally, then, in summary, family planning and contraception should be discussed with all appropriate, particularly newly diagnosed MS patients, as well as their partners. And again, we need to think beyond the traditional male-female couple. In many situations, we need to be as open-minded as possible and broach the subject of family planning, things like surrogacy and whatnot, with all of our patients. We want to do our best to provide accurate information and guidance around pregnancy, as well as disease-modifying therapy use, and all healthcare professionals who care for patients with MS need to be up to date on gender-based issues. And on that, I'll thank you.
So you may have touched on part of this, but what are the theories behind why pregnancy improves the MS prognosis and decreases relapse occurrence and MRI lesion activity, and what happens in the postpartum period?
Well, the theory is with the hormonal changes. There's also the theory that there's a Th1, Th2 shift as pregnancy goes on, and we see less inflammatory activity, which may be, part of the reason why people feel better, about why women feel better during pregnancy. And postpartum, if the woman is not exclusively breastfeeding, we see that somewhat abrupt shift back to normal hormone situations, and sometimes an increase in inflammatory activity.
Yeah, we worry about those 3 months. There's some data that goes both ways, but there's more data suggests an increased risk. Okay, and one more that's actually kind of very important. How about family planning for men and DMTs?
That's a really good question. We talk about, particularly with drugs like teriflunomide, where we have a very long washout, we would recommend that if a male is taking teriflunomide, and he wants to father a child, which, as you know, males can father children much, much longer than women can have children, that he undergo that accelerated elimination procedure as well. There's no increased risk in terms of infertility, but we look at very similar washouts from males as we do females.
Okay, and you already discussed breastfeeding, so good, thank you very much. Okay, next we're going to hear updates in MS healthcare disparity, optimizing care strategies from Rob Naismith from WashU.
Hi, everybody. Rob Naismith from Washington University. Thanks to Fred and Tim and the rest of the academic CME group for inviting me back. And I really enjoy doing this lecture, and I liked doing it last year because it gave me a chance to reflect on what I'm doing in my own practice, because my practice is never static. I'm always making changes. So people came up to me after the lecture last year and were wondering what they can do for their practice. And it's amazing, you know, how willing people want to help in medicine. So I reached out to my neurology business clinical practice manager, inquired about social services that can help out, set up some phone calls, emails, some meetings, put protocols in place, some Epic templates. We were able to get better social work support for our MS center. And the other reason why I like doing this is because there's a lot of enthusiasm from people in the audience, particularly the residents, fellows, and junior faculty that have a lot of passion for doing the best that they can for their patients, and that you have a lot of influence to make changes and to, as I say, find a way or make a way. So you have a lot of power and ability to kind of think outside the box and do things to help your patients. So it gives me a chance to reflect on what I'm doing and how I can improve it, and I invite you to do the same and think about what you're doing and what ways you can improve it as well. So this goes back a long time, probably since the beginning of writing in human history. The concept that health relates to where you are in life and your resources. But a lot of this in the modern era stems from the 60s. So this has been ongoing for many decades. Back in the United Kingdom, Wilkinson and others put together this Whitehall Civil Service Studies in the 60s and noticed that you can't explain health just by looking at diet, exercise, smoking, and access to your doctors. There are other parts of life that factor into how well you do or how well you don't do. And a lot of this revolved around job control and security, social support, effort and reward balance, your social networks, and your control outside work. And a lot of this has been tied into sort of the stress response. And we know that the stress response is really key for autoimmune diseases like multiple sclerosis because these things all feed into the disease process as well. And it was with this observation that as countries made economic progress, there was fragmentation of different populations where some had more than others, and this was associated with differences in health outcomes. So this presented a great dilemma, and people have been struggling with how to bridge this gap continually through this time. Even like in the 90s when I was in medical school, there was a huge emphasis at Case Western Reserve on social determinants of health and doing home visits and thinking about getting a very detailed social history and understanding the patient. So this is a continuation of many decades of trying to do better for our patients and struggling with very difficult issues at hand. What's great about this profession is that we really are here to do the best for our patients and take pride in being sure that our patients are well taken care of. So we take the Hippocratic Oath from the old translations. You'll help the sick. The newer one, I will remember that I do not treat a fever chart, a cancerous growth, but a sick human being whose illness may affect the person's family and economic stability. My responsibility includes these related problems if I am to care adequately for the sick. So it's our ethical imperative that we do what we can for the people that come see us to try to get them to feel better, prevent new problems from arising, regardless of where they're coming from or their outlook on life. So for those of you that were here last year, I did give a brief, I gave a case presentation about a patient that I've been following for some time, just as in terms of summarizing and providing some updates. This is a 39-year-old Black American woman, single, currently on Medicare with a high school education and on disability. And she has 5 children. The oldest is 26 and she's 39, so do the math there. So she, definitely has had a lot of struggles. She's widowed and she got Medicare in 2014 and was on Medicaid before that. So I met her in 2007 when I was attending in the resident clinic, which I don't do too frequently. But I recognized that she was really in trouble. She had a lot of disease, a lot of ataxia, even at an early age. And I pretty much said, I need to take you into the MS clinic to make sure that you get on treatment. We can kind of look over things very carefully, like in the MS clinic setting and not the resident clinic setting. And we put her onto Sabri, and she'd been on that for a number of years on and off, had some pregnancies in between. But unfortunately, in December 2014, became HIV positive. So despite having a very severe inflammatory disease, we had to stop the Tisabri, and we're treating her intermittently, first with glatiramer and then interferon. And she's really struggled with her HIV medications. And this, I think, worsened when her fiance and father of her children died in 2020. And at the time when I presented her last year, her CD4 count was less than 35, and her HIV was over 155,000 copies. And really kind of at a loss as to what to do in some ways, and because I realized that I'm under-treating her, but I was kind of stuck. We've contacted the social workers and the ID clinic, and she's back on her medications, and as of like 2 months ago, her CD4 count is now 94 and her HIV is undetectable. So I have an appointment with her next month. I'm really looking forward to hearing how she did it, what were the things that kind of made things change her view of taking care of her HIV, and putting a plan together with her in terms of, what other therapeutic options we can select amongst if we're able to get her CD4 counts up higher. So I'm looking forward to seeing her and working with her to figure out like how she did it and what we're going to do next. So a lot of this literature on Black Americans with multiple sclerosis coalesced in the 2000s. And it was pretty consistent, regardless of where you were, whether it was in New York, St. Louis, Detroit, California, no matter what parameter you looked at, Black Americans with MS did worse than white Americans. Whether it was relapses, time to disability milestones, MRI lesions, spinal cord atrophy, OCT results, CSF parameters, they were all worse amongst many different investigators. So it was a very consistent finding, and this has been appreciated for several decades at this stage. The surprising things were that there was not a great difference in the time or the age to diagnosis or treatment. Black Americans were quite comparable in terms of the age of diagnosis, the time to treatment, and the percent who were treated. This kind of brings up two questions. Number one, is this sort of a representative sample? Because a lot of these places are at academic centers, and perhaps these are the worst cases, and we're missing a lot of the worst case, the less severe cases out there. So it could be a biased sample because it's academic center, or it brings up the issues: is autoimmune disease worse in Black Americans? And that's something that I wonder, because I've seen some really dramatic cases as a resident, in particular with different autoimmune diseases, whether it's MS or lupus. It's quite striking in some regards. So I think it's probably a little bit of both, because we know that there is some disparity in the access to care. So here's a study that came out in 2017 by Sadi, who found that Black and Hispanic Americans are 30 to 40% less likely to see a neurologist. Here you can see that with multiple sclerosis, out of all the conditions here, they looked at Parkinson's, MS, epilepsy, headaches, and cerebrovascular disease. MS for the entire group seemed to be at the higher end. As an MS specialist, I still think it could be higher, because I think people with MS should see an MS specialist specifically. But they found, even after controlling for all these different parameters, they found that the access across neurologic diseases in its totality was less. They weren't able to have the power to look at MS in particular, but they found that 30 to 40% less likely to see a neurologist overall. And then here's another study that found very comparable results, doing telephone surveys of over 2,000 patients with MS, and 72% saw neurologists for their MS care, whereas about 20% saw their PCP and 8% others. So again, I think if you have MS, you should really see an MS specialist. But being a Black American had an odds of about 50% of seeing a neurologist. And we know that seeing a neurologist or an MS specialist is going to be superior because we have greater familiarity with disease-modifying therapies, optimizing treatments, outcomes, monitoring for safety, rehab, OT, PT, multidisciplinary care. So I think seeing an MS specialist is really the standard that MS patients should follow in 2024 and beyond. And a recent study by Marissa McGinley found that telehealth utilization was less for older individuals, Black Americans, Hispanic Americans, people in a higher area of deprivation index, and non-English speaking and government insurance and self-pay. So telehealth's been great for reaching out to patients who are in more rural areas and may not have transportation, but there still are some areas for improvement here. So here's some definitions that I like, because I think that these are things that we can all agree upon. You know, we want there to be no negative differences in people's health, regardless of the cause, and it's our job to address these to the best of our abilities. We don't want there to be difference in access to or availability of faculties. We don't want to have inequities of access. And we want to make sure that we're taking care of people, regardless of where they're born, grow, live, work, and age. Anything that can adversely affect health is open to intervention, so we could do our best to take care of them in whatever way we find we have our strengths to do so in. This is a study that came out of the Kaiser system recently, and it shows that MS among white Americans and Black Americans is essentially equivalent in terms of its prevalence. Back in the 60s and the 50s, there were case reports of Black Americans with MS as though it was an oddity, but now we can appreciate that it's pretty much proportionate. Here in the black line at the top here, you can appreciate that this is across the age group, the prevalence of MS among Black Americans, and then the blue line is for the white Americans. So it's pretty much overlapping with one another. Maybe a little bit more Black Americans in the lower age range and white Americans in a later age range, but pretty much it's equal at 226 per 100,000 for Black Americans and 237 for white Americans, so pretty close at this stage. Here's a study that looked at decreased access, and they found that it was involved with men, older age groups, people lower socioeconomic groups, less educated, non-white, those with underlying mental health problems, and those that are from rural areas. And I think the rural areas is also an issue that a lot of our MS centers see, because like in St. Louis, we have a catchment area of several hours, so we see people from all over the Midwest. And you know, a lot of people in these rural areas don't have a lot of health care support or access to facilities in their towns. So this is another paper that came out recently by Marissa, and I think Dan was also involved with this, looking at the locations of care, the geographic disparities, and finding that access was lower in rural or small towns, those that had predominant Hispanic individuals, those that had more men, uninsured, and individuals with hearing, vision, and ambulatory difficulties. So, you know, the United States, depending upon whether you're on the East Coast or up here in the upper Western Midwest, is going to be quite different in terms of how you're going to practice neurology and see your MS patients. This is a paper that came out that was a focus group of 19 Black American women with multiple sclerosis. And I think there's room to do more of these types of focus groups, just to kind of elucidate on the qualitative perceptions that are out there so we can better understand what's going on. One person, one Black American woman described MS as a white people's disease. We saw from the Kaiser data that that's definitely not true, so we need to make sure that people understand that when we talk to them about, MS, what causes it and who gets it. One person said, "You just explain it away, especially as a Black woman. We're used to just doing above and beyond where we need to do, and so that's what I did." So kind of, not taking care of yourself perhaps, or just thinking that you can power through it. That Black female thing of just push through it all. And sometimes we have to talk to our patients about the need to rely on others and to ask others for help, because some people are just very reluctant to do that for their children, or their spouse, or their parents. And I find when they come to visits, I think patients, caregivers, when they come to visits, they learn a lot about the person just by hearing me kind of ask my questions and realize, how this is really affecting them, and what else can be done to help. Because I don't know that people always talk about these private issues, and they just kind of, like this woman says, push through it all. Friends, often nurses and family, played important roles in convincing these women to seek professional care and take care of themselves, and often helped them navigate the system when they were dismissed by healthcare providers. So that's, an idea that if you're seeing a Black American with multiple sclerosis, maybe ask, do you have any nurses or medical assistants or anybody in the profession that can accompany you or aid you in making sure that you're getting to your visits and are taking care of everything, and using them to kind of help to make sure that they're getting the best care. A lot of African Americans think you can go to church and pray this away. They mean well. People tell me that if you have enough faith in God, you can just not. I imagine there's guilt involved here, and you have to make sure that people realize that this is a medical condition, we need to treat it and have the appropriate follow-up, and so on and so forth. These are some additional questions. The greatest challenges: fatigue, cognition, focusing, the non-visible symptoms, being perceived as sick or lazy. Every day is different. Frustrated, mad at myself, fearful of getting worse. These, I think, are common to all MS patients. MS patients have a lot of the same concerns. Concern to maintain dignity and not get stressed out about everything, limited spontaneity, families seek to minimize symptoms and experience, fighting to stay employed, difficult finding a good neurologist who understood MS, changes in insurance plans, trouble fitting appointments into their work schedule. These are things that we hear about all the time from all of our patients. So I think these are very common things that people are concerned about that we can try to help to address. This is a study looking at research attitudes, and we know that it's important to get representation within trials so that we know how these medications work optimally across different populations. This is looking at 2,600 people with MS. And in fact, the Black Americans with multiple sclerosis did have some greater concerns compared to their white Americans in terms of privacy and being taken advantage of, and concern for receiving poor quality medical care. But in the end, they didn't find any significant difference in the willingness to participate in drug treatments or non-drug treatments like exercise or diet, and no difference in concern about being fully informed. So I think there's a shift in the attitudes of participating in research across all MS patients, and an understanding that it really is important that we get a full picture of how this disease affects everyone and how the treatments impact everyone as well. This is a study that was done at WashU and Johns Hopkins. Misty Harrison and Jackie Badarai headed this study, and we looked at 150 Black American visits and 150 white American visits at the MS centers at Hopkins and WashU. And I think to the extent that you kind of abstract charts and count up all the different aspects of them, there were some encouraging things to see here. There was no difference in age of diagnosis, time to diagnosis, frequency of training involvement in encounters, documentation of smoking status in level 5 visits. The Black American patients were more likely to be on treatment, 87% versus 75%. Black patients more likely assessed on cognition, mood, and physical activity. The duration between appointments was slightly longer for the Black MS patients, but it was only 1.5 months longer. And there were no differences in the evaluation for MS relapses, having an MRI considered, although there were some trends that went more towards the white American patients. So I think that this kind of speaks to the power of templates and Epic, because pretty much we're able to have this visit that's in the chart and we're following these parameters. So I think the medical records and electronic health records and our Epic templates probably are doing a really nice job at making sure that we're covering all these different elements of the encounter. It's at least encouraging to see that there's no huge difference in this small study between two academic centers. This is a study that just came out looking at the use of high efficacy therapy. This first chart is showing the time from diagnosis to the first treatment, regardless of what it is. And they found across all the different race and ethnic categories, it was quite comparable. I mean, to me, 4 to 5 months seems to be quite a long time. I wish this was a little bit longer, but there's really no difference between the different groups here. This is looking at high efficacy line of initiation of first high efficacy disease modifying therapy. And it's a little bit confusing because you have these big bars that are the never, but if you look at the second bars in each category, about 28% started high efficacy as first line, and for the Black Americans, it was about 26% and about 30% for the white Americans. It was lower for the Hispanic Americans. So it looked to be pretty compatible in terms of first-line use of high efficacy therapies. But I also wonder whether it should be more offset. If the Black American MS patients are having greater disease activity, more inflammation, should this be higher than what you're seeing for patients that may have what turns out to be more mild disease overall? So I think it's good that these are on par, but I wonder whether this should actually be higher. So we'll see kind of in future years how it goes. This is looking at the effects of socioeconomic status and race in the MS PASS data set, 1,200 Black American patients with MS versus 7,500 white Americans. Again, the data is very consistent. Black Americans were younger, shorter disease duration, more likely to be unemployed, more likely to be treated, more likely to be on an infused therapy, more disability, worse walking speed, manual dexterity and processing speed, more brain atrophy, and greater T2 lesion burden. They found that fatigue, depression, anxiety were associated with socioeconomic status and disability, but not with race. So here are two studies that showed that education, income, employment, disability, those things seem to correlate with fatigue and psychological symptoms, but not race in and of itself. And then a more recent study came out that essentially confirmed that there did not seem to be race or ethnic effects of mental health attitudes, anxiety, fatigue, depression by race or ethnicity, although it was present there for socioeconomic status overall as proxies of income, disability, education, et cetera. I noticed in doing my research, there's this National African Americans with MS registry. There wasn't a whole lot of information. If anyone knows about this, maybe they can speak to it a little bit after I talk. But I think this is a great idea to get a registry together to see, how outcomes are being assessed more rigorously, and to see, how everyone's being treated. So in terms of some practical recommendations, I might suggest carefully consider inflammation and tissue injury burden in your treatment selection. I'm not saying that all Black Americans need to be on high-efficacy therapies, but it should be a strong consideration if you have any concerns for the disease severity, especially at the early stages. Spend extra time discussing the benefits and risks. Really work on adherence and partner with the manufacturers, because I find that they provide a tremendous amount of assistance. Consider risk for rebound if people are on a treatment gap. We just heard about women of childbearing potential. Riley Bove just last month came out with a paper in Neurology that showed that Black Americans with MS, their children did not have equal outcomes in terms of the care during pregnancy with more emergency C-sections. So I think for women of childbearing potential, definitely having that conversation, thinking about treatment and how to get them plugged into the obstetrician and making sure that they have their visits on an ongoing basis. Referral to an MS specialist, consider more frequent visits in the beginning, especially with medication starts or changes. We alternate between our nurse practitioner and the doctors, which I think is a good tag team approach to kind of have two people review everything and offer different solutions. Liberal use of rehab, PT, OT. We have a mental health counselor list that we're able to put into our patient checkout sheet. Neurocognitive testing, voc rehab, social work referrals we discussed, supporting their disability applications when it's time to do so, encouraging them to bring family to their visits, get phone numbers for all members of the family. It's frustrating when numbers are disconnected and you're not able to get with the patient as readily. Black American men, I think, are at an extreme high risk for disability. We've seen a lot of Black men become severely disabled and wheelchair bound within a very short period of time at a very young age. So we have to make sure that we've enlisted their family members and follow up and include support for them. Providing a lot of resources. I make sure that people are signed up on my chart and actually help them download it to the phone so that they are able to kind of see all their visits and the results online for themselves. Talk about all the different breakthroughs provided by MS research. I think coming from a meeting like this, patients love to hear, like, I was in Florida, we had our huge meeting of MS in the United States and Canada, and here's like all the interesting things that we talked about, and everyone was really excited about the progress that we're making. So patients love to hear about the research and our meetings and what we've learned. And enjoy the visit. I've kind of learned with time, get to know your patients, ask about the family, look at their pictures. If they've told you that, I'm starting to walk outside more, I'm walking the dog, hey, let me see the dog. They love showing you stuff like that. They love hearing about yourself and your family and the kids. People are looking to connect with their doctors, and I think sometimes you just have to kind of remind yourself, like, this is an important part of taking care of the patient, and connect with them and hear about their lives and what they're up to, and they want to hear about you, and tell them when you're concerned. And sometimes when I make a change, I'm like, shoot me a note and tell me how you're doing and whether this was a good change or what you think. And like with this lady that's taking her HIV medications, I'm definitely going to provide a lot of encouragement because she's taking care of herself, and it's going to give us some more treatment options in the near future, hopefully. So here's the oath that I think really kind of bounds us to do the best for our patients that we can. And I think here's a couple quotes from Dr. King. We may have all come on different ships, but we're in the same boat now. Change does not roll on the wheels of inevitability, but comes through continuous struggle. And I think Dr. King is remarkable because he really transcends the political divide. I think everybody agrees that we need to do the best for our patients and take care of them no matter where they're coming from. This is just a continuous process, and everyone, I think, despite differences in how people approach in their political affiliations, we all feel like we need to do the best for the patients that we can. So thank you. No questions?
Okay, next before the break will be Dr. Markowitz talking about new aspects of comprehensive care.
Okay. I won't keep you too long in this conversation because I know a break is definitely imminent. All right, so I'm going to talk about new aspects of care. Now, let me just see if this advances. This should advance, yes? There it goes. Good. So when you think about the world of an MS patient, think of somebody who was living their life, they had no concerns, and all of a sudden they're being diagnosed with MS, and they have to interact with all of these individuals now. This whole world has changed for them, whether they're seeing a neurologist, the nurses, the physical therapists, urologists, it goes on and on. So, this is a major change for patients' lives. So just keep that in mind when, you think about the diagnosis you're giving to somebody and how that's going to impact them. All right, so, we've got lots of issues in terms of the complexity of this disease, and over the last, 25, 30 years, with all the different treatments available, we have to incorporate all of that into an already, very complex world. And, I'm of the opinion that you cannot do this on your own. I mean, if you're a small practitioner and you have maybe, half a dozen MS patients or a dozen MS patients, you could probably manage that. But if you're at an academic center, the size of the practice, you personally may have, 500 to 1,000 MS patients, and your colleagues may also have that amount. And now your center has, 2, 3, 5,000 patients. You cannot manage this as neurologists alone. You need a full team of people, and this includes people, at different aspects, whether it be the nurses, whether it be pharmacists on your team, social workers, et cetera. But it's really important to engage that team with the family, with the patient's families as well, because it's really important to know that, they have the support system at home. They're going to be going with lots of new information and data. So having that is key. And, one of the other aspects of this is that, they may come into the office to see you, and they may not tell you all the details about what's going on. But then the husband or wife is sitting there and they say, I just want to say, this is not exactly true what this patient is telling you. I see this, that, and the other thing. So other family members can tell, what's going on. And also, when they call in to maybe talk to the social worker about something is going on, maybe they'll disclose they're not on their medication that they were supposed to be taking. So all of this can help you figure out how to optimally manage somebody. So I have a case. So this is a 25-year-old medical student with 2 days of blurry vision in her left eye associated with painful eye movements. Visual exam showed a left central scotoma, a left APD, normal acuity. Rest of her exam is completely normal, and she was diagnosed with an optic neuritis, treated with 3 days of IV steroids. And they did an MRI scan, which showed 3 non-enhancing lesions in the brain. A lumbar puncture was performed, and positive oligoclonal bands. So the question, and I'm going to ask this, but I'm not going to necessarily make you respond to it, is how should we manage this patient, right? In today's world, whether or not, the optic neuritis fits into the criteria or not, or whether you think somebody actually looks like MS but, doesn't meet all the check boxes, we still have to manage these people. We still have to think about how we're going to recommend how they be monitored and how we recommend if we're putting them on a therapy or when should we re-image them or things like that. So important pieces to consider. So you heard earlier about our, usual approach to treating MS, which includes, dealing with clinical attacks, symptomatic therapy, and disease-modifying therapies, but also dealing with this wellness conversation, which I think we've learned over the last decade or so how important this is. Dealing with the comorbidities. We know that diabetes, hypertension, all these other things can contribute to a worse outcome in MS, and making sure you do the best you can for your patients in terms of, make sure they're not smoking, whether or not the vitamin D piece is a moving, target here for us to know whether or not we should be doing anything different about that. We're learning a little bit more about things like regular mental and social stimulation being very important in MS and outcomes as well, sleep, stress reduction, all of that. Here's another case. 30-year-old African-American man developing difficulty walking. Neuroexam reveals an ataxic gait. MRI shows 14 non-enhancing lesions, 4 GAD-enhancing lesions, including 1 in the spinal cord. He was treated with IV steroids. LP shows positive oligoclonal bands. Blood workup was negative. So here's just another case of somebody presenting to you, very different than the other case that I showed you. How should we treat this patient? Should we treat them all the same? That's a question. And, that's for us to figure out. All right, so general principles of therapy: treat as soon as you feel appropriate, that even with a diagnosis of MS that you've confirmed, or even in some cases where you say you're at CIS and we want to put you on therapy, and the question now is still about RIS, whether or not they meet the criteria, and we should be treating those as well. And then when you think about starting a therapy, what are you going to use as your barometers to determine outcome? MRI, clinical, demographics, et cetera. And I think the field has really moved a lot in the last 15 years about how aggressive we are up front with starting people on therapy. And I'll get into this a little bit about the escalation versus induction. And I'll tell you that, I think that bar has moved way toward, the idea of almost like an induction approach. And if you go and look at the oncology world, that's kind of how they deal with things, because, the outcome for that is death. And for us, the outcome is disability, but we don't treat disability like death, but maybe we should. We got to follow patients very closely and be very ready to make switches. You don't want to be waiting around. So there are many factors that play into what decisions we make, and we all know about the disease factors, but I want to highlight the aspects of patient factors. The parts that you listen for with your patient and discuss whether or not, a particular therapy is appropriate. What is their risk tolerance? What is their plans for pregnancy? This is a very important piece when you're thinking about this from the get-go. What are their comorbidities? How adherent are they going to be? Over at our children's hospital, they are the most difficult patients to adhere to treatment. And sometimes they'll come over to us when they age out at 18 or 20. And I will tell you that it is brutal because they live the worlds that they live, and it's not like I have time for this MS. So it's an important piece to consider there. By the way, I took this picture in Iceland. So if you haven't been to Iceland, you should go to Iceland. All right, so I'm not going to go through all the different drugs that are available these days, but just so you know, this is the landscape, how it's been over the last 25 plus years. And, we have many different mechanisms of action, and we can divide them up into, injectable therapies, orals, monoclonals, et cetera. So when you think about this, you can either say, you guys decide, the patients decide, and you tell me what you want to do. And probably for the first maybe, 10 years that we had therapies available, that was kind of how things went, even though, in most MS centers, we didn't like to think that that's how it went. But now we sit down with the patient and you talk about what you think is the right treatment for them. And that may be choosing within a class. Maybe, it doesn't matter if you're going to go on an oral drug, if you feel that, that's the drug, if this patient feels that's the drug they want to take, you give them choices within that conversation. So, we got this one, or you got this one, but you got to guide that conversation. Not like, here's a couple things, go home, read about it, come back and tell me what you want. We are the specialists. We know all the side effects. We know all the safety concerns, all the monitoring. And as you might imagine, this is a lengthy conversation, and I'll get into that. So, we have to be able to read into the patient's world and figure out what makes sense. So I'm just showing you this as kind of like, we determine if somebody's JC virus antibody positive, maybe we will choose a drug based on that conversation. I tend to go to highly active drugs these days. I don't even do too much in the way of injectable drugs like the original interferons or GA. Some of the orals I will use what I considered in a highly efficacious group. But for the most part, and I do factor in their world, but if they're asking me what would I take or what do I recommend for them, that's the classes of drugs that I'm typically doing. So a very important piece about, so your patient shows up, you're telling them they have a diagnosis of MS, they do not hear another thing out of your mouth. They've checked out, they're into a whole world about how their life is upside down, and they don't know how they're going to deal with their family or school or work or whatever. So it's important that, if you're going to discuss a treatment, you bring them back for a separate visit to really go over what you think makes the most sense. They'll hear you on that. They'll understand a little more as opposed to, not paying attention. And making sure people have realistic expectations about what to expect from the treatments. Most people say, I have an infection, I take an antibiotic, and it cures my infection. Well, we don't have anything that cures MS. And in fact, we don't have anything to necessarily make all the symptoms that they have go away. We have drugs, as you heard earlier, about symptomatic management, but we don't have something that's going to make weakness go away necessarily. I mean, to some degree we can manage that. So they need to understand what the expectations for these drugs are. And always think about, things like comorbidities and monitor the pregnancy conversation. So this shared decision-making, I'm sure, you guys have heard this 100 times already. It is an important piece, and it gives the patient the ability to connect with you as the practitioner or your team and be able to understand that you are working together and that whatever it is that they have concerns about, you have heard, and you are willing to incorporate that into the decision and be able to acknowledge so that they feel like they own the decision about what treatments they're going to go on. That's a really important piece because, that's going to ultimately lead to better adherence. Another case, 46-year-old woman with a history of MS, diagnosed 15 years ago, was started on GA, switched to dimethyl fumarate. A couple of years ago, her MRI showed one new enhancing lesion. She was not compliant with the dimethyl fumarate. She was switched to Ocrevus, or I should say ocrelizumab. Over the last 2 years, she had a slow, steady decline in ambulation, while her MRI scans have not shown any new lesions. And this should not be an unfamiliar scenario for you guys, because this is what secondary progressive disease looks like. And we do not have great treatments for this conversation. She's not active in MRI activity, but she's showing this slow, smoldering deterioration. So, again, how do we treat this patient? And, this is the food for thought piece. How do we come up with therapies that are going to impact this world for her? And right now, we're in trials trying to figure this out, but this is what we have to deal with. So this issue of the induction versus escalation, Mark was a big fan of the idea of, starting somebody with a maybe lower efficacy compound and then working your way up. And again, I think it's appropriate for certain patients who are very risk averse and don't really want to go down that pathway. But I'll tell you, having been in this practice for, many years now, I don't think there's so many risky aspects of the drugs that are in the high efficacy world. We know how to manage them, and we track them, we monitor them. So I see no problem starting people on these higher efficacy drugs from the get-go, because I think they're going to be potentially, and we'll have data from studies that might demonstrate this, but potentially preventing that disability progression in 5, 10, or 20 years. I really believe that. All right, so when we're monitoring people on therapy, how do you assess it? You look for, you bring them back for neurologic exams, you listen to whether any symptoms, any progression, MRI, et cetera, and dealing with things like side effects of the medications. But the piece that we have not been adequately able to manage is cognitive issues, depression, fatigue, and I think that this is probably up to you guys going out into your future careers, that this is going to be an important piece that we need to come up with a way to better assess and better monitor with treatments. So you heard from Mark earlier about the idea that, when you start somebody on a therapy, you don't know exactly when that drug's going to be most effective. We feel from some of the studies that we know roughly in that 3 to 6 month time point. So if somebody's having attacks early on, you're not going to necessarily call it a treatment failure. You're going to say, okay, well, the drug hasn't had its benefit yet, so we're going to monitor you, see how you do over the next 6 months. And it's really important to get a baseline MRI at that 3 to 6 month time point starting a therapy, and then you can monitor them from there. Again, we usually think about 6 months is a good amount of time before you even think about a therapy switch. Washouts, I'm not a fan of washouts, so I think it's really good to get people on. I don't like to see new disease activity, so I like that idea. All right, so the NIDA conversation, if you look at all the clinical trials for every drug that we have available, you don't really see that anything is really shutting down disease activity, greater than 50% on the NIDA conversation. Now, if you look at what the Canadian group has done, looking at bone marrow transplants, this is probably our best strategy in terms of suppressing disease activity with, shutting down relapses, maybe even looking at, normalizing brain atrophy, and then even looking at NIDA. Hold on, I think this mouse will get me there. You're looking at this population down here from, getting into that 60 to 80 or maybe even 90% NIDA, no evidence of disease activity. So I think, there's something there that we're really going to try and address, and I think over the next bit of maybe the next 10 years, you'll start to see a lot more of this cell-based therapy approach as opposed to what we're using now with, individual molecules like that. So you heard about all of these earlier today, so I'm not going to spend too much time in this conversation. I think that, there's some hope that things, address the cognitive piece, the brain atrophy piece, whether things like, gold nanocrystals may have some benefit in that conversation, whether the BTK inhibitors will address some of these smoldering inflammation in the brain. These are all our hopes at this point, and we don't know yet, but we are very happy about it. Immunosenescence. So you heard a little bit about the notion of stopping therapy, the notion of maybe de-escalating therapy. So let's just spend a few minutes in this conversation. So if you look at across all species on the planet, they basically all have immune systems that peter out over time. It's the nature of organisms on the planet. It isn't specific to humans. So, that's just what happens. And what ends up happening as you age is that your immune system can't fight off the cancers, you can't fight off the infections, and those are the things that get you when you're older. I think we all have something to look forward to. So the question you could say is, well, should we be de-escalating? And I think the answer is probably yes. The question is, when is it appropriate? And, we started up a study, looking at ocrelizumab and maybe treating them for a year or two and then stopping it to see whether or not disease activity will come back. And if so, when? Like maybe it doesn't come back, or maybe it comes back in 5 years. We don't know the answers to these things. But regardless, we know that there's some rationale in terms of risks of disease, risks of, the complications of the treatments. But there are here a couple of points that I think are interesting about it. So as you look at MS and aging, with age you get less relapses and less disease on MRI as well. And all the treatments that we have available, they seem to have less benefit in the progressive phase of the disease, and they're more effective when you look at the early relapsing population, younger patients. So, we have every clinical trial says 55 or below as enrollment criteria, except half of the population that we're treating these days who have MS are older than 55. And we have no data to know whether or not that drug for that patient is effective in this group. Very important. So we have to figure that out. So risk of disease, we know that, if you don't have adequate treatment, you're going to get, more disability, and as you age, you acquire more disability. Relapse rates are age and time dependent, and maybe even decline by 17% every 5 years. So what's the risks of treatments? Well, we know that some of the treatments, particularly the cell-depleting ones, cancers, neoplasms, et cetera, are definitely increased with age as well. Hypogammaglobulinemia, PML, zoster, all these things seem to get worse as people age. So maybe we have to think about, de-escalating to get them on safer treatments as they age. And we know what happened during COVID in terms of the inability to get vaccinations for some of these medications. So all important pieces that we have to figure out. I'm just going to show you this one slide. You're going to get a talk after the break about telemedicine. I'm just going to say, I hate telemedicine. Just going to say that right up front, and I can own that completely. So, there are a lot of technical issues that go into this conversation. It is so frustrating. You know, like if your system works great, and that's fine. And my nurse practitioner, she loves it because she can be at home with the kids, and I think that's wonderful. But for me, I like in-person visits. I like to be able to touch. I like to be able to examine patients. So, you know, there are a lot of questions to address here. All right, I'm going to finish up this last section with what I think is important for the junior people in this room. It's also important for us too, but regardless. So you know that MS is a very labor-intensive prospect. You go in, you're going to talk to your patients. This is not headache. This is not seizures. You can't knock them out in 10 minutes or 5 minutes in your office. This is a lengthy conversation, so you're going to be discussing with them all aspects of the diagnosis, the treatment, any of the concerns and symptoms, so everything takes time. 45 minutes to an hour is really minimal for a lot of these visits. And, you know, there's lots of other things that need to be addressed. Family concerns, you know, messaging through the Epic takes time, dealing with the insurance companies about getting approval for the tests and the medications takes time. Disability forms that need to be filled out. I mean, this is why many of my colleagues said, thank God you're in MS, because I couldn't do that. So here's something that I think is important for you to realize. Everything that you do, that you order a test for, your institution makes money on. So here are just a list of the things that the MS neurologists order. Tests of laboratory tests, MRIs, evoked potentials, OCTs, et cetera, and then the therapies, follow-up evaluations for all of this to monitor people over time, and then consultations you refer out to various specialists. So when you go to go get a new job somewhere, and you're interested in building a program, and the hospital administrators say, well, we don't have any money for this, you have to come up with a plan as to why this is going to help them. It's not going to necessarily give you money in your pocket, but it's going to give money to the hospital. And with that, they can say, okay, I get it, so how much do you need for your staff? And how much will you need for all the other people to run a program like this? So this is important. If you have a specialty pharmacy, if you practice in a underserved area where patients either have low income or uninsured, the government has set up this 340B pricing for drugs. And so that the individual hospital can get the drug at very, very discounted prices, whether it be, you know, 30 or 40 or maybe 50% off in the price, and then they do the treatment at that institution, and they can charge the insurance companies or whatever as much as they feel indicated. And there's a lot of profit in that for the hospital as well. All right, so I'm not going to go through all this in detail, but you can see here that there's decent amounts of money that are going to be generated profit-wise to the hospital for all of the things that are getting done there. And then if you look at the individual compensation for that physician, you know, cardiologists, radiologists, GI, et cetera, and neurology's down, you know, half of that as a general piece. But if you look at what the inpatient and outpatient revenue to the hospital relative to the compensation they're paying you, MS neurology is at the top of that list because of all the things that you order or treat. That is a huge amount of money for the hospital. So at some point, you'll be able to say, I need a nurse, I need a social worker, I need people to help me, and you're going to make a lot of money. So you just have to be able to kind of, you know, couch this in a way that makes sense. Joe Berger did a nice assessment for us a couple years back looking at the contribution margin, and this is the money that the hospital makes based on all the things I just gave you. And at the top of this, so we're in this dark blue area down here. This is the MS neurology MS group here, right? And then if you look at spine, spine is up here in this. We're making more than spine for the hospital. We're actually making more than all of neurosurgery than the hospital. But last time I checked, they did not pay us like the neurosurgeons get paid. So an important piece to think about when you're building this center for yourself. So, as an ideal MS program, you know, you need the staff, you need physicians, fellows, pharmacists, social workers, research team, nurses, admins, schedulers. You need an ability to capture data from your patients. So, you know, whether it be pre-screening things for, you know, depression, fall risks, et cetera. But then on the physical side of this, you need a place for the patients to be seen. So check-in, rooms for the clinicians, consultation rooms for your pharmacists and social workers to be able to talk to patients on the day that they come in for their visits. Phlebotomy space, we set this up recently in our clinic to be able to have the blood drawn right there as well. So, you know, this is all pieces that build an MS center that is going to be a viable opportunity for the hospital, and they're going to actually be happy, as will you. So in conclusion, it takes a village to treat MS in 2024. You can't do this on your own. Again, you consider the aspects of the disease, the drug, the risk factors, et cetera, adherence. Really important to deal with this issue of shared decision-making when you're making the decision to treat patients, monitor them very closely, and de-escalation, I think, is really appropriate. And I have been seeing, you know, I'm in practice for many years, I'm seeing patients in their 70s, and they're still doing injections. And I say, you want to stop? And some of them say, I'm okay, I'll continue doing it. And some will say, I can stop? Yeah. So there are a lot of pieces to this that I think are important. And the most important part of this is that you are a commodity, okay? So this hospital that you're going to be working in or that you work in now, you are a commodity and you should be treated like that. So thank you, and that's all I was going to go. No questions, right?
All right, I hope you all enjoyed the break we were supposed to have. So let's do like 5 or 7 minutes to do whatever you need to do, grab a snack, and then we'll restart. Okay, can we get folks in? Because we need to get started. Don't get comfortable, Amy. Okay, we're going to move along. Next up again is Amy Perrin-Ross on patient education and tools.
Well, thanks, Dr. Loveland. We're going to talk for a few minutes, literally just a few, about patient education and tools. So when we think about patient and family education, there's lots of different things that are going through our mind. And the bottom line in terms of what we need to keep in mind is that this really needs to help guide the patient towards self-efficacy. Because we could talk all we want, we can recommend all we want, but until the patient really perceives their own self-efficacy, this kind of stuff isn't necessarily so successful. So we want to promote maximal health potential, coping and adaptation, as well as self-care and empowerment. So in order to think about education, what we have to do is a learning assessment, assessing the patient's readiness to learn. Many of our patients are in no mood to learn, particularly early in the diagnosis. Many of the patients who may suspect that they have MS and have gone to that premier medical resource, Dr. Google, and looked up all those symptoms and filled their heads with all kinds of information, may just not be ready to hear anymore. So we have to think about their style of learning, cultural literacy, we'll talk about that in a minute. What's the role of the family? What are the coping mechanisms? Sometimes the role of the family is challenging to me because we sometimes have various different ethnic groups who come in with 8 to 10 to 12 family members. And that's not my approach, that's not my style of learning, but I have to accept their cultural values and beliefs and try to accommodate that as much as I can. And if you can imagine trying to manage not only the questions from the patients, but 11 of their favorite family members, all in a 20-minute visit, you realize what some of the challenges are that Dr. Markowitz just talked about. So we also, again, think about cultural literacy. Culture is the values, beliefs, norms, and practices of a particular group that are learned, shared, and that guide thinking, decisions, and actions. And Dr. Naismith did a really nice job talking about some of the cultural beliefs in the Black American population that may be very different than yours and mine. Cultural health beliefs affect how individuals think and how they feel about their health and their healthcare problems. It also affects whom, when, and where they seek their health care, and it provides a context through which meaning is gained from information. So what are some of the guidelines to facilitate learning? Well, obviously everyone is a unique individual. We want to identify their literacy level and those who might be at risk, look at their cultural health and beliefs and practices, and utilize various different teaching strategies. If you take one thing from this short 15-minute presentation, the one thing I would like you to take is the concept of listening. There is really nothing more important that you and I do on a daily basis than to listen to our patients. When we listen, our approach tends to fall into line. So what are some of the learning needs of the MS patients? Well, one of the things that I have always spent a fair amount of time on, after you get through the diagnosis and you get through some of the symptom management and stuff, is when we talk about disease-modifying therapies, it's very important for me personally to be able to explain mechanism of action to my patients. And because I find that if they understand what I think this drug is going to do for them, or what I hope it will do for them, they're much more likely to be adherent. They're much more likely to take it. And this became increasingly evident with the onset of COVID. What's this drug doing to my immune system? What's this drug doing to my MS? How is it going to affect me? So we look at a lot of those things, but for me personally, it's mechanism of action. One of the other things I really focus my assessment on, besides the list here, is when to call the office. Okay, I tell my patients, don't sit home and worry, call or in-basket us. Let us do the worrying for you if there's something to be worried about. If not, we'll help you get through whatever it is. So when to call the office. Sometimes that backfires because they call every 5 minutes, as you know, in the first couple of months. But eventually, once they realize that if they need you, they can get you or someone in your practice, those calls and in-baskets tends to decrease. I also often encourage patients to bring family members or significant others or friends. I mean, sometimes it's you know, for a single person, it's really the next door neighbor that it lives in the same condo building that they do. That's really the biggest source of their support if all the rest of their family is, for example, out on the West Coast. So we look at diagnosing multiple things with patient and family. We look at disease management goals, try to help them level set some realistic expectations, help them understand the difference between disease management and symptom management, and always, always, always let them know there's hope for the future. Dr. Markowitz talked a fair amount about the realistic expectation. Again, informing patients that DMTs aren't curative, but they really do make a difference in the long term. I, like Dr. Lublin and Dr. Miller and many of the other faculty here, have been doing MS for a number of years. And I too remember the days early on, before we had DMTs, or early on in the case of DMTs, and how much different that disease looked back then, and how much different it is today in terms of what our expectations can and should be. Providing balanced information should really be our approach, balanced information to the best of our ability about everything from disease-modifying therapies to symptom management to living your life with MS. Some general advice for motivating our patients. Remember that MS is a lifelong disease and treatment is a lifelong commitment. Doesn't mean you have to take a shot or a pill every day or every other day or every month for the rest of your life. We just need to realize that this is a lifelong disease that's going to require lifelong management and tweaking things along the way. Looking at the approach to wellness, some of the things that Dr. Naismith and Dr. Markowitz talked about as well. What are some of the challenges? Well, I'm going to leave that whole concept of challenges and telehealth to Dr. Miller, who will be very well positioned to talk about this kind of thing. Again, we need to take with a grain of salt what we hear and see on the internet, and yet there are so many great resources out there for us. Things like online counseling, online exercise programs. If you read the International Journal of MS Care, there's some great articles in there about people doing telehealth for rehab, just phenomenal kinds of things. We look at optimizing patient care, recognizing and identifying individuals' perceptions of quality of life, shared perspective between the clinician and the patient and family in terms of their healthcare goals, collaboration, extremely important between patients and practitioners, ensuring that they understand your perspective, but remember, listen, listen, listen to what they have to say. Listen with your eyes as well as your ears. Shared decision-making has been mentioned several times throughout the day. So remembering the 5 steps of shared decision-making, engaging the patients in participation, exploring and comparing some of the treatment options, whether that's symptom treatment, disease management therapy, whatever it is, assessing the patient's values and their preferences, reaching a decision with the patient and their family, and then constantly evaluating and reevaluating. So finally, some of the tools. We have a number of tools available to us today. This, for example, Brain in Life, is one of the tools that's available to us and to our patients through organizations like the American Academy of Neurology, the CMSC. For those of you who are residents and fellows in here, I think it was Dr. Berger who mentioned the CMSC MRI guidelines earlier this morning, or perhaps it was Dr. Lublin. The CMSC is a vast organization of resources for us as healthcare providers. mscare.org is the website, mscare.org. It's all free. So you can just search MRI parameters and the MRI guidelines come up, you print them off, give them to the patient, and they take it off to their local MRI facility wherever they're having things done. So lots of really good resources. Additional patient education tools come from patient support organizations such as these two from the Multiple Sclerosis Association of America, the National Multiple Sclerosis Society, the Multiple Sclerosis Foundation, Can't Do MS, and others. Online resources, again, this is an issue from WebMD, focusing specifically on multiple sclerosis. Again, lots of good online resources out there, but I often try to be a conduit so that if people come in and tell me about resources that they've seen online, I try to vet those resources to the best of my ability. And then from our pharma partners, patient education brochures and booklets, I make sure to give these to our patients. Gone are the days when we give them 3 and tell them take them home and figure out what they want. No, not anymore. But once we come to a shared decision about what it is we think might be the best for our patients, I do provide the pharma-provided patient information material for them to take a look at, and or I tell them, take a look at it online. So in summary, comprehensive care team approach, just what Dr. Markowitz talked about, with the patient at the center and a multitude of healthcare professionals available around it. That's the best opportunity for patient education. Thank you.
Thank you, Amy. I know this is a long day and it's a lot to process, but we still have some very good lectures to come along now. And next will be Dr. Miller again with integrating telehealth and remote monitoring.
So what I'm not going to do this afternoon is tell you how to do telemedicine visits. I suspect most of you have learned. In February 2020, I had done 0 telemedicine visits. In March of 2020, I was shipped home by my department chair who sent all of us old codgers home to avoid the ravages of COVID that was hitting New York City at the time. I spent the next 13 months doing nothing but telehealth visits, to the point my wife got distressed when I told her I felt like I was under house arrest. But I don't share the view that Clyde has of hating telehealth visits. I think they have their place. But I too prefer to see patients live. So what is telehealth? Telehealth is the use of virtual technology-based platforms to deliver health information and medical care. And you can think of it as divided into two rubrics: synchronous telehealth, which is what telemedicine is, telemedicine visits, and asynchronous, where data or other things are gathered offline and then transmitted back to the physician or other provider. It may be that there are residents here who have not yet had the opportunity to perform any or many telehealth visits. I'm not going to go over that in detail, but if you're familiar with NeuroBytes, the little 3 to 5 minute product of the AAN, there is one on doing the telehealth visit, which is quite informative. I think I have a link to it at the end of the talk, but you can just go on the AAN website and find it. But there are clearly benefits of telemedicine in multiple sclerosis. And interestingly, the AAN had a telemedicine working group that was put together prior to the pandemic and reported in 2019 that telehealth reduced missed work days by 65%, saved travel by an average of 258 kilometers. That means that people were saving an average of 75 miles a visit. I don't know. That's a long way between MS neurologists. Well, this is not MS, this is all of neurology. And it reduced the costs of lodging by 17%. When you think about it, I practice medicine in Manhattan, but probably somewhere around 80% of our practice does not come from Manhattan. And probably over 50% of it doesn't come from the 5 boroughs of New York City. Even if you live in Manhattan, if you live downtown, to get to our office on the Upper East Side is going to be a couple of hour round trip. So think of the time you save patients with a telemedicine visit. And think about how often you actually need that neurological examination to make a decision and give advice to an MS patient. I would warrant that the vast majority of time you're doing it on the basis of the story that the patient tells you and the MRI. Not to disparage the neurological examination, it just isn't the way we make most decisions in MS. So Clyde might not like it, but patients really like it. And not only that, it helps in their care. So there was a randomized controlled pilot trial among veterans that showed that they adhered better to their disease-modifying therapy when they were getting telehealth visits. 87.5% of vets reported a positive experience, and a prospective study of 36 patients found that 97% would recommend it. So patients like it. I learned a lot in those 13 months of doing telemedicine about what I could gain from it, what were the drawbacks, and there are a number of tips. This is a useful website to look at in the AAN website. So they give top tips. I'm not going to go over them, but I'd have too little time, but these are the subjects they cover. Instructions to send to patients in advance of visits. Preparations by the physician or the advanced practice provider or the medical team in advance of the visit. What you should do during the visit, and what can be done after the telehealth visit to improve quality of care. One of the things I learned the hard way in my telemedicine visits was the importance of ascertaining the safety of the patient during the visit. I had the humbling experience of attempting to watch a woman walk when she suddenly went collapsing to the floor, crashing into the potted plant, which got spilled over. She lay there in a pile of dirt, alone in her apartment. Fortunately, this woman who lived in a doorman building in Manhattan had a good relationship with her doorman who had a key to her apartment. And she was able, holding onto her cell phone, to call down to him so he could come up and pick her up. But it's a good idea probably not to have people who are imbalanced walking when there's nobody else around in the home. Of course, there is the obvious disadvantage that you can't do a complete neurological examination. You can't assess tone, you can't assess muscle strength very well, you can't address sensation very well. Fiona might have a way to do fundoscopy via telehealth, but I don't, and you can't measure the reflexes. But again, how often do you need all that information? But Riley Beauvais at UCSF has developed a kit. She's willing to send patients all kinds of paraphernalia to enable them, with or without somebody at home, to do a more complete neurological examination. She sends a Rosenbaum Near card, a red color paper, a cotton swab, or a safety pin. She has them use a 5-pound weight, like a big Marzano can of plum tomatoes. I think it's better used for a marinara sauce. But a massage app on the eye for the iPhone, and a pen light or flashlight. That would enable you, with some question about the validity of the exam, to do a more complete exam, but I don't think most of us are actually doing that. Okay, Rob already told you most of the information here, but there are equity disparities in telemedicine. A UCSF study of visits to primary care patients in a 2-week period after they implemented telehealth visits compared to a 2-week period prior to implementation, they find that everybody who was old, poor, or non-English speaking or non-white were less likely to come for those telemedicine visits than they had in the previous non-telehealth visit era. Only visits for non-Hispanic whites were increased during that period of time. A NARCOM study similarly showed that older age was associated with decreased usage and lower satisfaction with the telehealth visits. Moderate to severe visual symptoms will also impair the utility of telehealth. Also, it's important to recognize that not everybody has access to telehealth, and in one urban primary care practice, 14% had no access to the equipment needed for a telehealth visit, and a number of others had a limitation on how much data they could use. There are some patient-reported outcomes that may help improve the utility of these visits. Lower step counts measured by an accelerometer correlate with higher EDSS scores and captured variability in walking that is masked by standard disability scores. But keep in mind that patients want to please their providers, so maybe they put their accelerometer on the washing machine and get their step counts up. So whether you're getting reliable information is uncertain. The patient-derived disease step score is strongly correlated with the EDSS, and that's easy to administer. If you want to see it, it's on the NARCOM's website, and you can see here normal, mild disability, moderate disability, gait disability, and then the use of assistive devices, which correlates very well with the EDSS scores from 6 up to probably 8 or even 10. Okay, so what about digital interventions? You can find so many things, you can download apps for everything, but how many of them have actually been validated as useful tools for the clinician? Not very many. I want to focus just a couple of minutes on the use of telehealth techniques for actual therapeutics. So there is a program called Amiria, which is an individual-based, cognitive-based therapy online, which has been shown to improve depression. In the left-hand slide, you can see that irrespective of whether you use this tool as a standalone tool, that is without any therapist to guide it, or whether you have the guided online CBT, in either case you get a significant improvement in depression, which is shown on both of these scales. The left is the Beck Depression Inventory, and the other is a different scale. So that's one scientifically validated improvement. The second is on fatigue, and again, the same group has reported this from Stefan Gold's group in Germany. And this was a randomized controlled trial of a self-guided online fatigue intervention in multiple sclerosis, which showed a statistically significant improvement on a fatigue scale called the Chowder scale, which I wasn't familiar with. But this is a modest benefit, but a statistically significant benefit. Now, I mentioned a moment ago that you can find all kinds of smartphone apps, but I'm not sure how useful they are. But one that I think is particularly interesting is the Floodlight smartphone app. So I went to download the Floodlight smartphone app. Don't do it. It will lead you on a wild goose chase. I followed up the wild goose chase and got a private demonstration of Floodlight. So Floodlight is a product of one of the pharmaceutical companies, and it's actually a lovely program which includes a number of functions all online on your little iPad or your iPhone: pinching a tomato, drawing figures with your finger, standing up and making a couple of U-turns, doing a 2-minute walk, or the equivalent of the symbol digit modality test. So very nice test. Doesn't take very long to do it, but they have a very large and commendable program piloting this program, which is not currently available for commercial use, piloting the program and trying to improve it. So it has a lot of promise. Here, I think, is the big problem with these techniques, and this is in a paper by Jiwan-Oh, and this shows that how great a fall-off there is in the use of this program by patients in the pilot study in various countries. Only in Denmark do they not have a long fallout. Maybe they give them Danishes with their successful completion. I don't know. But every other country, there's a very steep decline in the utility or in the utilization of this program. And this shows it in numeric values, looking at their persistence. And if you look out at 24 weeks, depending on which particular way you measure it, it's down basically around 10% use by 24 weeks. Now, you might still argue that for the people using it, it may provide useful information. But I think one of the big problems with all of these digital apps is one problem is they're not integrated into your medical records. And that's one of the big problems with the Floodlight program. As yet, they have not figured out a way to get it into your electronic medical record. Well, raise your hand if you want your patient to bring you gobs of printouts of data about their step counts, their pinch a tomato counts, their U-turn counts, when you have maybe 30 minutes, if you're lucky, to spend with that patient. So I think that's a big drawback to the utilization of any of these programs. But there's still lots of work being done, and maybe they'll iron out these kinks. And I think it would become much more useful if this could be directly fed into the electronic medical records. This is data also from Riley Beauvais from years and years ago, looking again at the persistence of use of various smartphone applications. And you can see that on the left-hand side, they had MS patients and their cohabitants both doing these studies. The MS patients stuck with it a little better, but in the middle slide, those who were scoring less well on the SF-36 test, and the mental components were not as likely to stick to the test. And those, I think on the right-hand panel, were people with visual impairment were less likely to continue to utilize these tests. So there are a lot of problems with persistent utilization. So that's basically, I think, what I have to say. These are, since I had very short time, these are a couple of useful websites. The first one is for that NeuroBite that shows the exam, and the other is a link that shows a number of potentially useful MS apps that are available for downloads. And finally, in the words of one of the greatest philosophers I know, Charlie Brown, he said, "There is no heavier burden than an unfulfilled potential." And that's personally where I think we are with digital health at the moment in regards to MS. Thank you.
Thanks, Aaron. Okay, we're going to move ahead. This is another one of these special talks that's sponsored. So this particular talk on BTK has been sponsored by Sanofi. You heard quite a bit about the important aspects of BTK from Jeff Cohen in his talk. You'll see some of that again now because I couldn't help but do it, and we didn't coordinate. But it's okay. It's part of the learning involves repetition. So, okay, first, do we need new agents for relapsing remitting MS? So, answer is yes. Then why? Well, we could still benefit from increased efficacy, as you've heard earlier, with agents, especially in the first 2 years of use. We can benefit from newer and different mechanisms of actions. Agents that have dual peripheral and CNS activity will be advantageous, and agents that involve both the adaptive and or innate immune system will have some importance for us moving forward as well. And safety. You've heard the discussion, the arguments about starting with escalation, starting with high efficacy and different opinions. That's ongoing. So what we want is safer, high efficacy therapies. We do have longer-term safety concerns on our agents now that we're treating people for 5, 7, 10, or longer years. And then the potential for switching to avoid longer-term safety issues. This is something that's been alluded to a little bit today, but we haven't really gotten to it. But Mark Friedman talked a little bit about this in terms of switching, and it's something that I think we need to think about more carefully. So for the future, we want agents that may work in combination. And we haven't done any of that, really, since we did the CombiRx trial. Agents that work in concert with neuroprotection and agents that work in concert with repair strategies, because for those two, we're probably going to need something to turn off the inflammation and then something separate for the neuroprotection and the repair, and that involves working within the central nervous system. And of course, we need better and more treatments for progressive MS. So BTK inhibitors are the next new mechanism of action that's going to reach and has reached phase 3. They have both an adaptive and innate potential, working on both sides of the blood-brain barrier. And the importance of brain penetrance has been discussed, but this is something we think we need to, especially for advancing disease, progressive disease, treating some of these newer MRI lesions that I'll show you. Are going to involve brain penetrance. And we need something for the different MS subtypes and the potential for one agent to treat multiple types of MS, relapsing remitting, secondary progressive, primary progressive, that sort of thing. So BTK inhibitors are a novel therapeutic target for us. They're a member of the TEC family of cytoplasmic tyrosine kinases. They're expressed in many immune cells, but not T cells, not NK cells, and not plasma cells, and on some epithelial cells. They play a critical role in the, oh, and I should say as I go along that I have to thank Ben Segal, who I stole many of these slides from. Stole's not fair. He gave me his permission with a caveat that I completed, but I won't tell you about that. Anyway, they play a critical role in signaling pathways in B cells and myeloid cells, meaning monocytes, macrophages, neutrophils, mast cells, and importantly, microglia. BTK functions downstream from the B cell receptors in B cells and at the FC receptor in myeloid cells. And it's also involved in other innate immune functions like toll-like receptors and chemokine receptor cascades. In nature, you can get a mutation that produces non-lethal X-linked agammaglobulinemia with BTK loss. And there is a BTK, the first BTK inhibitor was approved for treatment of B-cell malignancies, lymphoma, and leukemias, which was ibrutinib. So here is sort of graphically showing you where these molecules are working. And in essence, they're working on B-cell production of immunoglobulin, B-cell presentation of antigen, and how that affects T-cell function and microglial function and macrophage function. And there's other graphics here as well. So the putative mechanisms of action are blocking the proliferation and effector functions of pathogenic B cells, as well as their maturation into antibody-producing plasma cells. It doesn't affect the plasma cells themselves. Suppresses antigen presentation by B cells and or myeloid cells to autoreactive T cells, blocks activation of pro-inflammatory microglia and CNS infiltrating myeloid cells like macrophages, inhibits microglial phagocytosis and uptake by synaptosomes, suppresses mast cell degranulation and cytokine production, and it can even have effects on microglia who have effects indirectly on remyelination. And this again shows you that checkpoints for a BTK inhibitor within a lesion within the central nervous system, which is very much working on the monophages and macrophages, and monocytes rather, macrophages and microglia. Now, you heard a little bit about these, and I want to bring them up again because this is half a hint and my last hint about McDonald 2024. So paramagnetic rim lesions, as you heard, are seen in MS. They're not unique to MS, but they're close to, because there's not a lot of other conditions that produce them. They can occur in white matter, they can occur in the juxtacortical region, and even in the cortical region, and in the spinal cord. And they represent an area of activation of microglia at the rims. And to see them, you need to look at susceptibility-weighted images on MRI, and we're going to have to think about altering the sequences that we use for looking at MRI so we can pick these up more readily. But they're important to think about, along with these slowly expanding lesions, in terms of worsening MS. Not progressive MS, but worsening MS, because while they're more common in progressive forms of MS, they're really more common in anybody who's doing worse, whether it be CIS, relapse remitting, primary or secondary progressive, they're there. But they're a potential metric for these studies, and you heard a little bit about this earlier, including one study that I didn't include, but we'll get to it. And so they also may be helpful as diagnostic markers, but I'm not going to get into that now. But, well, here, it just shows you how to see these paramagnetic rim lesions. So here, here we go. This is a good example of one right here, looking at that rim. The chronic active lesions that are slowly expanding are interesting because you need special techniques of co-registration of the scans, so the head's in the same position every time, to see this very small enlargement. The overlap between pearls and cells is only about 20%, which is probably telling us something important about underlying pathophysiology, but I'm not sure yet what it is. So BTKs have been used in other autoimmune diseases. They were not successful in a trial of lupus. In rheumatoid arthritis, they mostly were unsuccessful, except for one which had some improvement in the highest dose that was tested. They have been successful in chronic urticaria, at least with two of the agents that have been looked at. And you saw this slide earlier on from Jeff Cohen, showing the trials in MS that are going on with BTK inhibitors. So you have evobrutinib, which had successful phase 2, and I'll show you that, and has a phase 3 that we'll talk about a little bit, but as Jeff Cohen mentioned, you'll see more data on that, I believe, on Saturday. Tolebrutinib, which has, again, a phase 2 that I'll show you because it's kind of interesting, but also 3 phase 3 studies. Fenebrutinib had a successful phase 2 study. I'm not going to show you, I don't think, more details on that, and is in phase 3. 1 in relapsing remitting, 1 in primary progressive. And the others, well, the remibrutinib is going right to phase 3 after having successfully studies in chronic urticaria in phase 2. So here's the evobrutinib trial design, and you saw this already. What it showed was that the 2 highest doses produced the best effect. Interestingly, the 75 milligrams once daily made statistical significance, and even though this looks to be a better effect, it missed on the p-value by 1/100th of a point. But it does show that you need to get into higher doses in looking at that. And this was a very typical phase 2 design of reduction of gadolinium-enhancing lesions over a 6-month period that's been successful and has successfully predicted success in phase 3 almost every time it's been employed. On the right-hand side, you have the relapse rates, which weren't significant, but you can see the 2 highest doses over here were sort of trending in benefit, and we don't really hold, we don't ding these studies, these phase 2 studies, if they don't make annualized relapse rate, because it's very hard to do in a 6-month study. And so it was a 24-week study, 6 months, relapsing MS, had multiple arms with multiple doses. The primary outcome was total GAD lesions at weeks 12, 16, 20, and 24, and 75 milligrams once daily made statistical significance, twice daily just missed. There were elevated liver functions and nasopharyngitis seen. I'll come back to that. Then we have tolebrutinib, also a phase 2 study, but a unique design to allow them to look at multiple doses. Again, primary outcome was GAD lesions, but this was a 3-month study instead of a 6-month study. And it showed success in the highest group. So here's the design, and this is a unique phase 2 design. At least it's the first time that I had seen it. So it has both this 3-month multi-arm design and then a crossover. So what in essence is a delayed start group. And then a placebo group with the group that was treated originally, and I don't particularly understand that. Nevertheless, they were able to show significant results here. So at the end of 12 weeks, you could see a pretty good dose response, a little flat there, but it goes down, and then a very potent reduction at the 60 milligram dose, which was significant in this phase 2. So no one has seen this type of phase 2 predict phase 3 like we saw with the 6-month study. So this will be interesting to see when they get to the phase 3s. A similar finding in total number of new and enlarging T2 lesions, a dose response, and a very good response out at 60 milligrams. Side effects. Well, the main one for us to think about is down here, and that's liver function abnormalities, because there were clinical holds put on at least 3 that I know of these agents, meaning to me that this is a class effect. and it involved both the covalent binders and the non-covalent binders. Some people thought non-covalent, because it gets off of the molecule, would have better safety, but that's not necessarily the case. So that's something, the holds were lifted, and the studies are either completed or getting complete. But other things that have been seen have GI symptoms, fatigue, some bruising, some hematologic issues like neutropenia. Some of it's a little hard to put into context for us because a lot of it was in individuals with leukemia and lymphomas. And then this was a study, I thought I was being clever, but Jeff found this as well, that just came out like a week and a half ago, I think, in neurology, looking at evobrutinib reducing the slowly expanding lesion volume in a dose-dependent manner again. So it was a post hoc analysis, and he had a study that I didn't find showing something similar, I believe, in tolebrutinib in an earlier study. But I think that this particular metric is one that's going to be important as a secondary analysis when we look at people with progressive disease and how they respond. And then we have this evobrutinib versus teriflunomide phase 3 study. And this is the second unique thing I'll talk to you about today, because I've never seen a result like this. So as I said, that phase 2, the 6-month phase 2 gadolinium enhancing lesion reduction, has just about always predicted success in phase 3. But the top-line results of this study showed, which were the Evolution RM1 and Evolution RM2, annualized relapse rate was the primary outcome measure, and it was really quite low in both groups, both the evobrutinib and teriflunomide, which was the active control. And you can see 0.15 versus 0.14, 0.11, 0.11. These are very low rates. So other outcomes are pending. I suppose we'll hear about them on Saturday. So I'm going to give you my take on this, not having any unreportable or data that I can't mention. I don't know what the rest of the study showed. So this wasn't so much, it was a failed study in the sense that it didn't show superiority. But it doesn't mean that evobrutinib failed. There's a difference between the study failing and the drug failing. Both drugs performed exceptionally well in reducing annualized relapse rate. And you kind of got a hint of this in Aaron Miller's talk about the GA study, where that number was lower than what was seen earlier on, although it was similar as what we saw in CombiRx. So studies that we're seeing now, and the population we're seeing now, are all showing very low rates. So it could be that teriflunomide is a better drug than we thought. It also could be that there was a systemic issue with the study design or the study conduct or the analysis, including the possibility of just errors. I did talk to someone that was on the relapse adjudication committee, which was one of the things that helps you feel better about the fact when they're looking at annualized relapse rate. And he assured me that the relapses that they saw were the relapses they saw, and they did a very good job of analyzing the relapses. So I'm not sure what to make of this. I think when we see the secondary outcome measures, it will tell us something about this, but may not entirely answer the question, unless the secondaries show a difference that the primary analysis didn't. I don't know that that will be the case, but I think there's going to have to be a lot of data analysis of this study to see why it got this very unusual result. Like I said, some of it may just relate to the population that was enrolled, but we'll see. And then for the tolebrutinib phase 3 program, there's 2 relapsing remitting studies underway. They are, I was just told, event-driven studies, so I can't tell you when they're going to report out. And then there is a primary progressive study against placebo. The two relapsing remittings are against teriflunomide, so we'll get to see whether teriflunomide continues to perform at this very high level. The primary progressive is against placebo, and then a secondary progressive, a non-active secondary progressive, which is the Hercules study. those two, Perseus and Hercules, are the ones that I'm most interested in because we so badly need to find therapies for progressive disease. I don't know whether the difficulties in analyzing the relapsing remitting diseases will make it harder to interpret the primary progressive and secondary progressive, but that's also a possibility. Fenebrutinib also has 3 studies, 2 relapsing remitting, and this is a very brave, but in some ways sensible primary progressive study because they're comparing themselves to ocrelizumab. So it's brave because it's an active comparator that has succeeded, albeit modestly, but it still raises that bar to 24, 25%. It's sensible because we need to do much better than that. And so for one of these agents to succeed and do better than that would be actually very encouraging indeed. What's next? Well, further analysis of the evolution RMS studies that you'll hear more about, I guess, on Saturday. These other relapsing remitting studies underway to see if they produce a similar confounding result or a more clear-cut result. The progressive studies in non-active secondary progressive and primary progressive MS. Safety, we're going to need to look at liver more carefully. I think it's a class effect. And I like to think as BK as a potential agent for add-on or maybe even more importantly as a switch agent for people, 3, 4, 5 years downstream of their primary therapy, especially if it's a B-cell depleting agent. And with that, I thank you for your attention. Okay, I haven't seen Jiwan. Jiwan, raise your hand. Are you here? Ah, there you are. Okay, terrific. So next, Jiwan O from St. Michael's Hospital and University of Toronto is going to talk about the new era of biosimilar therapeutics. And this talk is also supported, and this one from Sandoz. So welcome, Jiwan.
Thank you, Fred, for the kind introduction, and nice to be here as a part of this outstanding course. So I am going to switch gears a little bit from many of the different topics that you've talked about today. And because we are likely going to have a biosimilar medication available very soon in most parts of the world in MS, I'll be talking about biosimilars in general and the development process for biosimilars, which is somewhat unique compared to new drug development, which is what we often discuss and we're used to in the MS field. And then I'll talk about the results from a very recent phase 3 clinical trial that looked at biosimilar natalizumab versus the reference product. So this is a slide outlining my disclosures. Okay, so we're just going to start by talking a little bit about definitions. And I have to say that I am by no means a pharmacist, so please excuse me if I get some terminologies incorrect. However, I'll do my very best to use the right terms. But just wanted to start by talking about what biologic drugs are. And these are actually different from many of the other pharmaceutical substances that we typically use in clinical care, in that many of the drugs that we use are chemically synthesized and they're often small molecules. And so this is not what we're talking about today. We're talking about biologic drugs, which essentially are any drug that are manufactured from organic or living substances. And as you can see here, there's a number of different drugs listed. Aspirin is an example of a chemically synthesized small molecule drug. Glatiramer acetate is not a biologic, but an example of a chemically synthesized complex drug. And then on the right-hand side are examples of 2 different biologic drugs which differ in complexity. For example, filgrastim is growth factor, and this is a protein that does not contain sugars, whereas rituximab, which is a monoclonal antibody, which many of us are familiar with in the MS world, is a glycoprotein. So this is a much more complicated biologic drug because it contains protein as well as variable sugars. So as you can imagine, the manufacturing process of these different drugs can be quite different because when you have a biologic molecule, there are a number of factors that you need to take into account in terms of how we look at the drug. So one thing, in contrast to chemically synthesized drugs, one thing we need to keep in mind is that variability is inherent in biologics. And it's entirely expected that, again, because these are organic molecules, many of them pretty complicated, variability is a normal principle in protein manufacturing. And it's expected that no batch of any biologic will be identical, exactly identical to other batches. However, the degree of variability is very tightly controlled within acceptable limits. And on the diagram on the right, you can see a figure outlining the variability that you see in a biologic medication. And then on the bottom, you can see two figures that demonstrate variability that you see pre and post manufacturing changes that we'll talk about in a second. So this is one key principle that differs with biologics in contrast to simply chemically synthesized molecules. In that, again, because of the complexity of the manufacturing process, as well as the fact that these are living molecules, there is a degree of variability, but that is very tightly controlled and monitored. In addition, because the manufacturing process of biologic molecules is pretty complicated, there's often manufacturing changes that can take place over time. And as you can see, this is a figure on the right that illustrates with many different biologic molecules that are currently being used, all of the manufacturing changes that have taken place when these drugs have been approved. So as you can see, this is to be expected. However, again, with any manufacturing change, these are stringently controlled and monitored and only approved if these manufacturing changes do not lead to any clinically meaningful differences in the biologic product in comparison to clinical outcomes prior to the manufacturing changes. So as you can see, it's pretty complicated, even in terms of regulation, because there is a degree of variability inherently, but this must be controlled within a certain limit. And then there's often manufacturing changes that occur with these molecules as well. And so then there's another degree of variability, and then comparisons need to be made to the product before these manufacturing changes took place. So in terms of biosimilar development, and again, we're focusing on this because in the MS field, for the first time, we will very soon likely have available biosimilar natalizumab. I think it makes sense to take a look at what this development process looks like. What is a biosimilar? The FDA defines a biosimilar as a biologic product that's highly similar to a reference biologic, but this can include minor differences in clinically inactive components. And so in a way, with chemically synthesized substances, this is very similar to a product as well as a generic medication. And in the MS field, we're pretty used to generic medications because many of these have emerged on the market recently. But again, this is the first time that a biosimilar medication is emerging with all of the complexities that it entails. With the FDA, when a biosimilar is developed, again, it's a biologic product that's highly similar to the reference biologic, and there must be no clinically meaningful differences between the biologic product and the reference product. And so we'll take a look at what this development process looks like because it's quite different from the development of a new molecule, which is, in terms of clinical trial development, something that we're very used to seeing in the MS world. And Dr. Lublin just gave a talk about so many different clinical trials where we're looking at the development of BTK inhibitors, and you'll see how biosimilar development is quite different. When you look at the process of developing a biosimilar, as you can see from these diagrams here, it's fundamentally different from the development of a new molecule. So on the left here, we have what a typical process looks like when a new drug is being developed, such as, for instance, a BTK inhibitor. So the first step in developing a new drug consists of developing the molecule itself. And so obviously there is quite a bit of analytical characterization of the new molecule. And then these molecules go into preclinical studies where if there is demonstration of efficacy, then it goes into human studies, so phase 1 PK and PD studies, as you can see right here. And then the bulk of the evidence for any new drug to be approved by regulators to be used in any disease state, and we're talking about MS, consists of clinical trials where there are phase 2 and phase 3 clinical trials that very clearly demonstrate efficacy of the new drug. On the other hand, as you can see from this diagram here, biosimilar development is kind of the opposite of what we see with new drug development, in that you already have a reference biologic, which is widely used, and we know based on prior studies, there is very clear evidence of clinical efficacy in a certain disease state. So when you're developing a biosimilar, the foundational evidence has to include a deep analytical characterization of the biosimilar. And so this is the bulk of the evidence when thinking about how a biosimilar is developed, because you have to first and foremost show that from both a structural and functional standpoint, the biosimilar is not different from the reference biologic. After that vast analytical characterization has taken place, as you can see, the next step in biosimilar development consists of preclinical studies, although these are not mandatory. But what is mandatory are PK and PD studies in humans demonstrating similarity with the reference biologic. And then at the very end, there's usually a phase 3 clinical trial that demonstrates similarity of the biosimilar to the reference biologic. However, as you can see, this constitutes the peak of the pyramid, and so typically these phase 3 trials are pretty small, and it's just a single study. But because this is fundamentally a different process than what is used for new drug development, this is essentially the totality of evidence that is required for a biosimilar to be approved for use for a specific disease indication. Okay, so let's look at a little bit more detail at some of these steps underlying biosimilar development. So again, at the base of the pyramid, there's this analytical characterization phase, which essentially is comprised of many, many different analyses demonstrating that the biosimilar has identical protein sequences as well as other molecules in comparison to the reference biologic. And once you confirm that the structure is nearly identical, then a number of functional assays need to be done to demonstrate that from a structural and functional standpoint, there is no meaningful difference between the biosimilar and the reference biologic. After that, again, you can move into preclinical studies, which are often but not always done, and then human phase 1 PK and PD studies, as well as finally a phase 3 confirmatory trial. So looking at this analytical step in a little bit more detail, just wanted to show you some of the different attributes that are evaluated in this step, which is by far the most important step in the development of biosimilars. And so essentially, confirmation is needed using various methods, showing that the biosimilar is identical to the reference biologic with respect to its primary structure, as well as its secondary and tertiary structures. Obviously, as we discussed earlier, with any biologic, there is variation, but it needs to be controlled within a strict range. Evaluation of glycosylation has to take place as well, and the strength and potency needs to be evaluated as well. This is an example of one of the methods that's often used to evaluate for structural similarity of biosimilars with the reference biologic product. So X-ray crystallography is a very commonly used technique used to confirm structural similarities. This is a table summarizing many different methods that are used for this analytical characterization step, and I don't want to take all of us back to pharmacology classes, but as you can see, there's many different techniques that allow one to confirm structure, as well as after the structure has been confirmed, there are also many functional assays that can be done, confirming that the biosimilar is from a functional standpoint nearly identical to the reference biologic. And this usually involves a series of ELISAs as well as adhesion cell-based assays. So once this analytical characterization has taken place, and again, there's a wealth of evidence that is required to feed into this step, and so biosimilar development will not progress at all if you aren't able to collect all of the evidence that very clearly demonstrates that a biosimilar is structurally and functionally nearly identical to the reference product. So once all of that data are there and look good, you can move on to the next steps, which include, again, sometimes preclinical studies, which are often but not always done, and then you move into comparative human PK and PD studies, as well as assessments of immunogenicity. So as you can see here, this is an example of a typical PK endpoint where the serum concentration of a proposed biosimilar is evaluated in comparison to reference biologics. And as you can see, these two curves look essentially identical. In terms of a typical PD endpoint, this is usually chosen based on its relevance to clinical outcomes that are measured during the time course of a phase 1 trial. And as you can see with the reference biologic as well as the proposed biosimilar, the biosimilar is outlined in the black curves here. These PD curves also look nearly identical. So finally, the last phase of a biosimilar development process consists of a phase 3 confirmatory study. And again, we need to keep in mind that it only goes on to this phase 3 phase when all of the steps below have been confirmed. But this is a comparative clinical studies that addresses any residual uncertainty and determines, importantly, if there are any clinically meaningful differences in the biosimilar versus the reference biologic. So this is what a typical design of a phase 3 confirmatory study looks like for a biosimilar. And essentially, it's usually a randomized parallel arm study that takes place typically in multiple centers where you compare directly the proposed biosimilar versus the reference biologic. And there very often is, at a certain point in the study, a time when people who are on the reference biologic are switched over to the proposed biosimilar, because as you can imagine, this is an important piece of information to collect to ensure that there aren't any unwarranted changes or tolerability issues when people are switching from the reference biologic to the biosimilar, because in the real world, should the drug get approved, this is probably something that will very commonly happen. In terms of the size of these studies, so first of all, in terms of the study population, usually the study population is powered to detect meaningful differences between the two treatments. And often the size of these confirmatory phase 3 trials are not very large. And this is because the typical phase 3 clinical trial endpoints are not necessarily used because this is the goal of this study is really just to confirm that there really is no difference with respect to clinically meaningful endpoints for the biosimilar versus the reference biologic. And so a sensitive endpoint is usually chosen that is thought to be within the disease state, something that is highly relevant to clinical outcomes of interest. And as you know, Dr. Lublin just talked about with some of the phase 2 and phase 3 clinical trials of BTKIs, often for a drug that is used in relapsing MS, a logical choice in this setting would be looking for new or active lesions in MS. So usually, with this typical phase 3 study design, these studies usually use an equivalence design, and there's symmetrical inferiority as well as superiority margins. So this is an example of a biologic, reference biologic that is being compared to a proposed biosimilar. And on the left, and I know the text is difficult to read, but it's not really that important because this is some sort of endpoint that has been chosen for this biologic that is used for some sort of disease state that is clinically meaningful. As you can see, with this sensitive clinical endpoint, there doesn't seem to be numerically very much of a difference. And then when you look at the mean difference in the primary endpoint, this is the pre-specified equivalency margin. And as you can see, the 95% confidence interval for this primary endpoint falls entirely within this pre-specified margin. So with these confirmatory studies, this is essentially what you're looking to do. You're looking to show that the reference biologic is similar with respect to this sensitive clinical endpoint as the proposed biosimilar, and you're looking to see that the difference in that primary endpoint falls within this pre-specified margin to be able to confidently state that the drugs are equivalent with respect to the primary endpoint of interest. In addition, embedded within these phase 3 confirmatory trials is that switch arm that I talked about. And again, this is not necessarily essential, but again, thinking about how biosimilars are used in the real world, it's a very important component of these confirmatory studies because at some point in the middle of the trial, people who are on the reference biologic are switched over to the biosimilar, and you want to demonstrate that pre and post switch, there is no difference in the primary endpoint of interest. And then importantly, immunogenicity is also evaluated, and you also want to show that there is no difference in immunogenicity once that switch is done. Okay, so in terms of the development process, I know that was a lot of information all at once, but I hope that I've been able to illustrate to you some of the important steps underlying biosimilar development and have highlighted how this differs from new drug development, which is what we more commonly talk about in MS. So first, we talked about how biologics are highly variable by nature, and you expect there to be some batch-to-batch variability, but obviously there's a certain range of variability that is acceptable, and this is tightly controlled. Biosimilars need to demonstrate a similarity to reference product, and this is done through the very first step is that analytical characterization that consists of confirming that the structure and function of the proposed biosimilar is highly similar or nearly identical to the reference biologic. Then the biosimilar will move through preclinical PK/PD as well as a confirmatory phase 3 clinical study before they can be approved. And again, the analytical studies essentially confirm that the structure and function of the proposed biosimilar is nearly identical to the reference biologic. The PK and PD profiles of the biosimilars must match the reference biologic. And finally, at the very end, there's a phase 3 trial that's used to confirm biosimilarity using a meaningful clinical endpoint. Again, that is often sensitive, so this does not require usually a huge clinical trial in the range of typically 1,000 that we often see in new drug development phase 3 clinical trials. So moving into specifically biosimilar natalizumab, which probably many of you know, has been approved in both Europe as well as the United States and likely will be approved in many other parts of the world shortly. So we'll talk a little bit about the development of this molecule, and I'll just call it biosimilar natalizumab, but the official name is PB006. And so this is the first biosimilar, again, that has been approved for use in the MS field. And as many of you know, this is a molecule that is biosimilar to Tysabri, or reference natalizumab, which was the first monoclonal antibody that was approved for use in MS. We're fortunate in the field because we have many other monoclonal antibodies that are commonly used. But as many of as the clinicians in the audience know, natalizumab is still an old drug, but a good drug to use and useful in many situations because we tend to classify it as one of our highest efficacy drugs. Of course, there is this issue of PML that can become an increasing problem over time, but there are ways to risk mitigate it. And I think one of the greatest utilities of a drug like natalizumab is the very rapid onset of efficacy. So I think in certain situations, there is clearly a role for this drug, and so it will be interesting to see with biosimilar natalizumab emerging on the market, how this will change things in terms of how we use the drug. So what does the timeline of biosimilar natalizumab look like? And actually, okay. So as you can see here, this is all very recent. Initially, between around 2019 is when the biosimilar natalizumab was first designed. It launched into phase 1, and during that time, obviously, there was the intense analytical phase where there was confirmation of structural and functional similarity to reference natalizumab. And then it went into phase 1 PK and PD studies around 2020, and this is also around the time when the phase 3 Antelope study that I'll tell you about in a second was launched. And then in 2022, the PK and PD studies completed at the end of 2021. And then towards the end of 2022 is when the phase 3 Antelope study completed and showed equivalence of biosimilar natalizumab to reference natalizumab. And very recently, last year, actually about 6 months ago, is when both the US as well as the EMA approved biosimilar natalizumab, and additional approvals are likely around many parts of the world. And so this is likely a product that we'll have available for use in the clinical setting very soon. And obviously there will be differences in price of biosimilar natalizumab in comparison to the reference product. So again, I think it will be interesting to see how this changes what we as clinicians do with respect to utilizing certain drugs, because I often find that it's often insurance and requirements of payers that can often determine what drugs are used in certain settings. And so when there is a cost savings, it'll be interesting to see how things play out. But this is a diagram that's very familiar to you, and so we'll take a look at some of the steps that were involved with biosimilar natalizumab and look how it compares to our reference product of natalizumab. Why don't we take a look at some of the analytical studies that were done. And so I know this is a very busy table, but as you can see, many of the structural and functional techniques that I outlined earlier when we were just talking in general about biosimilar development were performed with biosimilar natalizumab in comparison to the reference product. And as you can see, structurally, it seemed like these molecules were highly similar. And then from a functional standpoint, a number of functional assays of relevance were done, including ELISAs looking at binding of biosimilar natalizumab to the alpha-4 beta-1 integrin, looking at interactions between VCAM1 and alpha-4 beta-1. And so all of these structural and functional assays confirmed the similarity of biosimilar natalizumab to the reference product. These are just a summary of some of the functional studies that were done. And so as you can see, again, this was kind of the bulk of the data that propelled further development of this drug. And based on all of these functional assays, there was confirmation from a functional standpoint of the equivalence of biosimilar natalizumab to the reference product. So after this, there were phase 1 PK and PD studies done that confirmed, again, that biosimilar natalizumab was nearly equivalent to the reference product, and that the final phase of biosimilar natalizumab development includes this phase 3 clinical trial that's also called the Antelope study. And so this was a study similar to that study design of a typical phase 3 confirmatory study that I showed you that evaluated the equivalence of biosimilar natalizumab to the reference product. And so the study design consisted of a multi-center, randomized, parallel arm, active controlled, double-blind confirmatory study, and it included a little bit over 250 patients with relapsing MS, and very typical criteria that we're used to seeing with relapsing MS clinical trials. And patients were randomized to receive biosimilar natalizumab or the EU-approved reference natalizumab product, and they received infusions once every 4 weeks. So this is what the study looked like. And again, importantly, the primary endpoint that was selected was the cumulative number of new and active lesions over 24 weeks And as I showed you earlier, in a typical confirmatory study design, at the 24-week mark, a proportion of people who are on reference natalizumab switched over to biosimilar natalizumab, which allowed an evaluation of any unexpected adverse events that may occur when people switch from the reference drug to the proposed biosimilar. So when we look at some of these outcomes, importantly, with the primary endpoint, which was the number of new active lesions, as you can see, there did not appear to be numerically much of a difference between reference natalizumab and biosimilar natalizumab. And again, when you look at the outcome in a different way, as you can see, there really was not very much of a difference in the primary endpoint of interest, and it fell entirely within the equivalence margins that were pre-specified. There were also a number of clinical endpoints that were evaluated, including the annualized relapse rate as well as EDSS scores. And again, the study was not powered to detect differences in these clinical measures, but when we just look at some of the numerical measures, and I'm sorry this table is so busy. I actually had sent an updated version of these slides, but this is the older version. The annualized relapse rate was not very different between the two arms at 24 and 48 weeks. It was 0.21 in biosimilar natalizumab versus 0.15 and 0.17 at 48 weeks versus 0.13. Moving on, looking at the EDSS scores at 24 weeks and at 48 weeks, again, when you just look at the values, not very much of a difference at all between biosimilar natalizumab in comparison to the reference product at 3.37 and 3.18, and then at 48 weeks it was 3.24 and 3.12. So this is all quite reassuring, and numerically there was actually a slight decrease in comparison to the baseline values, but this is probably not clinically meaningful at all. Finally, at 24 weeks, there was that proportion of patients in the reference natalizumab arm that switched over to biosimilar natalizumab. And as you can see, again, when looking at the MRI outcomes, when you look at all three arms, so people who are on just reference natalizumab, those who are on biosimilar natalizumab, and those who switch from reference to biosimilar natalizumab, there really wasn't very much of a difference in terms of the mean number of active lesions. And again, the text is very small, and I apologize. As well as the mean number of gadolinium enhancing lesions. And again, looking at clinical outcomes, namely the annualized relapse rate as well as EDSS, there weren't any significant differences between the groups. Okay, so finally, when safety was evaluated, importantly, there were no fatal treatment-emergent adverse outcomes. But as you can see, the proportion of people who had any AE was similar across the three groups. So again, this is the biosimilar natalizumab, those who did that switch, as well as those who just remained on reference natalizumab. And then when you look at rates of adverse events of special interest, which include infections, malignancies, as well as cutaneous issues, as well as obviously PML, there were no meaningful differences. And then finally, looking at treatment-emergent adverse events that led to withdrawal from the study, there were none across these treatment arms, but this was only over 48 weeks. I should note also that one of the exclusion criteria of being enrolled in this study was having a high JC virus index titer. So this is something that was also monitored during the study, but this study only included people at baseline who had a JC virus index titer of less than 1.5. Okay, looking at safety at a different way, again, it's a little bit easier to see this because you don't have to read the small print, but as you can see, when you look at all of these, any treatment-emergent adverse events, SAEs, everything, it looks pretty similar between the three treatment arms, which again include biosimilar natalizumab, reference natalizumab, and then people who switch from reference natalizumab to biosimilar natalizumab. When looking at the most common AEs by treatment arm, again, as you can see, pretty similar and what we would expect to see. So COVID-19 and nasopharyngitis were some of the most common AEs that were seen, but the usual suspects did emerge as well, including back pain and headache and dizziness. And this is reminiscent of many different MS clinical trials. Finally, looking at immunogenicity between biosimilar natalizumab as well as reference natalizumab and in people who made that switch. As you can see, there was a pretty high proportion of people who had neutralizing anti-drug antibodies, as you can see here. And the explanation for this was that a much more sensitive anti-drug antibody assay was used. But what I found quite interesting was that there's a proportion of people who did have anti-drug antibodies that were confirmed to be neutralizing antibodies. And as you can see, the proportion was quite high here, but there clearly was not a difference in efficacy. So I have to be honest, I don't really know how to interpret this from the clinical trial. There are other studies that have shown with reference natalizumab, when you look at proportions of anti-drug antibodies using a highly sensitive assay that was used in this clinical trial, the proportion of anti-drug antibodies can be as high as was seen here. But I find it puzzling that there was such a high proportion of actually confirmed neutralizing antibodies. That is a question that I have that I'm not sure I can answer, but this is something that was observed in the clinical trial. And importantly, there was no difference between reference natalizumab as well as biosimilar natalizumab and individuals who switched from reference natalizumab to biosimilar natalizumab. Okay, so this brings me to the end. I hope, it was a lot of information, I know, but I hope that I've been able to give you an overview about what biosimilars are and what the steps are in biosimilar development and how this is different from new drug development. Just to summarize again, biosimilar development consists of the foundation of evidence is derived from the analytical studies, but then they move into phase 1 PK and PD studies as well as a phase 3 confirmatory study to confirm that the biosimilar product is equivalent to the reference product. It will be interesting, I think an interesting time in the MS field because again, biosimilar natalizumab has already been approved in Europe as well as in the United States and will be approved likely in many additional parts of the world. So we have the addition for the first time of a biosimilar product that we have a lot of experience with over nearly 2 decades. So it will be interesting to see how things play out, and especially with the cost savings overall, I think this is a positive thing for the field and will likely result in improving outcomes for people living with MS. So thank you very much for your attention, and I'm not sure if we're doing questions. Okay, great.
Thank you, G.Y. Aaron, go ahead. The question is for the folks in the cloud there, whether there's problems if the biosimilar doesn't have access to the reference drug.
I presume that the proprietary company is not mandated to give the drug to the competitor.
Sir, I don't think I understand the question.
You have to do a comparative trial against the reference drug.
Yes.
Therefore, you have to have access to the reference drug to do that trial. I raised the question because I just read an interesting book about the development of BTK inhibitors focused on ibrutinib and acalabrutinib, the next drug. And when they went to do the acalabrutinib trial, comparative trial, they had great difficulty obtaining ibrutinib. No one would sell it to them. Could we not be in that situation?
Well, the trial has already been done, so...
No, he's talking theoretically.
Oh, theoretically.
The answer is yes.
Yes, I think so. I feel that that would be unethical, though, and...
But that has nothing to do with business.
Yeah.
So some of the teriflunomide studies were done with teriflunomide synthesized and sold elsewhere in the world, for example.
You raise an interesting point, and I can see... That could make things difficult, indeed.
So as a reminder, before I give you my question, so
PK, pharmacokinetics, is what your body does to the drug in terms of distribution, metabolism, and excretion. Pharmacodynamic is what the drug does to your body. And so, for example, if I was developing a biosimilar for an anti-CD20 we're going to hear about in just a moment, it would be easy. I would look at B cell counts. So you kept saying PK-PD. What is the PD for a Tysabri study?
They looked at saturation of the alpha 4 beta 1.
In vivo or in vitro?
In vitro. Oh, sorry, it's PK-PD in vitro as well as in vivo.
In vivo?
Yeah.
Okay, and that would be a good PD.
And so it's, for any drug, it really is something that is thought to be clinically meaningful. And so for natalizumab, it obviously would be the target engagement.
Yeah, okay.
Yeah.
I'll buy that. Mark?
Thank you, Jiwan. That was beautifully done. I have just a comment and a question. So the anti-drug antibodies, at least initially with natalizumab, were associated with increased infusion reactions. I guess that was not seen in these studies. So exactly what kind of anti-drug antibodies they are is the question, right?
So yes, and the association was not reported on. I would assume that there probably was higher infusion reactions, and there were infusion reactions observed, but this was not one of the outcomes that was reported, at least in the paper.
And the other one is just a curiosity. The antibody test for JC virus is proprietary and owned by another company. So how do you have access to it to screen patients for the biosimilar?
I'm not sure. That's a good question. But it was very clearly reported in the study, so I'm assuming that maybe the proprietary test was shared, just because, again, I feel like it would be unethical to not make the reference product available or not have necessary tests to monitor the safety of people that are in these clinical trials. Maybe another one will have to be developed.
You talk about the JC antibody test?
Yeah.
Yeah, okay. Well, that was an inclusion criteria, so it's a little different.
Mark
And there
is
was a
saying
question,
it's
there was a,
proprietary, though, the test, and so how did they access it?
well, you can
And
order
what
it.
happens?
You can order it on your patients, whether it's proprietary or not.
It was part of a clinical trial, though.
But it was an inclusion criteria.
Yeah.
So, and someone raised a question about cost. Do we have any understanding of how this is going to be handled in terms of costs related to Tysabri?
I've asked this question, and I heard it will be about a 30% reduction, similar to what we see with generics.
Okay, thank you very much. Okay. We're down to the final talk of the day, and we're even going to end up on time. So we're going to have Dr. Freeman come back up and talk about clinical update on anti-CD20 therapeutics. This talk has been kindly supported by an educational grant from TG Therapeutics. So your cleanup, Mark.
Thanks, Fred, and thanks to all of you who are still here. I appreciate hanging in to the end like this, even though the weather's so beautiful outside. Okay. I'm going to review a little bit about the clinical trial data. You've seen it all. It's all been published anyways. But talk a little bit about the differences amongst these drugs, because we now have 3, 4 if you include the rituximab, and then try to, again, summarize, similar to what I did earlier, putting this into perspective of a treatment paradigm. So we've got 3 drugs to talk about, and I'm not going to really talk too much about rituximab, because although it's there and it's been used off-label for many years, there really aren't properly controlled phase 3 studies that speak to the efficacy. That doesn't stop people from using it and or using it to replace some of these other drugs. We have situations even in our country where ocrelizumab or even ofatumumab, if it's ordered is replaced by the government with rituximab because it's in fact cheaper. So there are differences and there are some limitations. I'm just going to go through these. We don't know who the bad guys are, and this is probably one of the issues. If I look over here, not all B cells are bad, and obviously you need your B cells to function at some point. So only a small segment of these are pathogenic. We don't know who they are. If we could identify them, it might be possible to make even a finer antibody, but that is not the case. We know that some of the B cells are important for conferring passive immunity, and how to distinguish between the good guys and the bad guys is just not possible. We have some thoughts about the different kinds of functioning B cells and which ones might be more associated with disease, such as the so-called memory B cells, but I'm not going to get into the basic immunology, especially at 5 o'clock after a long day. So don't worry about that. But over time, one of the things that we worry about is the body is going to need a B cell to defend itself. And so the concern is over many, many years, is it putting patients at risk for perhaps infections or other concerns with the immune system, which also guards against malignant transformation. So some of these answers are not there, and I'll even throw in maybe a sixth one here, and that is, do we need to sustain the hit on the B cell forever, or could a period of treatment, 2 years, 4 years, 6 years, whatever, be enough to sustain a durable response on the disease so that you don't need to maintain the depletion of the B cell? I wish I had answers to all these questions, as I don't. But let's talk about the differences amongst these agents. So they target CD20, but CD20 is a complex molecule, as you see here, and the focus of each of these monoclonals is a different portion of the CD20. So you can see the epitope for ofatumumab overlaps a little bit with the epitope for ublituximab versus rituximab and ocrelizumab. So this is like the only immunology here, but it's what sort of things are relevant to the B cell and what it might be doing in MS is not 100% clear, but we know that activated B cells are actually very important to the immune system. They release cytokines, we know that. They very much interact with the other major elements of the immune system, such as the T cell and the antigen-presenting cell. So the molecules that are produced by the B cell encourage the interaction with the T cells, to the point where actually the B cells can act themselves as antigen-presenting cells, and the result of that interaction is often the stimulation of a very potent T cell. So this is sort of the theory here, is that the B cell is acting as an antigen. What it's presenting in the case of MS, not clear, but the B cell can function because it has an MHC class II molecule on it, and it can function as an antigen-presenting cell, and when it does so, that interaction is a very potent one. You could think of it as a very specific interaction, whereas the myeloid antigen-presenting cells constantly sampling in the environment, and the T cells may or may not react, but when you see the same kind of interaction with the B cell, they almost always react. The concept of why B cells may be important is kind of derived from some observations. The one that keeps coming up is this notion that within the brain there are structures that resemble follicles, like you would see, for instance, in lymph nodes, and they stick around in the meninges. These are more prominent in progressive forms of MS, but nevertheless, these follicle-like structures contain a lot of the B cells. They can, in these follicles, act like they do in a lymph node, and that's where the interaction could be for the T cells to do their thing. So you've got this follicular network in the brain, you've got a follicular network in the periphery that are generating these things, and there's a constant exchange between the two. And the thought is that if you deplete the B cells peripherally, they are probably the source of the B cells that go centrally. So you don't need to necessarily get the depleting monoclonal into the brain to do the depletion. You can deplete peripherally and get that kind of result. This is all very theoretical, but this is the rationale behind the B cell treatments, at least in the periphery. At some point, you'll have depleted the cells of interest, whoever they happen to be, and that's why I raised the question, do you need to keep this up year after year after year, or can you have an ability to stop the treatment, allow already whatever changes have taken place in the B cell repertoire to maintain themselves, and if you could identify which cells are bad, maybe at that point you might want to retreat. And I throw that out at you because our Swedish colleagues have been doing this for years. With rituximab, they have the capability of monitoring for these so-called memory B cells, and only when they see a return of the memory B cells do they then go back and actually retreat again with rituximab. And that's something that requires flow cytometry, a lot of markers, and something that's not routine done in most laboratories. This is the life of a B cell, starting way over here on the left as a stem cell to its final differentiation state, which is a plasma cell making immunoglobulins. And there are many, many different stages during which we can identify the differentiation of a B cell as it grows. And some of these are markers that you see here, but where does CD20 play a role would be from the immature B cell right out into probably the end of the memory B cells, not really the plasmablasts, although there is another molecule out there that targets CD19 that is used for NMO that might actually target the plasmablast. So if you're going to use an anti-CD20 to treat or eliminate B cells, you can see the range of the B cell that may be eliminated at any one point here, but you're certainly not going to get rid of the plasma cells or the late plasmablasts. Just a little thing on terminology. I thought this was kind of cute. There's so many monoclonals out there, and everybody's got MAB as an ending, right? Monoclonal antibody. What's the real difference? So the actual little terminology is out there that if it's OMAB, that's murine, we don't use those. Those are mice. But a chimer has mostly a human nature, so that the thing that actually binds to the human molecule is human, so it's got a little piece of human. But the base of this, the so-called FC portion of the molecule, is mouse. So those are all named iximab. So if you have rituximab, anything that's iximab has got some mouse in there, okay? You can humanize it and really get close so that only very, very little of this molecule is mouse, and that's the zumabs. And if you are completely human, no mouse, it's an umab. And this is relevant to the point of whenever you've got mouse in you, your body will probably make an antibody to it and reject it, and that leads to all sorts of different reactions. So pretty well, anything that's an iximab or an izumab is going to require a little bit of forethought before you give it so that you can avoid reactions. So we just heard about natalizumab, so it's over here. It's actually a humanized monoclonal, and not surprisingly, before you give it intravenously, you may consider some things like antihistamines or even a small dose of steroids, so there's less of reaction to the little bit of mouse that's sitting there. Whereas you have a fully human molecule, you don't have to worry about this. because it's fully human. It's very unlikely to be rejected. Just thought I'd throw that out at you. Okay, so here are the 4 guys we're going to talk about. We're not going to talk about rituximab so much, but ocrelizumab, ofatumumab, ublituximab are the 3. So these are the differences. I think I've already pointed these out. The ofatumumab is fully human. Here you can see a little bit of mouse, a little bit less because it's humanized mostly as the molecule, and the various motifs of the CD20 molecule that is bound to by the different drugs. Does that mean anything to the absolute efficacy? That's the big question, right? So here are some of the differences. We've already talked about it. These are B-cell depleting monoclonals. So how does that happen? I don't want to get, again, into too much of the immunology, but when an antibody binds to something, there's a reaction that takes place. It can bring in that whole family of complement molecules that you know, once assembled, create a pore in the cell, literally opening the door for a rapid exchange of water and other molecules, leading to probably the cell exploding and dying. So complement-mediated lysis is one way in which it works. The other major way is something called antibody-dependent cell cytotoxicity, where they literally bind to the cells, exposing the Fc portions, and then along comes a cell that has an Fc receptor, often an antigen-presenting cell or even an NK cell, sees the cell that's marked for death and pulverizes it with all its proteases and other things that those cytotoxic cells can release. So it's quite potent. Either of these 2 types of mechanisms are quite very good, let's just say, at eliminating the B cells. And where they occur, depending on where they occur, is where all the side effects may occur. So if you're going to give it intravenously, and a lot of this is going to happen intravenously, you have a problem when cells explode because they release the things that are stored within it that they don't normally release. And so those types of cytokines can create a bit of a storm, create a lot of side effects in the body. So we try to protect by giving pre-doses of things like antihistamines and steroids to cut down the reaction that you would see from this cell death. The ofatumumab obviously has an advantage because it's not given intravascularly, so you're not going to see that type of thing. So these 3 are all given as an infusion, whereas ofatumumab is given as an injection. Here's why you give steroids and antihistamines. I think I explained that to you. And then the frequency, the intravenous drugs are given every 6 months, which is not terrible, whereas the ofatumumab, after the initial few doses, is a monthly sub-Q infusion. The other thing is what happens to the B-cell population if you stop it, how quickly do they come back, and when do they come back? And that's a little bit different amongst the different drugs, and I think I have a better slide at this. But if rituximab, we're not going to talk about, it could take a year. We don't have data on ublituximab on B-cell repletion, at least I didn't see any. And then you can see that there's variable recovery with ocrelizumab. It's takes quite a bit of time, 46 weeks or so for the lower limit of normal. And then it's much shorter for ofatumumab, for the B cells to return to at least a normal number. What the constitution of those cells are is very important, and those differences have not been looked at. So we've got the different trials that you can see here that have been done. There are no phase 3 trials for rituximab. There was the Hermes study that was a phase 2 that led to the push towards rituximab. There was a phase 3 study in primary progressive, but it failed, so we're not talking about it. But each of these other products have gone through identical paired phase 3 trials. So basically, I don't know if this is an FDA requirement. You had to do 2 trials in 2 separate populations, more or less to prove the efficacy. And each of these have done this. Because it's in relapsing remitting MS, the primary outcome was ARR, although with the ublituximab it was MRI. But we've got data on all of this, and I'll just briefly run you through it because it's all published data. It's been around for a while. The first one that came out was ocrelizumab, and it was pitted against the interferon beta-1a 3 times weekly dosage, where you saw a substantial reduction in ARR. You know, these numbers are almost historic now, Fred. We never see these numbers anymore. I remember the first ones were up in 1.5. But here you have OPERA 1 and 2. The numbers were almost identical. It was amazing when these things came out because there were 2 completely separate studies and they produced exactly the same results. So interferon produced the same result, and so did ocrelizumab. The real marked effect was on the reduction in new enhancing lesions, with a near 95% reduction in the presence of new enhancing lesions. It's not 100%. Remember what I was talking to you earlier? It's not 100%. So if you're looking for 100%, none of these drugs are going to give it to you. Number of new or enlarging lesions, you can see here, these were statistically important. And whether you looked at 12 or 24-week confirmed disability progression, there was an advantage over the interferon, statistically significant, at reducing the number of people who had progression. It also looked at confirmed, these are just similar endpoints. I'm not even going to talk about it. But they looked at NIDA, and so this is something that you can compare amongst the other products. So NIDA 3, which is no relapse, no progression, no MRI, 48% versus the interferon, which you saw was 28%, for a 76% increased NIDA rate. They looked at NFL, and this is interesting because you heard earlier how NFL didn't work very well in progressive disease, but there hasn't been a study in relapsing disease that NFL has not paralleled the treatment efficacy that was seen with whatever drug that you're going to test. And that's probably one of the benefits of measuring something like serum NFL, because it'll go down as a response to the medication. So remember I talked to you earlier, I said, how do you know if a drug is working? Well, you could say, well, nothing's happened, so maybe it must be working. Or you could look at something positive and say, the NFL should go down. It went down. So if it goes down, you've got a measure. What's the downside? What were the adverse events? Clearly, because you're giving intravenous, there's an infusion reaction. These infusion reactions can be mild, moderate, severe. For the most part, they're mild. They're usually abated by the pre-med that we often give. But there were a bunch of other things that are present in everybody, like the nasopharyngitis, etc. The one concern was influenza reactions, or just influenza or flu-like illnesses or upper respiratory tract infections. And I'm going to come back to that because I think there is an issue there with ocrelizumab. There was also very early on a concern that has not panned out with longer-term safety data, that there were, between the 2 OPERA studies and the primary progressive study, which was oratorio, 4 breast cancers. So rather than having 4 random malignancies, there were 4 breast cancers. And the question is there something about this drug that might expose or unmask the risk to breast cancer? And that has just not been seen with any of the other B-cell therapies, and it hasn't been seen in a long-term follow-up of these patients. So that's what can happen very early on in a study. It raises concerns, so you follow these patients and you follow the group, and it didn't matter whether you were exposed long-term or not, the risks did not go up. But nevertheless, they were there. So what was the downside also? I mentioned that if you deplete the B cells, you also deplete the population that'll give rise to your plasma cells. The plasma cells make your immunoglobulins, and especially immunoglobulin G protects you against respiratory infections. So you can see, forget about IgM. They measure it in everybody, but IgMs go all over the place, and they're not terribly relevant in this regard. But the IgG definitely reduced, and these are the 2 arms here. The IgG this is the ocrelizumab versus the Rebif arm, or the interferon arm. And there was a period where IgG would go down. And if you looked at the rate of serious infections with regards to the periods during which the IgG was below the lower limit of normal. So let's focus on this 5.48 versus the 2.14. So you were nearly twice as likely to experience some of the upper respiratory tract infections that are associated with that. And remember a few years ago with that thing called COVID, there was a concern that the anti-CD20s were in fact associated, and mostly with rituximab, because it was used much more commonly around the world than ocrelizumab, but nevertheless, those two drugs were pegged with perhaps an increased risk for COVID and very severe COVID. Let's switch to the ofatumumab now, because that was the next drug that came out. Very similar, 2 parallel studies, relapsing remitting MS, this time not against interferon, but against teriflunomide, double-blind study, same types of outcome measures, similar to the ocrelizumab studies, but the comparator drug is now different. Remember, it was about 46% or so reduction in ARR. Here's ofatumumab showing about a 50% reduction in the first study, a 58% reduction in the second study. The overall ARRs have gone down compared to the other study. So every time we go further out, the population seems to be doing better. And as we saw with the recent evobrutinib, teriflunomide is doing exactly what interferon did over 20 years or 30 years. I jokingly say it's like a good wine, it just keeps getting better with time. So it's probably not the drug, but it's the population that's changing. Similar to ocrelizumab, which produced a 95% reduction in GAD-enhancing lesions, you got a 97% reduction in one, 94% in the other, relative to the active comparator, in this case being teriflunomide. And when you look at new enlarging lesions, you're getting the same sort of range of reduction in MRI activity. And you're getting an effect at slowing confirmed disability worsening. You like that word better, Fred? Okay, so CDW. This was statistically significant in both studies, either looking at a 3 or a 6 month definition of confirmed disability worsening. They also looked at PIRA. We heard earlier what PIRA was of interest. And so here, this is sort of the new thing to look at. There was a 41% reduction in PIRA with or without confirmed relapse, and even looked at the patients who evolved to secondary progressive MS versus teriflunomide. Looked at NIDA. So how well did you do with regards to NIDA? So there was a threefold increase in the number of patients achieving NIDA versus the teriflunomide. Serum neurofilament, it goes down. Interestingly, it also goes down with teriflunomide, but it goes down a lot more with the ofatumumab in both studies. What was curious was when you looked at something like brain volume, and we knew from studies with teriflunomide that teriflunomide reduced the amount of brain volume loss in its studies, but in this particular comparison with the ofatumumab, neither of the studies showed a statistically significant difference in the loss of brain volume over time, as you can see here. In terms of adverse events, we don't have infusion reactions because this is not an infused drug. This is a subcutaneously given drug. But if you looked at infections and infestations across here, there was only a slight difference between the teriflunomide and the ofatumumab, and there really weren't anything else of concern here. And when you looked at the serum IgG changes, which, remember, I'm going to ignore the IgM, but I'll come over here and talk about the IgG. There was a very minimal change. In fact, the red is actually teriflunomide. So ofatumumab was not associated with any significant reductions in IgG in either of the two studies. And so this was really, when you try to associate the infections with or without the immunoglobulin changes, the whole exercise was rather moot because the only real IgG drop was seen in teriflunomide, but there were so few infections that you couldn't really tell the difference between the teriflunomide or ofatumumab. What about, this is after the first drop of IgM, which doesn't, it's just it's flogging a dead horse. There's nothing there, so I didn't bother showing it to you. Okay, ublituximab, also 2 studies, Ultimate 1 and 2, looking at, in this case, also with a comparator and the same sort of outcome measures. The comparator is the same now, it's teriflunomide. It was a 96-week study with a typical follow-up. Very similar populations as seen in the Asclepios trials or even the OPERA studies. And the endpoint of ARR, a little different at this particular population, but again, look how good teriflunomide did in this study, 0.188. So we've seen it go from, the original teriflunomide study was like 0.4, and now it's 0.2, now we're into the 0.1 range. That much better though with the ublituximab, a 60% reduction in relapse rate in the first study, 49% in the second. So very similar numbers on the MRI. So when you suppress the gadolinium-enhancing lesions by 97% in one study, 96% in the other, and new enlarging T2 lesions were quite significantly. This number was actually a lot better than what was seen in the ofatumumab, but they're different studies. Interestingly enough, no effect on confirmed disability progression at 12 or 24 weeks. This was not statistically significant in either study. But look how few patients in the teriflunomide study actually progressed. Only 6% in this study and 5% in this. So you're really threading the needle here and trying to see if there's been much of a difference. We're talking about only, look at the number of patients, very, very small proportion of patients actually progressed in either of these studies. So you could argue you were not really powered to see a difference in progression as measured by EDSS with so few people progressing. Now, the opposite of progressing is improving, and occasionally we see that, so this is a bit of a post hoc kind of, or tertiary sort of analysis. Interestingly, there was a statistical significance in that more patients showed confirmed disability improvement either at 12 or 24 weeks, but we are talking about a very few patients percentage difference, but this was at least statistically significant. In NIDA, there was 198% improvement, if you like big numbers here, the way they can amplify it here, but there were more NIDA patients with the ublituximab versus the teriflunomide. In terms of adverse events, we have a big one at the top here, which is infusion reactions, because you are giving this drug as an infusion. So with teriflunomide, very few percentage, because of course this is all placebo, but nearly 50% of the patients with ublituximab had infusion reactions. Other things like headache, nasopharyngitis, any of these other things are really not significant. What about serious adverse effects? So we did have some malignancies, but they were across the board, 2 in the ublituximab, 1 in the teriflunomide group. There were some deaths, they were all unrelated. There were no cases of PML, but slightly more of these serious events were seen in the ublituximab versus the teriflunomide, but it didn't really pan out for infections, just 1% difference there. The infusion reactions, well, obviously none here because we're not infusing anything other than placebo in the teriflunomide, but there were at least a number of infusion reactions up front with the first infusion. They disappeared, as they often do with subsequent infusions with this particular study. The IgG, so IgMs are all over the place, we're going to ignore them, but for IgG, you can see here at week 48 and week 96, there were very minimal to no differences between the ublituximab and the teriflunomide group. So overall now, these are the concerns with B-cell therapies. I'm just going to bring them all back together here. The concern is serious infections. The trials were short. As we monitor patients in the long term, I think those of you using B-cell therapies have seen that if you do measure it, that the IgG can drop and it tends to stay down. Has that been associated with infections? And I've seen it in some patients, but they're mostly my older patients they've been receiving anti-CD20 for primary progressive MS. It's less common in the younger group where you're using it for relapsing remitting disease. Serious opportunistic infections are rare to none. I know there's a case of PML out there that was not due to natalizumab crossover to ocrelizumab, but there were other things. I think that individual was quite an elderly individual with comorbidities. So you have to seriously consider the fact that these are immunosuppressive drugs and look at the patient who you're giving it to. And if these are sick, debilitated, old individuals, then what are you doing giving a drug like this to them where you know you're going to get into trouble? We don't know about the reconstitution of the B cells. We think it's going to be different. So that's the whole key, is that you're knocking them all out, but maybe the bad guys, the pathogenic B cells, are going to be more sensitive to the anti-CD20s, and then over time they're going to deplete, and the reemergence of the B cell population seems to be less likely to attack. Maybe there's something about those cells that are different, and we need some more studies to actually look at which B cells are involved. Most of them talk about the suppression of B cell memory cells, which people have hypothesized are the pathogenic B cells. But you can't let up your guard, especially in older patients. You need to be watching for potential for problems. The problems could be as minor as upper respiratory tract infections. In the case of the COVID, make sure your patients were immunized. There was a thought that you couldn't immunize these people because on a B-cell therapy, you're going to block the ability to make a vaccine response. All the companies have shown, I haven't seen data for ublituximab, but I'm sure it's there, that despite the B-cell therapy, you can get a vaccine response. Some very elegant work was done by Amit Bar-Or's group at UPenn, where they looked at not only the antibody, but they looked at the ability of a cell response to a vaccine. So it looks like the capability of responding to vaccines is still very much there. So you counsel your patients, get your COVID shots, get your vaccines for the flu, because you're possibly at higher risk for those viruses, and why don't you do what you can to protect yourself from it? Makes sense. The breast cancer issue has popped up with ocrelizumab, but not of the other drugs to date. And even with ocrelizumab's now vigilance going over 10 years to almost 20 years, we've not seen that increase. I'm going to just rehash what I said earlier, but I don't want to get into it. There's a lot of considerations as to where you would use the anti-CD20. It's considered a higher efficacy therapy, so I think we've discussed that ad nauseum today. If you can get your prognosis, if this is a patient who you feel is at a higher risk for early progression, you're going to grab the high efficacy therapy to start with. Maybe if it was a failure in the first line, so you would use it as a second line. Think now you're using a more potent drug. You got to consider the possibility the patient's older or may have certain comorbidities. What about pregnancy? And there's some data out there that suggests that the anti-CD20s are probably safe during pregnancy. That's different than actually doing a study proving that they're safe in pregnancy. So there is some concerns there, but there's a workaround. If patients have a risk aversity, some of these drugs can produce immunosuppression. Those are the types of things you have to worry about. If they're traveling, you might want them to get their vaccinations first if they're worried about how efficacious the vaccine will be. Do you monitor anything? The products are not really written to say you should monitor, but I know we monitor. I look for a B-cell response. And I've seen in several circumstances where the patients are coming in for their infusions, I do a B-cell count, I do a CD19 count, and they haven't gone down. And I've seen a few people, though, I've looked at the 3-month mark and the 4-month or the 6-month, and if I'm not seeing B-cell suppression, maybe they've already got an antibody to the antibody, and you're just not getting the efficacy that you're looking for. But you should get with most of these drugs, unmeasurable CD19, like less than 0.1 when you do a flow, because they should be completely absent from at least the vascular tree. What's happening in the organs you can't measure, but when you do your flow cytometry on the blood, you're looking at that very small proportion of circulating B cells as an indication of what may be going on in the tissues. So I measure that. I measure IgG, because you can get it, and you can just see whether or not these patients are at high risk. And we won't talk about reimbursement, because that's really different. We've talked about escalation versus induction. The elephant in the room is always the safety. If everything was safe, we wouldn't be having this whole discussion about induction escalation. Everybody would just use the high efficacy therapy to begin with. And I don't have to get into why you treat early, although I sort of put this lecture together as if it was a standalone, but you've heard enough about this all day. I think that if you can get an effective therapy in earlier, you're protecting that reserve, you're getting at the disease very early, you're protecting the patient not necessarily for today, but how they're going to do 10, 20 years from now. And strategies have evolved, right? So going back, I don't want to go back too far because I don't want to tell you how old I am, but we had nothing when I started. When we looked at the first drugs like interferon and GA, we went, okay, patients only had a couple of attacks, so what, 2, 3 attacks. Our tolerance for the disease was very different because we didn't know what we know today 20, 30 years ago. So now the tolerance is really, really low for any form of disease activity. But you really got to balance that with how much better you're going to do with the next drug. Because if you keep, oh, well, I'm going to treat this, and if I see one lesion, I'm going to change, your patient's going to lose faith in you if you've changed products on them 6 times in 1 year because of 1 or 2 enhancing lesions or a numb hand. So you really have to have that strategy of what level of disease activity is actually a bad one. A lot of people recommend this high efficacy therapy to start because that way you don't have to think. You don't know who has mild disease, so let's just hit everybody hard. Nothing wrong with that concept. Clyde's been using it for years, right, Clyde? That's your concept. I mean, you may be over-treating a few people, but you're certainly not going to under-treat anyone. I completely get that. We're not just looking at EDSS anymore. There's a real elegant way of looking at it now. We're talking about this progression that is always there, that's surfacing now. We can measure it as the so-called progression independent of relapse activity. We don't have anything that really addresses progressive pathology, but you heard from Jeff earlier that we're on the horizon of perhaps being able to figure things out. And at least for the inflammatory form of disease, we have a serum biomarker like neurofilament light chain, which is an adjunct then to your clinical and your MRI measures of disease activity. I don't know who I would recommend HET for to start. There are patients who are very mild disease and risk averse who there's still a role for some of the other drugs. But certainly if there's any indication that the disease is becoming more active, I would not hesitate to go through that escalation. We talked about the monitoring scheme. This is the Canadian monitoring scheme that I showed you in more detail earlier. So I'm going to conclude by saying these B-cell therapies have proven themselves as highly effective. You're seeing numbers like 90%. For the most part, they're very well tolerated. There are very few limitations, although we're still early. Some of these drugs have only been around for less than a decade. We have long-term safety data from the trials. We need long-term safety data in the real world because the trials don't often reveal everything. Keep in mind, when you're putting patients into clinical trials, you truly are cherry picking. These are the perfect patient who goes into a clinical trial. When the drug comes out into the market, you're not so much cherry picking. You're giving it to everyone, and things emerge where you hadn't seen them before. So those are the things that we have to continue to collect. And patients now have an option, right? If they don't want to come for IV infusions, there's at least now a sub-Q version of a B-cell therapy. And with that, I will stop and take any questions that you might have, okay?
Okay, we have time for a few questions. Mark, did you mention colitis?
No.
Have you seen it?
No.
So we've seen it. We're putting together the cases of a B-cell depleting colitis and working with our GI folks.
And that didn't come out of the clinical trials?
Did not come out in the clinical trials. The other thing I might mention, because we looked at the COVID-19 responses, the antibody responses were quite poor, but there was a very robust T-cell response when you did that. So there's a question here for you. This is an interesting one. So how long do you think patients should receive anti-CD20 before stopping it? He knows no data, but do you have a recommendation?
Well, there is some data, and hopefully we'll get the results from the randomized study. But based on what the Swedes have been doing, they've been treating, initially they treated for 4 years, then they're treating for 2 years with actually lower doses of rituximab, and they monitor for the return of the memory B cell subset, and then they can decide whether they want to retreat or not. And they've been maintaining people like that for a long time. We have data that's been published for the people who took a hiatus, we'll say, during the COVID era. And so the paper was entitled, I think, what was it, interval dosing, like the same sort of study with natalizumab, but extreme interval dosing. And the interval dosing was up to 2 years in those patients, and they looked at whether or not they had a return of disease activity through relapse or MRI, and there were very, very few differences from the patients who voluntarily stopped taking their ocrelizumab infusions versus those that stayed on them. So that's sort of an indication that maybe a couple of years may be enough to control the disease for a few years henceforth, but really we need the properly controlled study to get an answer to that.
Okay, and do you have an opinion as to the mechanism for neutropenia?
Oh, yeah, I've seen that on several occasions. So when they tell you not to monitor for patients on the B-cell therapies, occasionally you see this neutropenia, and you're going, neutropenia, why? Neutrophils don't have CD20 on it. There may be some influence of the B-cell therapy, at least in the stem cell department, and that's kind of where one possibility, I don't have a good explanation for it. Ben, do you have an answer for why you get it? No, nobody really knows, but it's a phenomenon that you see, and you have to stop the drug, because otherwise the neutropenia continues, but if you stop the drug, it returns.
Actually, we have a little experience. Aaron has some experience with this.
You didn't.
Rheumatologists have recognized this for years with rituximab, and the general recommendation is to resume the anti-B cell therapy. I think this is much more common than we see. The most recent patient that I had was in mid-cycle of her ocrelizumab treatment, and her primary care physician, for I don't know what reason, she wasn't sick, did a CBC, and she had 0 neutrophils. And she wasn't treated, and within 2 weeks, the neutrophils are back to normal. So we don't commonly measure CBCs in the middle of a cycle unless there's a clinical reason. So I have a hunch it happens more often than we know.
Yeah, the first patient I ever saw it in was with rituximab in an NMO patient. And they just had periodic blood work, but I watched the neutrophil count drop with every single test. And finally, it went down to 0.5, and I asked the hematologist what's going on. He says, I don't know, but why don't you stop the drug? We stopped the drug, and we had, fortunately, an alternative to give that patient, and the neutrophils returned. So do you have to? I don't know. Your experience was it came back up, but if it goes down and stays down, I think most people are a little bit afraid of leaving someone neutropenic.
And here's related to what you were talking about and some of the early things, and I think we'll both answer this. So regarding lower relapse rates than expected in the studies discussed, do you think that could be due to patients now having more information about the importance of lifestyle modification and perhaps following better diets, exercising, et cetera, than they did in prior studies? And that's an interesting thought, that maybe it is. I think that the relapse rate in studies started going down before we were paying attention to, this goes back 20 years now, before we were paying attention to lifestyle issues, but certainly is one. But I think, from my point of view, it highlights the idea that every study is a universe unto itself, never to be compared to any other study. There isn't a single metric that you can look across studies with confidence and say relapse rate, PIRA, NIDA, none of them, because the selection criteria is always a little different. And I think that's probably what's happening now in terms of the selection criteria patients are getting in. The type of patients we're seeing, even now compared to 15 years ago, are still earlier, probably less severe if you look at the baseline data and such. But you have a thought on that?
Well, I think the most obvious thing is the diagnostic criteria have changed. And if you look at the original studies where we used poser criteria, you needed 2 attacks to even be called MS. And maybe in 24, you won't even need an attack to be called MS. So our population is going to be very different in the next study that's going to be done.
Okay, Mark, thank you very much.
Wonderful.
All right, so we're getting ready to wrap up. If I didn't get to your question, I apologize. I'm sorry. Pay attention to this. So to get your credit, please do that. Please, please complete the evaluation, because we're going to do this again next year, and we pay very close attention to what you thought was good, what you thought could be improved upon. So we very much appreciate your giving us your honest opinion. If I can complete it, for the ACTRIMS Resident Summit, there's a reception at 6:30 at the El Camino, right, Ben? Okay, so that's not too far from here. Are you guys doing something productive?
It's right across the street.
It's across the street. It's, let me just tell you, it's on Rosemary. It's 700 South Rosemary Avenue, Suite 232 for the residents.
Okay, that's good. So thank you all for your questions, your attendance, getting through the day here. I know it was rather intense. Many thanks to this outstanding faculty who performed, as I promised you at the beginning, exceptionally well. Thanks to Bristol Myers Squibb, EMD Serono, Myline, Viatris, Sandoz, Sanofi, and TG Therapeutics for their support, because if they didn't have the support for us to do the CME program, we wouldn't do it. And many thanks to academic CME. Dr. Hayes is wandering around here. So there he is over there. And Patrick is around somewhere as well. And oh, there you are. Okay. The ladies had to leave, but for all the outstanding arrangements. Hope to see you all again next year. Thank you very much.